Good morning, Sabah al Khair. I am very happy to welcome you this Saturday morning to the sixth edition of ESMO Together. As you know, this edition of ESMO Together, as all previous one, have been prepared by the faculty members of the Department of Hematology Oncology at St. Joseph University in Beirut. It is a selection of the highlights of the latest ESMO Congress, which has been presented in Berlin this year, 10 days ago, and the selection of the abstracts which are presented are only the responsibility of the members of our faculty. Each member have selected some of the abstract that he, at his personal level, thought they are representative, or for him were representative of what's going on as a news or practice changing or anything. We do not have any pretension of giving the best of ESMO. We are only having the pretension of giving you a flavor of what seems to us was something very nice to our patients and maybe practice changing to our patients. I would like to officially thank at the beginning of our meeting for today. It will last until 5 or 6 p.m. this afternoon. I would like to officially thank Professor Sami Al-Khatib, the president of AMAC, who has been continuously supporting our continuous medical education through the years and supporting all medical oncologists and specifically young medical oncologists in our region. I want also to thank Professor Joseph Cattan, the current and actual chairman of the Hematology Oncology Department at Hôtel Dieu de France University Hospital in Beirut and at the Faculty of Medicine at St. Joseph University, for being my friend and for having showed a continuous support during all these years for this activity. I would also like to support also my friend Professor Fadi Farhat, who is the chairman and the president of the Cancer Research Group. I would like to thank him for his friendship all the years and his collaboration in making so many trials all together, and also for supporting this activity. I would like to thank, last but not least, Professor Hamdi Abdel Azim, the chairman and the president of the ABSI, Africa Middle East Cancer Intergroup, who also have been a friend and would also have been supporting this activity during all this the fifth edition of this activity, and today we are presenting the sixth edition. Also, I would like to thank the Lebanese Society of Medical Oncology for giving their support for this activity. And at last, also, I would like to thank my faculty at my university, the Faculty of Medicine of St. Joseph University, who have been supporting us all these years. So thank you again for being with us, and welcome to this edition 6 of ESMO Together. Thank you and welcome.
Good morning, esteemed guests, distinguished speakers, and honored participants. On behalf of the Arab Medical Association Against Cancer, I would like to thank Professor Marwan Ghosn, and it gives me immense pleasure to extend a warm welcome to each and every one of you in the 6th ESMO Together 2025. In partnership with the Arab Medical Association Against Cancer, AMAC, the Lebanese Society of Medical Oncology, the University Hospital of St. Joseph, the Cancer Research Group, and the Africa Middle East Cancer Intergroup, we have embarked on a journey of knowledge sharing and collaboration in the fight against cancer. Throughout this activity, we aim not only to disseminate the most up-to-date information, but also to faster dialogue, collaboration, and innovation. It's not just about what we know, but how to apply that knowledge to make a tangible difference in the lives of those affected by cancer. Once again, I extend my warm welcome to each of you, and I am confident that your collaborative efforts will yield impactful outcomes in the fight against cancer. Thank you, Prof. Marwan Ghosn, for your dedication and continuous commitment to this important cause. Thank you.
Hi, thank you and congratulations, Dr. Ghosn, for this ESMO Together number 6. We will be presenting in this session the interesting and breakthrough data from the ESMO 2025. I am Fadi Farhat. I'm the president of the Cancer Research Group Collaborative Group, and I invite you all to follow all the data for a very interesting meeting. Thank you.
As the head of the Hematology Oncology Department at the Faculty of Medicine, St. Joseph University of Beirut, I'm honored to welcome all of you from Lebanon, from the Arab countries, and abroad to discuss together the latest news from ESMO 2025 Congress. ESMO Together in its sixth edition will bring to you all the oncology advances as presented 10 days ago at Berlin. Thank you, Dr. Marwan Ghosn, for creating this great event and for giving us the opportunity to be part of the future of oncology. Thank you all for being with us virtually, and hope all the success for the 6th ESMO Together. Thank you.
And the 6th ESMO Together, organized by my friend Marwan Ghosn. Congratulations, Marwan, for doing this for 6 years in a row. And of course, I wish to thank the organizers, the InfoMed group, Karine, Mira, and Nancy, for the help to prepare my presentation to you. I'm here as well as a member of the AMSI, Africa Middle East Cancer Intergroup, which is starting from the next year. It will provide its educational platform for everybody in the field of oncology. Having said so, my task is to discuss with you the most striking advances in breast cancer from the last ESMO 2024 to this ESMO 2025. That's to say, a year in review. I wish to remind you that we have other presentations in the meeting tackling what really happened during the last ESMO. Dr. Fadi Farhat, Dr. Adel Tabashi, and Dr. Philippe Aftimos. they will cover more details of what happened during this ESMO 2025. So that's my disclosure. I will try to cover certain key studies for the different subtypes of breast cancer. We'll start with ER positive, HER2 negative, the INAVO study in patients with the PI3 kinase mutation, metastatic breast cancer. As you know, PI3 kinase mutation is very tricky in early breast cancer. It has a good prognosis, while in metastatic breast cancer, it has a poor prognosis. We have several reasons for this biological behavior. But anyway, we know that endocrine resistance and poor prognosis of this biomarker will evolve during the metastatic phase. Trying to do targeting of PI3 kinase mutation, we have the SOLAR study, which was published several years ago, utilizing alpelisib plus fulvestrant versus fulvestrant alone. We have a cohort with PI3 kinase non-mutant, and it was a failure. It didn't work. Alpelisib didn't work in this population. And as expected, it worked in the patient population with PI3 kinase mutation, an impressive improvement in progression-free survival. The response rate, as you can see, was not very gratifying, only 26% versus 12% for fulvestrant alone, and there was no improvement in overall survival. Because of the severity of the side effects and the very high rate of discontinuation because of side effects, actually, the real interest of alpelisib was in failures after PI3 kinase exposure. And we have the BILIVE study that reported first alpelisib plus fulvestrant after prior exposure to CDK4/6 inhibitor and aromatase inhibitors. That what we see, not very impressive, as you can see, progression-free survival was 7 month overall response rate was only 17%. Anyway, we knew more than a decade ago that actually CDK4/6 inhibitors are needed to have a better outcome for PI3 kinase mutation. The problem was actually is that the available PI3 kinase inhibitors were extremely toxic to combine with the CDK4/6 inhibitor. Till we have the discovery of inavolisib, which is a highly selective inhibitor and degrader of the mutant PI3 kinase isoform. And in preclinical models, it showed a much superior outcome compared to alpelisib. So that's why, with the reason of being much less toxic compared to alpelisib, it was possible to try this combination, the triplet combination, inavo plus palbociclib plus fulvestrant versus palbociclib fulvestrant in patients with endocrine resistance as first line, remember, first line with endocrine resistance in patients with PI3 kinase mutation. The outcome was enormously well, as you can see, at 2 years, the triplet combination provided more than 25% improvement in progression-free survival compared to palbociclib and fulvestrant alone. And again, we have seen during the last ASCO that there was a significant improvement as well in overall survival. And what was very striking is the extremely high overall response rate that you can see of the triplet. It was more than 60%. So it was the duration of response. For that reason, the drug, the triplet, was approved around 1 year ago. And the toxicity profile was pretty acceptable for the triplet combination. During the last ESMO, we have seen the Victoria study, which was providing a brand new drug, which is gadotolisib, which is a pan-PI3 kinase and mTOR inhibitor. When you see this, actually, you expect problems in side effects, which we did not really see in the study. It was directed for PI3 kinase non-mutant, the wild type, which are the majority. And again, we have a triplet of GADA plus palbociclib plus fulvestrant versus GADA fulvestrant versus fulvestrant alone. The primary endpoint was the outcome of each of the combination, the triplet of the duplet versus fulvestrant alone. We have seen a very impressive progression-free survival for the triplet and also for the duplet. Whether the duplet or the triplet will gain more fame, we'll see that in the future. But these data are extremely promising for after failure of CDK4/6 inhibitor. Now, remember, all the patients in this study received and failed prior CDK4/6 inhibitor. In the adjuvant setting, the Monarch E, a very famous study, showed very impressive improvement in invasive disease-free survival when we added abemaciclib to the standard endocrine therapy in patients with high-risk disease, not positive disease always. It was important to see for the first time that this kind of approach, the adjuvant use of alpelisib, of abemaciclib could result in improvement in overall survival as well. You can see that separation of the Kaplan-Meier is not yet very impressive, but it was statistically significant. And we know this will deepen up, the difference will be more seen with subsequent follow-up. For patients with triple-negative breast cancer, we know before the last San Antonio 2024 that we have 3 randomized studies for the use of immune checkpoint inhibitors in the neoadjuvant setting in triple-negative breast cancer. The famous Keynote 522 and 2 studies utilizing atezolizumab, the Impassion 031 and the NuTripa. From the first, site, you can see that we have one big failure in the NuTripa for PCR rate, while the 2 other studies, the Keynote and the Impassion, were impressively improving the PCR rate in triple-negative breast cancer. Unfortunately, the Impassion didn't make it for the improvement in event-free survival. The NuTripa, again, a completely negative trial, and the winner, as we know, was the Keynote 522. During the last San Antonio, we have seen the Jupardus trial, which has exactly the same design like the Keynote 522. With the exception is that we are using atezo instead of pembro as an immune checkpoint inhibitor to test. Once again, another negative study for atezo. There was no improvement in event-free survival, and there was no improvement in overall survival, which was provided by the Keynote. The question was raised during the last ESMO, actually. Our colleagues from India, they posed a very attractive study design using a very low dose of pembrolizumab in the neoadjuvant setting in a phase 3 study, small size, as you can see, around 155 patients, administering pembrolizumab at a very modest dose. It is 3 cycles, each of 50 milligrams, total dose once every 6 weeks. So this means they are providing less than 15% than the regular dose of pembrolizumab in the Keynote study. And we have seen this very impressive improvement in PCR rate, almost the same identical benefit, 13% improvement in the PCR rate. Mind you, they included more locally advanced disease, and in all the subgroups, there was a very significant improvement in PCR rate in favor of this very short and low dose pembrolizumab course in the neoadjuvant setting. Whether this will survive or be proven in a bigger study or not, but I think it can provide a good option where the drug is not really accessible for the patients. In the metastatic setting of triple-negative breast cancer, we have known during the last few years that the Keynote 355 could show that first-line Pembro plus chemo has provided the best efficacy outcome in patients with PD-L1 positive, that's to say CPS 10 or more, improvement in progression-free survival, overall survival, and overall response rate. And this is actually the standard of treatment now for patients with PD-L1 positive disease. If you see the subgroup analysis for overall survival, you'll see that those patients who relapsed early, less than 1 year from the end of adjuvant or neoadjuvant treatment, they had no benefit at all from the addition of pembrolizumab. And these patients actually, they present a very difficult to treat population. We have seen during the last ASCO, the ASCEND-04, which included similar patient population, or they are PD-L1 positive, and they included patients who relapsed early, 6 months or more. They were randomized to receive chemo plus pembro versus sacituzumab, the ADC, you know, plus pembro again. There was they allowed the crossover for patients who failed chemo to receive second-line sacituzumab. But let's see first the primary endpoint was positive in favor of the new combination sacituzumab plus pembro, improving the 1 year progression-free survival by 15% with a very good hazard ratio 0.65. You can see this regimen did not really improve the overall response rate versus chemo pembro, but it really provided a significantly longer duration of response. There was no improvement in overall survival, mind you, because crossover was allowed. 81% of patients in the chemo pembro arm, they were crossed over to second-line sacituzumab. So in the subgroup analysis, I was really happy to see that we have something good for patients who relapse early, between 6 to 12 months from the end of neoadjuvant treatment. This was in favor of the sacituzumab combination. For patients with de novo recurrence more than 1 year, again, the new combination was better. But for patients with de novo triple-negative breast cancer, there was no improvement in favor of sacituzumab. So the question is, having reviewed the side effects of there was more serious treatment-related adverse events with grade 5 events in the sacituzumab arm because of infection, actually. Would you reuse this combination in the first-line setting for all patients with PD-L1 10 or more, or you'd better wait to give it as a second-line treatment, since we are not able to improve overall survival if you provide this as a second-line treatment? I would personally put my money on this group. In patients who recur early, certainly I will provide this combination to my patients. Anyway, for those patients whose PD-L1 negative, which are the majority, we have the ASCEND-03 that in a head-to-head comparison, they compared sacituzumab versus the physician choice of any Taxol or nab-paclitaxel or gem-carbo, the classical chemo we use actually in PD-L1 negative. And there was improvement in progression-free survival in favor of sacituzumab. This is a good news. Now a new standard of care. But before you decide, you have to see that there was no improvement as yet in overall survival. And once again, with this drug, we have some problems in treatment-related mortality due to infection. And actually, during the same ESMO this year, there was, in addition to ASCEND 3, we have another study for the same population using another ADC, which is Dato-DXd, again, another anti-TROP2, using DXd as the payload. They have similar, as you can see, a number of patients, almost more or less similar progression-free survival benefit, but there was a straight difference, which is the improvement in overall survival, which was seen in the TROPION-Breast02 by the Dato. Again, overall response rate was dramatically increased with the Dato treatment, which was not seen with the ASCEND treatment, but the duration of response was equally good in both. Lastly, the grade 3 and 4 toxicity and treatment-related mortality were more seen in the ASCEND study using cetuximab. The toxicity profile is a bit different, and my own bias actually will probably go to the Dato-DXd for the improvement on overall response rate and for the improvement of the overall survival. But of course, you have to weigh the toxicity profile according to each patient's, because actually we know that the ADCs, they have a lot of toxicity profile actually when used. The Chinese, they are providing another anti-TROP2 antibody drug conjugate, the cetuximab TMT, which has a different linker and a different payload, always topo-1 inhibitor, and they have shown in the ASCO last year that when this drug, the cetuximab TMT, was compared against chemotherapy as a third line or beyond, it was a great success actually. And this drug, unfortunately, is only approved in China till now. But I think the 3 ADCs in triple-negative breast cancer, the metastatic phase, will be better utilized if we use them in the early phase as the post-neoadjuvant treatment for patients with residual disease. We have the ASCEND-05 using cetuximab plus Pembro versus Pembro plus CAPE. We have the TROPION-03 Dato plus Durva versus pembrolizumab plus capecitabine, and for the Chinese comer, we have Pembro plus cetuximab TMT versus Pembro plus capecitabine. Moving to the last part, which I call the trastuzumab DXd to tsunami actually, because actually this drug is providing great data during the last few years. But for the early phase HER2 positive breast cancer, we know that neoadjuvant therapy has evolved as the main treatment approach for patients, at least with stage 2 and 3. This can provide less mastectomy and less axillary dissection. That's for the sake of quality of life, but more importantly, the neoadjuvant therapy can serve for identification of biologically high-risk disease, which are those with no PCR, and to induce the PCR, actually, the utilization of taxane, carboplatin plus trastuzumab, pertuzumab has evolved as the combination of choice in the neoadjuvant setting, and we have seen this in the Trifenia study. We have 2 arms of anthracycline based versus this combination, the TCHP. The PCR rate was the same, and there was much less cardiac toxicity. And at a later scale thereafter, we have seen the TRAIN2 study, the Dutch group doing the same exercise, but this time for a longer duration, 8 to 9 cycles of one anthracycline based and the other not anthracycline based. Once again, There was no difference at all in the PCR rate, whether in the ER positive or ER negative, with similar event-free survival and much less cardiac toxicity. And during the last ESMO, we have seen the famous trial, the induction treatment in the neoadjuvant setting, utilizing 3 arms, trastuzumab DXd times 8 cycles versus trastuzumab DXd 4 cycles. This to be followed by paclitaxel, trastuzumab, and pertuzumab, or a third arm, which is AC dose dense, followed by once again paclitaxel and the HP combination. The study first announced last year that trastuzumab DXd arm should be stopped because it it provided inferior PCR rate with the comparator, which is the AC paclitaxel HP. Then during the last ESMO, we have seen the new combination, the DXd plus pertuzumab arm. It provided here, I'm sorry, the DXd plus paclitaxel, trastuzumab, pertuzumab provided a higher PCR rate, significantly higher, especially for those with the ER negative disease. And the toxicity profile was more or less similar, if not a little bit better than the dose dense AC with trastuzumab, pertuzumab, paclitaxel. We learned from this study that 8 cycles of trastuzumab DXd is not suitable, and we learned again that the sequential use of trastuzumab DXd followed by paclitaxel TP is probably a new standard of care. But before you decide this, this was for the PCR rate, it increased. But we know that for the no PCR rate, since a long time now, that the Catherine study could show that the trastuzumab TDM1 is the standard of care actually in patients with residual disease after induction chemotherapy with Herceptin or Herceptin plus pertuzumab. It improved the event-free survival as well as overall survival, and it was actually a practice-changing study. In this particular study, actually, although everything went in favor of TDM1, actually, there was a little bit of a higher CNS metastasis in this population. So the question is important: who is still at a high risk of relapse after TDM1 treatment as post-neoadjuvant treatment? We have seen during the last ASCO, the last San Antonio, that patients with ER negative still they have poor prognosis in spite of TDM1 treatment, and so is patients with node positive, especially N2 and N3, and so for locally advanced disease. So for this purpose, the Destiny study was actually designed to check in patients with high risk population after induction neoadjuvant treatment with residual disease, whether TDM1, which is the standard, can beat trastuzumab DXd, and the answer was no. Trastuzumab DXd was superior as expected, actually. And in patients with CNS recurrence, the TDM1 once again showed a little bit of a higher CNS recurrence and overall recurrence. Importantly, and you have to pay attention for that, toxicity as expected was more seen for trastuzumab DXd. So the question is when to use trastuzumab DXd actually in the early stage HER2 positive. Is it during the neoadjuvant setting, the induction phase, or you prefer to wait and give it during the post-neoadjuvant setting if your patient does not achieve PCR? In my own bias, actually, is that I will keep it uh, for the post-neoadjuvant. That is the subgroup analysis in the neoadjuvant setting, the Destiny 11. Um, for the induction, you can see I will use it only here for patients with HER2 um, positive by being immunohistochemistry +2 with each positive, because you can see in this population actually the standard treatment uh, actually the PCR rate is very modest, only 16%. It is as well low. This population, we know by now, immunohistochemistry +2 with each positive, they respond quite poorly. For this particular patients, I will put my money on trastuzumab DXd combination actually. So the final conclusions of my presentation is that antibody drug conjugates are coming to stay for long, most likely for good in the management of breast cancer patients. Importantly, moving antibody drug conjugate into the earlier setting will present new challenges, the top of which is the toxicity profile. Of course, toxicity profile is always important, but it is extremely important, more important in patients with the curative phases of the disease, the neoadjuvant or adjuvant setting, where actually you have good standard of care. So the presence of fatal toxicities should be taken care of. We have to work, especially for a drug like trastuzumab DXd and the associated interstitial lung disease. Anyway, early stage treatment again may pose more difficulties in the treatment of these patients whenever they relapse in the future. Identification of predictive biomarkers that may allow better tailoring of antibody drug conjugate therapy and minimize overtreatment is critical. But we have, in my opinion, one biomarker is ready for a prime time, which is HER2 +2 positivity with each positive. You know, these patients, we consider them as HER2 positive, but we know they do not respond well at all in all the studies to the classical TP, trastuzumab, pertuzumab chemotherapy. So here, this is an area where trastuzumab DXd regimen is really needed. We have a new wave of quantitative assays under development, but we don't have anything at the present time to be used in the clinic. Having said so, I come to the end of my presentation and thank you so much for your attention.
Hi, everybody. Thank you, Professor Ghusn and the organizer for the 6 ESMO Together session, for giving us the opportunity to present 2 abstracts from the ESMO 2025. It's about Vera and Victoria 1 trials. These data are really impressive and interesting. What's the rationale behind the selection of these drugs for trials? We know very well that the PI3K ACT-mTOR pathway drives breast cancer growth and contributes to endocrine and CDK4/6 inhibitors resistance. We also know that the most available therapy are only for PI3K mutated. So there is a need for effective therapy for PI3K wild type. And we know that the third option are expanding really, and we know that they are used plus with or without companion therapy, target therapy, or with and without somatic mutation post CDK4/6 inhibitors. So for the Evera trial, what was the rationale specifically? Again, limited effective treatment post CDK4/6 inhibitors. The efficacy of everolimus plus ET, as we know from the Bolero trial, which is established as a standard of care treatment option post CDK4/6 inhibitors in case of no ESR1 mutation, and the importance of giredestrant, which is a next generation oral SERD. It's important to mention that it's a full ER antagonist and degrader, and it's more potent than the other SERDs in cellular viability assays. So the combination of everolimus with giredestrant was important because it will target two signaling pathways, which are the ER and PI3K mTOR inhibitors. Sorry, the two pathways, the ER PI3K ACT mTOR pathways, which both are associated with the resistance to the therapy with endocrine treatment. So the EVERA trial study design, it's a global randomized open label phase 3 trial. Patients were included if they have two or less prior therapy with endocrine therapy in the metastatic setting. They should have a previous CDK4/6 inhibitors treatment, and the chemotherapy was not allowed. And for sure, we should get measurable diseases in order to evaluate. The treatment was evaluated and stratified plus minus fulvestrant, and also for the measurable diseases per RECIST criteria. The treatment was randomized. The patients were randomized in 1-to-1 to receive either giredestrant or plus everolimus or standard of care endocrine therapy plus everolimus. The treatment should be continued until progression of the disease or toxicity. Primary endpoint were PFS in ITT population and ESR1 mutated patient, and the key secondary endpoint were OS and ORR plus disease plus duration of response. When it comes to the co-primary endpoint, the PFS in the SR1 population showed a significant a higher PFS, as you can see, 10 months almost, compared to 5.45 for the standard of care, which translates in a 62% reduction of progression or death. And for the intent to treat population, we see that also the benefit was there, with a 44% reduction of progression or death, and we can see that giredestrant showed 8.8 month PFS compared to 5.6 months to the standard of care. So it was really impressive. The overall survival results are still immature. We see that there is a trend in favor of the giredestrant in ITT and in ESR1 population, but it's still immature. What about toxicity? We see that for such drugs and such patients, we know very well that there will be as I said, what about the toxicity? It's an important issue always in the oncology treatment. The most common the most common all grades treatment adverse event were stomatitis, diarrhea, and anemia, and it was in both arms, since both arms included PAM inhibitors. Also, we had grade 1-2 bradycardia in the giredestrant arm, 4% approximately, while it was 0.5 only in the standard of care. There was no case of photopsia, and remember that the assessment of toxicity is usually influenced by the longer median treatment duration in the explored arm, here the giredestrant. So overall, the toxicity experience was fairly balanced between these two arms and reflected the safety profile of these agents. What about the take-home message from the authors? The authors concluded that the next generation oral SERD, giredestrant, in combination with everolimus, showed statistically significant and clinically meaningful improvement in the PFS versus standard of care, which is endocrine therapy plus everolimus in the luminal metastatic breast cancer after progression on CDK4/6 inhibitors. The ESR1 mutated patients could benefit from a 62% reduction in progression or death, and the whole population benefited in 44% of cases in reduction of risk of progression of death. It's important to mention that across all subgroups there was a beneficial gain from giredestrant. Also, the response rate and duration of response benefits were seen irrespective of the ESR1 mutated status. Now, we have to mention that overall survival is always an important endpoint, and we are still waiting the data because it's immature. Finally, the safety profile was well accepted. I will move now to the second trial, which is a Victoria-1 trial. And Victoria-1 trial is a trial including the novel SERD, the gedatolisib plus fulvestrant, with or without palbociclib versus fulvestrant. And this was in PI3K3 wild type breast cancer. We will mention today, we will present today the data of the wild type PI3K patients. So indeed, these are two studies. Victoria-1 included two studies. The first one including the PI3K, the PIK3CA wild type patient. The second one, PIK3CA mutated patient. Today we'll talk about the study 1. So the PIK3CA wild type patient. Patients were included if they had for sure hormone receptor HER2, hormone receptor positive HER2 negative advanced breast cancer. They could be pre and postmenopausal. They have to be absolutely in progression after CDK4/6 inhibitor plus aromatase inhibitor, less than 2 line, less or equal to 2 line of prior endocrine therapy for metastatic disease, measurable disease, and PI3K status, PIK3CA status should be known. No diabetes type 1, diabetes type 2 accepted if the hemoglobin A1C was less than 6.4. No prior mTOR, PIK3CA or ACT inhibitors, and no prior chemotherapy. This trial didn't accept any chemotherapy in metastatic setting, and the stratification was concerning the liver and lung metastasis, the time to progression on the prior therapy less or more than 6 months, and the region. The study has 3 arms: the gedatolisib plus palbo plus fulvestrant, the gedatolisib plus fulvestrant, or the fulvestrant alone. We do not use, or we rarely use, the fulvestrant alone, but apparently in this trial it was requested by the FDA to use this arm. And the primary endpoint was the PFS, comparing the arm A, the triple therapy with the monotherapy, and arm B, the double therapy, plus the monotherapy. So PFS, primary endpoint, OS, response, safety, and the quality of life as secondary endpoint. For the characteristic, the patients were well balanced concerning demographics. I mean by that the age, the sex, the menopausal status, race, region, the PS. So it was well balanced between the 3 arms, and also well balanced when it comes to the disease characteristic. So we see that it was well balanced for the liver and lung metastasis. And look here, high number of metastasis, 80%, almost on the three arm. So for the neoadjuvant therapy and for the prior lines, and mainly 80%, 86 to 87% had received at least received one line of prior endocrine therapy in metastatic setting. Remember, no chemotherapy. And also, these patients received the palbo in 40% almost, and the ribo in 45%, and abemaciclib less than 20%. This again will show the shift in the CDK used to ribociclib. It's not our subject today. And when it comes to the outcome, the first co-primary endpoint was the PFS, and we can see that the PFS was largely in favor of the triplet therapy compared to the monotherapy, 9.3 versus 2, with a significant hazard ratio 0.24. It's impressive, yes, we know, but remember that the arm, the blue one, fulvestrant, is monotherapy. When it if we look to the primary endpoint, the co-primary endpoint, which is the comparison of the arm B and C, the doublet to the monotherapy, there is still a significant improvement from 2 the monotherapy to 7.4 months with the doublet therapy, with a hazard ratio 0.33. Impressive, impressive. Overall survival results are immature. We will not mention it now. And the safety profile, as usual, is important in such drugs. We see that in the arm of triple therapy and double therapy, we have a high number of stomatitis. The grade 3 stomatitis, 19% in the triple therapy and 16% in the double therapy, and 0 in the control arm. Remember, in this trial, the steroid mouthwash was not obligatory. It was not mandatory. We can see that there is also grade 3, 4 neutropenia more in the triplet arm, but there was a low number of discontinuation on all arms, and there was no death related in all these arms. So even if there is a neutropenia, it's manageable as we can see. So some hyperglycemia also, but grade 3, 4 less than 5%. So the authors here concluded that Victoria 1 trial demonstrated a statistically and clinically significant improvement in PFS with the PI3K ACT mTOR inhibition in patient with wild type PI3KCA. We do not have the results of the mutated study. As you can see, the PFS for the triplet therapy 9.3, doublet 7.4, compared to almost 2 months for the monotherapy. The efficacy was comparable, whatever you will use as CDK, palbo, ribo, or abema. And the adverse event mentioned here were hyperglycemia and diarrhea, and also the mucositis, and the discontinuation 2.3 and 3.1 in the doublet, which is not really important. So these results validated the pathway, the PAM pathway, as a molecular driver in the PI3K or PIK3CA wild type disease. And now, what's the take-home message from the ESMO 2025 for these two presentations? First of all, these are the first randomized trials clearly pushing PFS beyond the usual 6 months. As you can see, we have a lot of trials from the Emerald, Serena, Amber, etc. But really, with Victoria trial and Evera, we are exceeding in very nice way the 6 months. And also it's important because it showed that independently of the ESR1 mutation, we can give the treatment, and independently of the PI3K mutation also we can give the treatment. It's important to mention that now, even with PI3K, PIK3CA mutated diseases, we can get a benefit from the SERDs. The toxicity is manageable, and the OS data is still immature. So after this ESMO, there is no longer we should no more say that it's a maintenance. It's more precision resensitizers of the ER disease. And with that, I finish, and I thank you very much.
Hi, how are you? So today we'll be talking about an important abstract for metastatic advanced triple-negative breast cancer, datoderuxtecan in combination with durvalumab, a PD-L1 inhibitor, as first-line treatment for unresectable, locally advanced or metastatic triple-negative breast cancer. So this is the results from arms 7 and 8 of the phase 1b/2 Begonia study. So this is a phase 1b/2. So mainly the studies that are phase 1 test safety and limited efficacy of drugs. In this case, in triple-negative advanced breast cancer. The rationale for this study: PD-L1 inhibition and chemotherapy is standard of care for metastatic TNBC. However, outcomes remain poor. Most patients progress within 1 year, with a PFS around 10 months. Treatment options are limited, particularly for patients with low, less than 10% PD-L1 tumors. Dato-DXd is a TROP2-directed antibody drug conjugate. It's approved for the treatment of adults with unresectable or metastatic hormone receptor positive, HER2 negative breast cancer who have received prior endocrine therapy and chemo for unresectable or metastatic disease based on results from phase 3 TROPION-Breast01 study. Begonia is a phase 1b/2 multi-center, multi-arm, two-stage, two-part open-label platform study evaluating safety and efficacy of durvalumab plus other novel therapies as first-line treatment for advanced triple-negative breast cancer. So here we report updated data in patients regardless of PD-L1 status. So the arm 7 is regardless of PD-L1 status. Arm 8 is with PD-L1 high tumors per local testing. So there are two arms, one regardless of PD-L1 and the second one was PD-L1 high. The eligibility criteria were unresectable, locally advanced, metastatic, triple-negative, no prior treatment in the metastatic setting. If they have adjuvant or neoadjuvant, it should have been more than 12 months since any prior taxane therapy, no prior ADC or immune checkpoint inhibitors, and arm 8 was PD-L1 high tumors. So as you can see here, arm 7 was 62 patients, any PD-L1 expression. Those patients will receive dato-DXd every 3 weeks and durvalumab every 3 weeks. Arm 8 was PD-L1 high tumors. They received dato-DXd every 3 weeks with durvalumab every 3 weeks. Primary endpoint was safety and tolerability. Secondary endpoint were objective response rate, PFS, duration of response, and overall survival. So if you look here at the baseline demographic and characteristics, you can see that in arm 7 and arm 8, the patient that discontinued treatment, more than 50% was due to disease progression. So in both arms, the most common reason for treatment discontinuation was disease progression. Median duration of follow-up for arm 7 was 35 months. Median duration of follow-up for arm 8 is 10.7 months. So the arm 8 is not very mature yet. We'll have more results in the future. If you look at the demographics of the patient, they're very well balanced. Around 40% of patients did not receive prior treatment. Around 50% had received prior chemotherapy for early stage disease, including taxane, in 45% of patients, and around 60% of patients had visceral metastases at the start of the study. If you look here, this is arm 7 results, arm 7. So around when they tested PD-L1 retrospectively, around 11% of patients had PD-L1 high tumors and 87 were PD-L1 low. So most of the patient, around 90% were PD-L1 low. However, this being said, the confirmed objective response rate of arm 7 was 79%. This is a very high objective response rate. Complete response was around 13% and partial response around 66%. As we said, median duration of follow-up was 35 months, and responses were observed in patients with both PD-L1 high and PD-L1 low tumors. So regardless of PD-L1, we had response. You can see here the waterfall plot. Most patients had partial response. Median duration of response was 17.6 months, and median PFS was 14 months, which is very good for this triple negative aggressive type of breast cancer. This is the arm 8 overall response and duration of response in arm 8. With this, I'm reminding you, this were the PD-L1 high tumors. The median duration of follow-up was only 10.7 months. So this did affect the fact that we did not get a median duration of response and median PFS. Those were both immature given the short duration of median follow-up of 8.3 months. However, the confirmed overall response rate was 82%. So this is also a very high objective response rate at 82%. You can see the waterfall plot. Most patients had response. So this is very promising. If we look at the safety summary, around 20% of patients discontinued treatment in the arm 7 due to side effects, and around 10% in arm 8 due to side effects. But overall, it was very well tolerated. The immune-mediated side effects were around comparable between two arms, around 32%. But only 1% was a grade 3 and 4 immune-mediated side effect. Those are the most common TAE, more than 20% of patients in either arm. They are very comparable in both arms 7 and 8. And so stomatitis was the highest, around 75%. Nausea came in at second in 65% of patients. Alopecia, constipation, and fatigue and rash. Those were the most common side effects that were seen in both arms. Hypothyroidism came in around 20% of patients. So in conclusion, the combination of Dato-DXd and durvalumab demonstrated robust anti-tumor activity in patients with metastatic, advanced, triple-negative breast cancer with any PD-L1 expression in arm 7 and in those with high PD-L1 expression in arm 8. In arm 7, specifically, median duration of follow-up was 35 months. Confirmed overall response, objective response rate was 79%, consistent with response rate were observed regardless of PD-L1 status. So whether you were high or low, you had a consistent response rate. Median duration of response was 17.6 months. Median PFS was 14 months. In arm 8, which had the high PD-L1 expressors, median duration of follow-up was only 10.7 months. Confirmed objective response rate was 82%, comparable to arm 7. Median duration of response and median PFS were still immature given the short duration of median follow-up of 8.3 months in censored patients. So the safety profile of the combination of Dato-DXd and durvalumab was manageable with no new safety signals. Thank you.
Okay, so we're going to talk about the ASCENT trial. It's a randomized phase 3 study of sacituzumab govitecan versus chemotherapy in patients having triple-negative breast cancer, metastatic or locally advanced, and who are unable to receive PD-L1 inhibitors. 60% of patients with metastatic triple-negative breast cancer are not candidate for PD-L1 inhibitor therapy. 50% of the patients treated in first-line metastatic triple-negative breast cancer do not receive the second line, and the median progression-free survival of those patients is less than 6 months. And on the other hand, sacituzumab govitecan is already approved for the second-line treatment of triple-negative breast cancer and also for the second-line hormone receptor HER2-negative breast cancer. To note that it is a TROP2-directed ATC with multiple previous trials. So for the study designs, the inclusion criteria were patients with previously untreated, locally advanced, inoperable, or metastatic triple-negative breast cancers What we mean about not candidates for PD-L1 inhibitors is having a CPS less than 10, having a CPS more than 10, but have been previously treated with a PD-L1 inhibitor in curative settings, or ineligible for immunotherapy due to another comorbidity. Those patients have to have more than 6 months since treatment in curative settings. They were randomized 1-to-1 sacituzumab govitecan versus chemotherapy. It could be paclitaxel, nab-paclitaxel, or Gemzar carbo. The primary endpoint was PFS. And to note that after progression with chemotherapy, patients were allowed of a second-line treatment with sacituzumab govitecan. For the statistical analysis, they used a hierarchical test process, and by that we mean that in order to analyze the OS, we have to have a positive PFS before that, and in order to analyze the ORR, we have to have before that a positive PFS and a positive OS, and this is to reduce the type 1 error and the false positives of those variables, because having too much variables in a study, we can have by chance a positive result. For the two arms, we have evenly distributed populations for the sex, for the age, for the race, geographic region, ECOG, curative treatment-free interval, of course, the PD-L1 status also, and the metastatic sites also. And we have also the same regimens used in both arms for the chemotherapy. Here are the progression-free survival between the sacituzumab govitecan and the chemotherapy. We have 9.7 months for the ADC versus the chemotherapy 6.9 months, with a 6-month PFS of 65 versus 53, and 12-month PFS 41% versus 21% for the chemotherapy arm. All the subgroup analysis favored the use of sacituzumab govitecan versus chemotherapy, and we should note also that CPS less than 1 also favored the use of sacituzumab govitecan, and CPS between 1 and 10 also. For the tumor response, we have the same tumor response, mainly 48% for the ADC and 46% for the chemotherapy. But as you can see on the right, the duration of response is longer for the ADC. For the overall survival, the data is not yet mature. It should be noted that, as we already said, that the patients with chemotherapy that progressed can use sacituzumab govitecan, and the majority of these patients used the ADC. So as we can see, we have an advantage in PFS2 for the ADC over chemotherapy, and it could be analyzed that starting with the ADC can have some advantage over starting with chemotherapy and then switching to the ADC. For the safety of this drug, we didn't have a major trouble with this drug. We didn't have new toxicities that should be noted, and just 7 versus 1 for the treatment-related adverse effect leading to death. For the adverse event, it should be noted that it is an ADC. The sacituzumab govitecan is an ADC. It is a TROP2 directed, but it is linked to the SN38. The SN38 is a metabolite of the irinotecan. So we should expect a similar toxicity profile. As we can see here, we can see a lot of diarrhea with the ADC, a lot of alopecia, and also neutropenia and nausea. With this, I conclude that the ADC sacituzumab govitecan led to a statistically significant and clinically meaningful improvement in PFS versus chemo, 9.7 versus 6.9, and the PFS benefit was observed across key subgroups. The ORR was similar between treatment groups. However, duration of response was longer, as we mentioned. OS is still immature. To note that it could be diluted due to the crossover in the chemo arm, and the safety is consistent with its known profile. Use of prophylactic G-CSF is advised as appropriate to reduce neutropenia of the drug, and rates of discontinuation is low, and it's actually lower with sacituzumab govitecan versus chemotherapy. And with that, I finish my presentation. Thank you.
Good morning. I'm Philippe Aftimos, medical oncologist in Brussels, Belgium, and I will be discussing today two abstracts presented as mini orals at the latest ESMO Congress in Berlin a couple of weeks ago. So the title of my presentation is Novel Endocrine Therapies in Hormone Receptor Positive, HER2 Negative Breast Cancer, the New Kids on the Block, Potentialize Activity, Improve Toxicity. This is my declaration of interests. An important scientific disclosure: the cross-trial comparisons in this presentation are only made to understand the background and context. Results of these trials have been used to build statistical hypotheses of future trials. These are the two abstracts I'm going to discuss. Abstract 293, a mini oral, TACTIVE-N, a phase 2 neoadjuvant study of vepdegestrant, a PROTAC estrogen receptor degrader, or anastrozole in postmenopausal ER-positive, HER2-negative localized breast cancer. And abstract 294 mini oral. This is a preoperative window of opportunity study with giredestrant or tamoxifen in premenopausal women with ER-positive, HER2-negative early breast cancer and the Ki-67 above 10%. The study is called the EMPRESS study. We are going to discuss today novel endocrine therapies, and beyond tamoxifen and the aromatase inhibitors, there are many in development, including the oral estrogen receptor degraders, but also the CHIRANs, the SERCAs, and the PROTAC. Two compounds we are going to review today. One is a PROTAC ER degrader, so it works using the ubiquitination proteasome system complex and directly inhibits ER. The oral SERD, giredestrant, that also uses the UPS complex but indirectly to degrade ER. We already have multiple reported phase 3 studies with novel endocrine therapies in metastatic breast cancer, and there are already 2 regulatory approvals. So the first phase 3 is EMERALD, that investigated elacestrant in second and third line after prior CDK4/6 inhibitors. One chemo line was allowed, and this study led to the regulatory approval of elacestrant in hormone receptor positive, HER2-negative metastatic breast cancer with ESR1 mutations. EMBER-1 is a phase 3 study in investigating imlunestrant, another oral SERD. There was a third arm with imlunestrant and abemaciclib, and this was also after first line AI plus or minus CDK4/6 inhibitor. And based on this study, imlunestrant is now also FDA approved for a hormone receptor positive, HER2-negative metastatic breast cancer with ESR1 mutations. 3 other positive studies are SERENA-6, which investigated an early switch to an oral SERD following molecular progression. So this is the detection of an ESR1 mutation in a liquid biopsy before radiological progression. VERITAC-2, which is a phase 3 study comparing vepdegestrant to fulvestrant after first-line endocrine therapy plus or minus CDK4/6 inhibitor. And recently at the ESMO Congress, VIERA, that investigated giredestrant and everolimus versus standard of care endocrine therapy and everolimus, second or third line after prior CDK4/6 inhibitor. So the following 3 studies are positive, but the indication is not yet approved. These are the study designs of the 2 abstracts I'm discussing today. So for TACTIVE-N, this is a neoadjuvant study. So patients received 6 months of therapy with vepdegestrant or anastrozole. There was a 2-to-1 randomization. However, regarding the endpoints, there was no formal comparison between the 2 arms. And then the EMPRESS study, this was in premenopausal patients, while TACTIVE-N was in postmenopausal patients. Again, the early setting, this is a window of opportunity study, only 15 days of treatment with giredestrant or tamoxifen, and there the formal comparison between the 2 arms. You can see in this table what is common and what is different. So the primary endpoint is the same for both studies. Ki-67 change from baseline to week 2. INT'L, since the neoadjuvant study, you have secondary endpoints, including some clinical response endpoints such as radiographic response rate or best % change in tumor size. And then the secondary endpoints in EMPRESS are biological, so complete cell cycle arrest, changes in ER and PR expression, molecular profiling, and also toxicity and safety evaluation. Now, just to put these trials into perspective, in the preoperative setting, we have two types of studies, window of opportunity studies or neoadjuvant studies. The window of opportunity study is usually short, 1 to 2 weeks. The primary aim is not clinical benefit, but a pharmacodynamic biomarker change, such as Ki67. And these studies have minimal impact on surgical planning. While the neoadjuvant study, longer treatment, 3 to 6 months, can downstage tumors. So the aims are pharmacodynamic biomarker change, assess on treatment response. It provides prognostic information and allows the study of residual disease. Now, both are platforms for biomarker discovery, adaptive trials, and therapy personalization. Neoadjuvant studies can also incorporate a window of opportunity component. So what about the primary endpoint in both studies? So Ki67 drop as an endpoint has been validated in different studies as a prognostic biomarker. So the POETIC phase 3 study enrolling thousands of patients, you see that when Ki67 is low at day 15, patients have better prognosis. And this is true for low, but also high initially and low at day 15. While if we compare to the prognosis of patients with high, there you have a worse prognosis. And in the ACOSOG Z1031 study, the absolute value of Ki67 at weeks 2 or 4 is also prognostic. So when it was below 10%, patients had a better disease-free survival. So this indeed led to the validation of this biomarker. Now, INT'L, the primary endpoint, Ki67 drop at day 15 was achieved in 71.4% of cases. In the control arm, this was 72.9, again, not comparative. And when you look at what is expected with endocrine therapy in patients that are treatment naive, for example, when we look at the study with imlunestrant, this was EMBER-2, or the POETIC study with preoperative AI, letrozole and anastrozole, this was minus 76.8%. So the same value across all the studies showing that the drug is working. Now, one would say, the novel endocrine therapies are more potent. Why do we have the same results as anastrozole and other AIs? Well, it's because here the populations are treatment naive, no ESR1 mutations, no endocrine resistance. So in a predominant endocrine sensitivity, you would expect the endocrine therapies to work the same. Now, looking at the clinical endpoints, and those are secondary endpoints such as radiographic response, breast conserving surgery rate, and pathological complete response. So the rate of pathological complete response was quite low in both arms. You look at the radiographic response, this was achieved in a little bit less than half of the patients. However, I don't think that those endpoints are really important for endocrine therapy, because pathological complete response is an infrequent event with neoadjuvant endocrine therapy studies. When you look at the data, it's 0 to 5% in studies of neoadjuvant endocrine therapy, including in ER-rich tumors. When you add CDK4/6 inhibitor, it's still between 0 and 5%, and that is shown in the studies such as Neopalana, NeoMonarch, and Coopera. Regarding radiographic response, this can be biased by the different durations of endocrine therapy administration. In some studies, it's 4 months, in others, it's 6 months. And the evaluation methods, some studies use caliper, others ultrasound, others MRI. And finally, regarding the breast conservative surgery rates, those can be influenced by patient preference. Some patients would request mastectomy, even though lumpectomy is possible. So moving to the EMPRESS study, this is abstract 294 mini oral. A very important study because it tested giredestrant without ovarian function suppression in premenopausal breast cancer. Why is this an important study? Because ovarian function suppression and younger age are associated with more severe side effects and lower rates of treatment compliance. And then the 20 to 30% rate of early discontinuation is associated with a higher risk of relapse, as we see here in this Danish cohort. Regarding oral SERDs, all pivotal trials investigating them mandate ovarian function suppression for premenopausal patients. However, the pharmacodynamic effect of SERDs, ER degradation, might still be potent in the presence of high estrogen levels. So we would hypothesize that ovarian function suppression is not needed for the efficacy of oral SERDs. Important because of the side effects that our patients have with ovarian suppression. I have put in this table on the right some select adverse events adapted from soft and text. And you see the rate of hot flashes, insomnia, musculoskeletal symptoms, osteoporosis, vaginal dryness, dyspareunia, all adverse events that are higher with ovarian function suppression and that influence the quality of life of our patients. So in the EMPRESS study, the primary endpoint was also the drop at Ki-67 at day 15. And there they wanted to compare to tamoxifen. And this was achieved more frequently with giredestrant versus tamoxifen. So the primary endpoint is met. But is this enough to forego ovarian function suppression? I think this study is informative. However, it will not be enough to forego ovarian function suppression because there was no giredestrant and ovarian function suppression arm. So a third arm that would show if giredestrant works better with OFS. Second, tamoxifen here is a suboptimal treatment choice for some premenopausal patients. We know from soft and text that some patients that are younger that need chemotherapy derive more benefit from aromatase inhibitors. And finally, the duration of treatment. So at 2 weeks, when we looked at the primary endpoint, steady state concentrations of tamoxifen would not have been attained. Nevertheless, EMPRESS showed efficacy of giredestrant without ovarian function suppression. And we can see that also on the secondary endpoints. And you can see here the rate of complete cell cycle arrest, which is by definition Ki-67 that drops below 2.7%. And this was higher with giredestrant versus tamoxifen. I put a table to compare to other patients to other studies in the postmenopausal setting, this time testing imlunestrant, elacestrant, camizestrant, and giredestrant. And you see that the rate of complete cell cycle arrest ranges between 5% to 51%. So what was found with giredestrant is actually demonstrating activity. Now, another endpoint was ER degradation, so looking at the ER levels. And this actually reflects the pharmacodynamic effect of these agents. And in vepdegestrant, we see a drop, minus 76% in the expression of ER. So it shows that vepdegestrant is degrading ER. The same with giredestrant in EMPRESS. So giredestrant, in the absence of ovarian function suppression, is degrading ER. As a comparison, we also saw that with imlunestrant in EMBER-2. So this is the mechanism of action of the drug, because you don't see that with tamoxifen in EMPRESS. And when you look at the impact study, you don't see that with tamoxifen and anastrozole. And because aromatase inhibitors and SERMs do not degrade the receptor. So where are we now? There are studies of novel SERDs in the adjuvant setting. lidERA, Cambria-1, Cambria-2, EMBER-4, ELEGANT, TREAT-ctDNA. These are studies either upfront or after 2 to 5 years of endocrine therapy. So we need to do better for patients' side effects. So there are possible improvements in musculoskeletal and gynecological adverse events with novel SERDs in postmenopausal breast cancer. And we see that, for example, in the Coopera study, where you have less arthralgia with giredestrant versus anastrozole. So this is for postmenopausal patients. So it's time to do better for premenopausal patients by trying to forgo OFS. Now, beyond EMPRESS, there are 2 other studies that are investigating oral SERDs in window of opportunity studies in premenopausal patients. There is the Coopera study that completed the recruitment, and there were 3 arms: giredestrant alone, giredestrant and ovarian function suppression, and anastrozole plus ovarian function suppression. So for me, the study responds to the flaws in the design of the EMPRESS study. And there is PREMIERE, which is a study with elacestrant, and there it was 2 arms, elacestrant and elacestrant with triptorelin. So the results are still pending for these 2 studies. Now, what have we learned from EMPRESS and TACTIVE-N? Let's start with EMPRESS. Learning if we can forego ovarian function suppression with oral SERDs is of utmost importance for premenopausal patients. EMPRESS has demonstrated activity of giredestrant without OFS in premenopausal breast cancer. The design of EMPRESS is unlikely to lead to a change in practice. Coopera and PREMIERE are ongoing with comparative arms, including ovarian function suppression. Moving to TACTIVE-N, TACTIVE-N provides further evidence of the pharmacodynamic effect of vepdegestrant. Clinical endpoints remain elusive with neoadjuvant endocrine-based therapies. Reduced ER pathway activation and increased immune activation. This is a part of the study I did not show in my presentation for the sake of time. So this was done using gene expression profiling, are consistent with results from other oral SERDs, studies such as ELIPSE that investigated the elacestrant. And then the safety profile of vepdegestrant, including lower rates of arthralgias and the 3% discontinuation rate, allows the investigation in the adjuvant setting, but the field has become crowded. Now, a few questions and perspectives. Will favorable results from window of opportunity studies be enough to convince regulatory authorities to allow oral SERDs without ovarian function suppression in premenopausal breast cancer? Second question, will the results be extrapolated or should safety and activity be demonstrated for every individual agent? So this means we have to do a study with camizestrant, a study with giredestrant, a study with elacestrant, a study with imlunestrant. Now, with the confirmation at ESMO 2025 of CDK4/6 inhibitors as standard of care therapy in early breast cancer, with the overall survival benefit in monarchE and the 5-year follow-up of NATALEE, combinations have their place in the preoperative setting and could improve clinical outcomes. And finally, beyond Ki67, novel biomarkers such as gene expression assays and ctDNA dynamics have a place as correlative endpoints in the preoperative setting. And with that, I would like to thank you for your attention.
Good morning to all. First, I would like to thank Professor Ghosn for always having us all together with this ESMO Together this year after this beautiful ESMO in Berlin. So for today, I selected some abstracts in breast cancer and specifically 4 abstracts related to early breast cancer and specifically high-risk hormone receptor positive HER2 negative early breast cancer. So I picked 4 abstracts. 2 of them about the monarchE trial, which is the very well-known monarchE trial. They presented this year at ESMO the primary overall survival with the use of abemaciclib in the adjuvant setting and the prognostic and the predictive value of Ki67 before and after chemotherapy. Then the 3rd abstract will be about the well-known NATALEE trial with using of ribociclib in the adjuvant setting, the 5-year outcomes with this use of ribociclib. And the 4th related to pregnancy after breast cancer with the well-known also positive trial that presented the safety of pregnancy and stopping hormonal therapy after breast cancer. So to start with the monarchE trial, we all know that monarchE trial is using the abemaciclib in the adjuvant setting plus endocrine therapy for hormone receptor positive HER2 negative high risk early breast cancer. And this year they presented the primary, as I said, overall survival and also the updates about the invasive disease-free survival. We all know that overall survival improved in hormone receptor positive early breast cancer with the use of tamoxifen versus no treatment before, then AI versus tamoxifen, then the extended AI versus 5 years AI, and then with the well-known soft and text trials with the use of ovarian function suppression for premenopausal high-risk hormone receptor positive HER2 negative early breast cancer. But we did more than this with the use of 2 years of adjuvant abemaciclib plus endocrine therapy that significantly in the monarchE trial improved invasive disease-free survival over hormonal therapy alone. And last year we presented the 5-year update about the invasive disease-free survival. And this year they presented the primary overall survival and the update at 6.3 years, so 76 months about invasive disease-free survival. So the monarchE trial design, as we all know, it's hormone receptor positive HER2 negative node positive high risk early breast cancer. We had 2 cohorts in the study. We had the first cohort that presented the big part of the patient, and the second cohort related to Ki67, which was stopped. So the main cohort was using high risk. The intent to treat population was high risk early hormone positive HER2 negative breast cancer, either N2, so more than 4 lymph node, or N1, so between 1 and 3 axillary lymph node, but with at least one of those high risk features, grade 3, or a tumor size more than 5 centimeters, which is a T3. They were randomized 1-to-1 to receive abemaciclib 150 milligram twice daily plus endocrine therapy versus endocrine therapy alone for 2 years. And the primary objective was invasive disease-free survival, and the secondary objective was overall survival. Here we present the overall survival in the intent to treat population, and at a median follow-up of 6.3 years, we had a main advantage of using abemaciclib for 2 years plus endocrine therapy, and it reduced the risk of death by 15.8% compared to ET alone, with a good hazard ratio of 0.8. And this was across all the specific subgroups. And also, as you can see here, we had more than 30% fewer patients that developed metastasis after using abemaciclib in the adjuvant setting for them. For the update about invasive disease-free survival at 6.3 years, we can, as you can see here in the curves, the use of abemaciclib plus endocrine therapy reduced the risk of invasive disease-free of invasive disease by 26.6% compared to ET alone, with a good hazard ratio of 0.7, statistically significant, and this was also across all the subgroups of patients. Also, if you can see here, abemaciclib plus endocrine therapy reduced also the number of patients with metastasis at the common site, so bone, liver, lung, and we had a lower rates of secondary neoplasm when we are using abemaciclib plus endocrine therapy, and even in the control group. So the use of abemaciclib didn't increase the risk of secondary primary neoplasm. Here, as you can see, we have a sustained disease-free survival with the use of abemaciclib plus endocrine therapy, and it was reduced by 25.4% compared to the use of ET alone. And the safety signals for the using of abemaciclib, we all know that we have the main adverse event with abemaciclib, that is diarrhea, but it is well managed usually, and the rates of grade 3 adverse events was not that significant in this trial. So as a conclusion, we know now that abemaciclib is the first CDK4/6 inhibitor to achieve a statistically significant improvement in overall survival and in invasive disease-free survival at a follow-up of 6.3 years for patients with hormone receptor positive, HER2 negative, node positive, high risk early breast cancer, and it is now a standard of care for using abemaciclib for 2 years for these patients. Do we have still a place for the Ki-67 and it is a prognostic or a predictive biomarker for the use of abemaciclib in the adjuvant setting? As we can see, they took a cohort from the Monarch-E trial, and we all know that in previous analysis that a high baseline Ki-67 was associated with a worse prognosis, and giving neoadjuvant chemotherapy for these high-risk patients is known to reduce the Ki-67. But the question is this Ki-67 prognostic and predictive pre and post neoadjuvant chemotherapy for the disease in general and for the use of abemaciclib? Here, as you can see, at 54-month median follow-up, the use of abemaciclib plus endocrine therapy showed sustained invasive disease-free survival improvement, either if we use adjuvant chemotherapy for this patient or if we use neoadjuvant chemotherapy for this patient. And as you can see here, a high Ki-67 index pre or even post-neoadjuvant chemotherapy is associated with a higher risk of recurrence compared to having a low Ki-67 before or after chemotherapy. But the use of abemaciclib, or the benefits of use of abemaciclib, was regardless of the Ki-67. So the population, even if they have a low or a high Ki-67, are having benefits from the use of abemaciclib. But we all know that the prognosis of high Ki-67 before or after chemotherapy for these patients is worse than the prognosis of having a low Ki-67. So all patients, they benefit from the addition of abemaciclib regardless of the change in the Ki-67 in their tumors before or after giving neoadjuvant chemotherapy. And this was the conclusion of the study. So having a Ki-67 is a worse prognosis, especially if it's still high after giving neoadjuvant or adjuvant chemotherapy. And the use of abemaciclib is beneficial in those both population, and it will have a better prognosis for the patient that have a Ki-67, especially after chemotherapy. The third abstract is about NATALEE trial, the well-known NATALEE trial with the use now of a second CDK4/6 adjuvant in the adjuvant setting, which is ribociclib. And here we present the 5-year outcomes of this study. So we all know that now ribociclib in combination with aromatase inhibitor is indicated in the adjuvant setting for patients with high-risk early breast cancer. But here the population is different from the population of the monarchE trial because we have included stage 2 and even node negative patients versus only node positive patients in a monarchE trial. And here we report the updated efficacy and the key safety outcomes of the pre-specified 5-year analysis of NATALEE using ribociclib in the adjuvant. So we all know the design of the NATALEE trial. So we usually included patients either N1 like in monarchE, N2 like or N3 like in monarchE, but the specificity of NATALEE is having N0 patients or grade 2 patients with one of those high-risk features, Ki-67 more than 20%, oncotype DX with a high recurrence score, or high risk via genomic risk profiling. And they were randomized 1-to-1 to receive ribociclib at a dose of 400 milligram versus the 600 milligram that we use in the metastatic settings, 3 weeks off, 3 weeks on, 1 week off with AI versus the control arm, which is the AI. And the primary endpoint was the invasive disease-free survival. And as you can see here, there is a benefit with a follow-up of 55.4 months of using ribociclib in the adjuvant. And there is a difference between ribociclib plus AI versus AI alone with a good hazard ratio, statistically significant of 0.7. And we all know also that most invasive disease-free survival events were distant recurrence, and those distant recurrence were seen less in the arm of ribociclib plus AI versus the arm of AI alone. And this was consistent across all pre-specified subgroups in this NATALEE trial. And this was independent of the nodal status. So with a median follow-up of 2 years, using ribociclib continues to demonstrate persistent benefit in N-positive patients, but also in high-risk node-negative patient. We have a trend of having improvement in overall survival, but the data for overall survival is still not mature in the intent to treat population. And as a conclusion, and this 5-year follow-up of NATALEE trial, the use of ribociclib plus AI continues to reduce the risk of recurrence beyond the 3-year window treatment, supporting its use as adjuvant treatment here for 3 years for hormone receptor positive, HER2 negative, high risk early breast cancer, either node positive or high risk node negative disease. And this was published in parallel with the ESMO Congress. I will end very rapidly with the positive trial. The positive trial was about having safety of pregnancy after breast cancer. And here we present the update of this trial. And we all knew the first result of this trial that was that said that it was safe to have a pregnancy and to interrupt hormonal therapy, but with specific conditions. So the patient has to have 18 to 30 months of adjuvant hormonal therapy, so usually 2 to 3 years, and then we can stop hormonal therapy, 3 months of washout, and then we can have to stop around 1 year, and then or up to 2 years, and then we have to continue hormonal therapy for up to 5 to 10 years as a total treatment. Primary endpoint: breast cancer-free interval versus other secondary endpoint, breastfeeding, etc. And as you can see, here we are presenting the 71st median follow-up update of this trial, and there is still data that it is safe to compare to the soft and text control arm to stop and interrupt hormonal therapy to have a pregnancy for this patient. And we all know that this is very important for the after cancer phase of our patients. And if you can see, at least 76% of patients reported becoming pregnant at least once when having this method of stopping hormonal therapy and having a pregnancy. I went very rapidly on this data, but just to say that it is safe to stop hormonal therapy after 2 years, for 1 year or up to 2 years, and then resume hormonal therapy for a total of 5 to 10 years. So as a conclusion, after 71 months median follow-up, we know that temporary interruption of hormonal therapy to have a pregnancy was not associated with worse outcomes in breast cancer. Pregnancy rates were high, complications and birth effects were low in the general population. Most patients resumed endocrine therapy within 5 years of enrollment, and they continued a total usually of 10 years of endocrine therapy. And these updated results provide critical safety to counsel our young patients with hormone receptor positive early breast cancer that they can safely have pregnancy if they are interested in getting pregnant again. But also, we always say that further follow-up is planned in 2029, and it is important to have further follow-up on this data to make it more and more safe. And with this, I will end, and thank you so much.
Good morning, everyone. Thank you for being with us today. It's a great pleasure to be with you in the ESMO Together. I would like to start by thanking Professor Ghassan for the kind invitation. And today I'm going to be sharing data about DESTINY trials, reshaping destiny and transforming outcomes in HER2-positive early breast cancer. So I will be talking about DESTINY Breast 11 or neoadjuvant trastuzumab deruxtecan for high-risk HER2-positive early breast cancer. Then the interim analysis data of the DESTINY Breast 05 for trastuzumab deruxtecan versus T-DM1 in patients with residual invasive disease after neoadjuvant therapy. And then we are going to be sharing a few thoughts on how to intertwine the destinies. And since we're talking about destiny, I want you to meet the Moiré or Fates, les Parques en français, which were goddesses in Greek mythology who personify destiny. You see here 3 ladies, Cloto, who spins the thread of life, Lachesis, who measures its length, and Athropos, who cuts it at the end of life. And this AI-generated picture is a modern allegory where myth and science overlap seamlessly, and maybe, in light of the recent data, we may be reshaping destiny. So let us start with the first abstract, which was the DESTINY Breast 11, or neoadjuvant trastuzumab deruxtecan alone, or followed by paclitaxel, trastuzumab, pertuzumab, versus the dose-dense ACTHP for high-risk HER2-positive early breast cancer. The study was presented by Dr. Nadia Harbeck. So we do know that with no new therapies in over a decade, there remain an unmet need for more effective and less toxic neoadjuvant regimens for HER2-positive early-stage breast cancer. We also know that the pathologic complete response is a prognostic factor for event-free survival and overall survival in patients with HER2-positive early breast cancer, and it does provide essential information to support clinical decision-making. And with the existing standard of care regimen, between 39 to 64% of patients have PCR, and the rates are unfortunately lower in patients with hormone receptor positive disease and those at high risk, such as large tumor size or extensive nodal involvement. And patients with PCR are eligible for less burdensome subsequent treatments, like the reduction in the extent of surgery and less toxic post-neoadjuvant therapy. And we also know that our standard of care regimen do have acute adverse events and long-term sequelae, such as cardiotoxicity, secondary leukemia, and neuropathy. And trastuzumab deruxtecan here demonstrated improved survival outcomes when compared to previous standard of care in the metastatic setting. And here comes DESTINY Breast 11, aimed to bring trastuzumab deruxtecan to the neoadjuvant setting to determine whether this would improve the efficacy and safety for patients with high-risk HER2-positive early breast cancer. So it was a randomized, global, multi-center, open-label phase 3 study. Patients had previously untreated HER2-positive early breast cancer, either HR positive or negative. High risk was defined as having more than CT3 and N0, N3, or CT0 to 4, but with N1 to N3, and inflammatory breast cancer cases were allowed. Patients were randomized into 3 arms, trastuzumab deruxtecan followed by THB 4 cycles each, or dose-dense AC followed by THB 4 cycles each, or third arm trastuzumab deruxtecan alone 8 cycles. Patients then underwent surgery, and the recommended post-neoadjuvant treatment as per the protocol were for patients that had PCR, radiotherapy, and concomitant trastuzumab plus or minus pertuzumab for up to 1 year. If no PCR, then radiotherapy and T-DM1 for up to 14 cycles, and if HR positive, then endocrine therapy. Data cutoff was March 2025, primary endpoint PCR, secondary endpoint EFS, and additional measures such as the RCB or residual cancer burden. Kindly note that the third arm, the trastuzumab deruxtecan alone arm, was closed in March 2024 following an independent data monitoring committee recommendations. Reasons here were multifactorial, including a lower PCR rate and low likelihood that trastuzumab deruxtecan alone would be superior to dose-dense AC followed by THP and the timing of surgery. So in terms of patient disposition, 3 arms. The first arm, trastuzumab deruxtecan alone, 283 patients. This arm was closed. We still have 2 arms, trastuzumab deruxtecan followed by THP, 320 patients, of which around 17% discontinued treatment because of adverse events, but 312 underwent surgery afterwards. In the second arm, the dose-dense AC followed by THP, 312 patients, of which around 14% discontinued treatment because of adverse event, and 300 patients went on to receive and to undergo surgery. Now, what about the key baseline characteristics? Keep an eye here that more than 70% of the sample in both arms were HR positive, and that more than 85, donc around 90% of patients in both arms were nodal status positive. So what about the primary endpoint in terms of PCR? When we take a look at the ITT population, we see that neoadjuvant trastuzumab deruxtecan followed by THP demonstrated a statistically significant and clinically meaningful improvement in PCR when compared to the dose-dense AC-THP, with a PCR rate of 67.3% compared to 56.3% and a delta of 11.2% and a p-value that was statistically significant. And this improvement was also observed in both the HR positive and the HR negative subgroups. Now, what about the PCR according by subgroups? We see here across this graph that the improvement in PCR for trastuzumab deruxtecan was observed across most of the pre-specified subgroups. Now, regarding the residual cancer burden outcome, we see here that after surgery in the ITT population, 81.3% of patients receiving trastuzumab deruxtecan followed by THP had no or minimal residual invasive cancer, so RCB 0 or 1, detected in the resected breast or lymph node tissues, as compared to 69.1% of those receiving the dose-dense AC-THP with a delta of 12.2%, and almost 80% of patients with HR-positive disease had an RCB of 0 or 1 with trastuzumab deruxtecan followed by THP. Now, what about the event-free survival hazard ratio 0.56? The data is still immature, but still there was an early positive trend in EFS that was observed favoring trastuzumab deruxtecan followed by THP when compared to the dose-dense AC. Now, what about post-neoadjuvant treatments? They were generally well balanced between trastuzumab deruxtecan and the dose-dense AC arm. And in both arms, we see that more than half of patients without PCR went on to receive post-neoadjuvant T-DM1. In terms of overall safety profile of trastuzumab deruxtecan followed by THP, it was favorable when compared to the dose-dense AC, where you see here reduced rates of grade of more than 3 adverse events, serious adverse event, treatment interruption, and left ventricular dysfunction, and the ILD incidence was low and similar in both arms. Now, what about the side effects that were observed in more than 20% of patients? We see here that we have more nausea in the trastuzumab deruxtecan arm, but despite it all, it had fewer any grade or grade more than 3 hematological and fatigue events when compared to the dose-dense AC. And aside from nausea, which I already mentioned, gastrointestinal toxicity was comparable between arms. Now, what about the conclusion? In the DESTINY-Breast11, trastuzumab deruxtecan followed by THP showed the highest reported PCR rate in HER2-positive early breast cancer for a registrational study in the neoadjuvant setting, despite a high prevalence of HR-positive disease and a high-risk population. It showed a statistically significant and clinically meaningful improvement in the PCR rate. You see here 67.3%. So more than 2/3 of patients in the TDXD arm had a PCR, of which 61.4% were HR positive and 83.1% were HR negative, and the p-value was statistically significant. And there was an early positive trend in EFS that was observed. In terms of safety profile, it was favorable when compared to the dose-dense AC-THP, meaning that DESTINY-Breast11 results support TDXD followed by THP as a more effective and less toxic neoadjuvant treatment when compared to the dose-dense AC-THP, and it may become a preferred regimen for patients with high-risk HER2-positive early breast cancer. But questions here remain. What would be the ideal adjuvant therapy for a patient treated with TXD-THP with no PCR? Will T-DM1 work if residual tumor has lower level expression of HER2? And most importantly, should TDXD be given in the adjuvant setting for residual disease rather than neoadjuvant? Stay tuned, because it's our second study, which were the DESTINY-Breast05. It studied trastuzumab deruxtecan versus T-DM1 in patients with high-risk HER2-positive primary breast cancer that still had residual disease after neoadjuvant therapy. These are the interim analysis of the DESTINY-Breast05 presented by Dr. Charles Geyer. In terms of background, we know that HER2-targeted therapies have greatly improved the outcomes for patients with HER2-positive early breast cancer. In the famous Catherine trial, the adjuvant T-DM1 significantly improved the invasive disease-free survival and the overall survival relatively to trastuzumab in patients with HER2-positive early breast cancer and residual invasive disease following the neoadjuvant therapy. However, we know that there are subsets of patients that do present with advanced local regional disease and positive nodal status after neoadjuvant therapy, and these patients had a 3-year IDFS rate of 76% and 83% respectively, and at 7 years, the IDFS rates were 67% and 72% respectively. And furthermore, the adjuvant T-DM1 unfortunately did not reduce the CNS recurrences relatively to trastuzumab. Therefore, an unmet medical need remained even with adjuvant T-DM1 for these high-risk patients in the post-neoadjuvant settings. And we have known that early phase studies in heavily pretreated HER2-positive metastatic breast cancer had demonstrated a remarkable activity of T-DXd, and the DESTINY-Breast03 demonstrated superiority of T-DXd when compared to T-DM1 in second-line metastatic setting. So here comes the DESTINY-Breast05 as a global, multi-center, randomized, open-label phase 3 trial that assesses the efficacy and safety of adjuvant T-DXd versus T-DM1 in high-risk patients with HER2-positive early breast cancer and residual invasive disease following neoadjuvant therapy. Now, in terms of eligibility criteria, patients had to have residual invasive disease in the breast or axillary lymph node after neoadjuvant therapy with HER2-directed molecules. High risk was defined as presentation prior to neoadjuvant therapy with either inoperable early breast cancer, CT4 and 0 and 3, or CT1 to T3 but with N2 to N3 disease, or operable early breast cancer, CT1 to 3 with axillary lymph node positive disease after neoadjuvant therapy, of course, centrally confirmed HER2-positive status. So 1,600 patients randomized to receive either T-DXd every 3 weeks for 14 cycles or T-DM1 every 3 weeks for 14 cycles. Primary endpoint was the invasive disease-free survival, followed by key secondary endpoint, the DFS, and other secondary endpoint, overall survival, brain metastasis-free interval, distance recurrence-free interval, and safety. We have to note that concomitant adjuvant hormone therapy was allowed for local practices, and if administered, radiotherapy could be given either concurrent with the study therapy or completed prior to initiation of study therapy. It was the sequential per investigator decision, and the ILD had a monitoring program for patients treated with radiotherapy. All patients underwent low-dose CT of the chest during screening. All radiotherapy patients, either receiving it concurrently or sequential, had a low-dose CT chest 6 weeks after start of study therapy, then every 12 weeks while on therapy. And sequential radiotherapy patient had an additional low-dose CT chest that was done at the end of radiotherapy and prior to start of study therapy. On patient disposition, 1,635 patients that were randomized, 806 in the T-DXd arm, of which 12 did not receive T-DXd, 223 discontinued treatment mostly because of adverse events, and 583 patients completed the study treatment. In the T-DM1 arm, 801 patients, 16 did not receive T-DM1, 190 discontinued treatment mostly because of adverse event, and we have 611 patients that completed study treatment, which gives us a median study duration of 29.9 months with T-DXd and 29.7 months with T-DM1. What about the baseline demographics and clinical characteristics? Keep in mind that around 50% of the sample in both arms were of Asian origin. 71% of patients in both arms were hormone receptor positive. In terms of the operative status at disease presentation, it was in more of half of the cases an inoperable CT4 and 0 to N3 or a CT1 to 3 with an N2 or N3 disease. Post-neoadjuvant pathological nodal status report was in 80% of the cases positive in both arms. And in terms of neoadjuvant HER2-targeted therapy, around 77 to 78.5% had received dual HER2 blockade. The majority of patients were exposed to anthracycline in the neoadjuvant settings, and all of them went on to receive radiotherapy at some point, either concurrently or sequentially. What about the primary endpoint, invasive disease-free survival? At 3 years, it was 92.4% in the T-DXd arm, compared to 83.7% in the T-DM1 arm, hazard ratio of 0.47, p-value statistically significant, meaning a 53% reduction in the risk of invasive disease recurrence or death. for TDXD when compared to TDM1. In terms of subgroup analysis, you see here that all of the subgroups favored the TDXD arm. Now, what about categories of first invasive disease-free survival event? We see here that we have lower distant and local regional recurrences that were observed in the TDXD when compared to TDM1, including the CNS recurrences. What about the secondary endpoint, DFS? At 3 years, it was 92.3% in the TDXD arm versus 83.5%, hazard ratio of 47, p-value statistically significant. In terms of secondary endpoint, for the distance recurrence-free interval at 3 years, it was around 94% in the TDXD arm versus 86% hazard ratio of 0.49. In terms of the brain metastasis-free interval, around 97.6% compared to 95.8%, hazard ratio 0.64, and overall survival data still immature. Keep in mind, it was 97.4 in the TDXD versus 95.7 with a hazard ratio of 0.61, but still the data is immature. Now, in terms of study treatment exposure, more than 72% of patients had completed the planned 14 cycles of therapy in both arms, and patients that discontinued the study treatment prior to the 14 cycles were allowed to receive additional HER2-targeted therapy as per standard of care to reach up to 14 cycles of HER2-targeted adjuvant therapy. Overall safety exposure, we see that in the TDXD arm, we had 3 deaths. 2 of them were ILD and 1 respiratory tract infection. And in the TD1 arm, 5 deaths. None of them was directly related to treatment. Donc, in terms of adverse events that happened in more than 20% of patients, we see here it was mainly nausea in the TDXD arm, followed by constipation, decreased neutrophil count, and vomiting. And in terms of radiation pneumonitis, the rates were comparable between the 2 arms. So in conclusion, DESTINY-Breast05 demonstrated a statistically significant and clinically meaningful improvement in the IDFS and DFS with TDXD compared to TDM1 in high-risk patients with HER2-positive early breast cancer and residual invasive disease after neoadjuvant therapy. The IDFS benefit was consistent across all the pre-specified subgroups. We had in terms of IDFS, I remind you, a 53% reduction in the risk of invasive disease recurrence or death, a 3-year IDFS rate of 92.4% versus 83.7%, hazard ratio of 47, and p-value statistically significant. And the CNS mets and death were numerically fewer in the TDXD versus TDM1. Overall safety profile was manageable, no new signal. And here it shows us that adjuvant TDXD demonstrated a superior efficacy with manageable safety in patients with high-risk HER2-positive early breast cancer and residual invasive disease after neoadjuvant therapy, representing a potential new standard of care in this post-neoadjuvant setting. But how about intertwining destinies? How could we integrate the DB11 and DB05 data since trastuzumab deruxtecan may become available across all settings for HER2-positive breast cancer? How to optimally integrate TDXD in the early stage setting? Should we give it preoperatively or postoperatively? And how do we proceed if TDXD becomes available in both pre-op and post-op setting? So one of the arguments to give it preoperatively would be that it would improve the PCR rate, less auxiliary surgery, shorter courses, 4 cycles versus 14, less toxicity at 4 cycles, better quality of life. We may also argue that if we give it post-op, it could allow for de-escalated preoperative therapy with THP, for example, sparing those patients with PCR, TDXD, but of course, those with residual disease would end up with 14 cycles. And on the other hand, if one does give TDXD pre-op, what do we do post-op? Let's say we selected our high-risk patients, we gave them trastuzumab deruxtecan for 4 cycles, then THP for 4 cycles, we did the surgery. If they reach PCR, fine, we give HP. But if they have residual disease, then what to do? Should we give more TDXD? The DB11 didn't suggest that longer was better. On the other hand, would TDM1 work post-TDXD? As per the DAISY trials where they did pair biopsy pre and post-TDXD exposure, it showed a decreased HER2 expression. So could HER2 loss impact the efficacy of TDM1? One proposed management, it's still a food for thought. Can we use a response-guided approach? Meaning, if we have PCR, we go for HP for 14 cycles. If we have residual disease, then we take a look at the RCB. If our RCB is 1, then TDM1 or TDXD for 14 cycles. And if it is higher, 2 or 3, then we expose them to anthracyclines, followed by TDM1. Food for thoughts. So in terms of take-home messages, we know now that adjuvant TDXD does reduce risk of recurrence by half when compared to TDM1. It should be adopted as a standard of care for patients with HER2-positive breast cancer who have residual disease and HER2-directed pre-op therapy, and either node positive at time of surgery or inoperable at baseline, meaning a T3 or T4 or N2N3 disease. T-DM1 should still be utilized in patients with operable disease at baseline and residual node negative disease, but we do need biomarker-driven trials to help us personalize therapies to the individual patients. And having said that,
good morning, everyone. Special thanks for the organizers and for Johnson & Johnson for this invitation. So today I'll be presenting a comprehensive overview of the evidence supporting the use of DARZALEX as a foundational therapy for all newly diagnosed multiple myeloma patients. In fact, we will examine the compelling data in both transplant-eligible and transplant-ineligible settings. The first slide sets the stage of our entire discussion. The key message here is that DARZALEX is a versatile and foundational therapy. In fact, when combined with standard regimens, it has consistently demonstrated proven efficacy across a wide variety of patient types, as we will see in the data from multiple landmark trials. And why to choose DARZALEX for all your newly diagnosed multiple myeloma in the frontline setting? Well, it's because it's the proven efficacy and tolerability. It's the only anti-CD38 monoclonal antibody that had demonstrated overall survival benefit, as we will explain in the coming slides in 3 large trials. And because it's the only anti-CD38 monoclonal antibody with patients preferred sub-Q and monthly dosing after 5.5 months as maintenance therapy. So we see here in the first our major efficacy endpoint, as for all the studies, the overall survival. So it showed a really extensive data for the prolonging the overall survival up to 7.5 years when it's compared to other regimens without the DARZALEX. It deepened the responses with MRD negativity data from the trials. Its efficacy across patient subgroups, even when we speak about cytogenetic risks and the frail and elderly patients, and it's reassuring for manageable tolerability along with a convenient 3 to 5 minutes of sub-Q injection, and as we said, the monthly dosing after 5.5 months. So this is a crucial slide. In fact, for the clinical practice, it shows us the specific guidelines recommended combination we can use. In fact, for transplant-eligible newly diagnosed multiple myeloma patients, we can speak about DARZALEX added to VTD, and in the maintenance phase with DARZALEX plus VRD with maintenance, DARA and Revlimid, in combination between induction and consolidation maintenance for the quadruplet regimen. And for the transplant-ineligible newly diagnosed multiple myeloma patient, we can speak about DARZALEX with RD and DARZALEX with VMP. And it was the first DARZALEX-based trial to use MRD negativity as the primary endpoint with DARZALEX plus VRD and maintenance DARZALEX and RD. In this way, we can talk about the DARZALEX that allow us to tailor our treatment for each newly diagnosed multiple myeloma patient. So to talk about the overall survival, so here we have the 2 large trials in the setting of transplant-eligible newly diagnosed multiple myeloma patient. We can see at the Cassiopeia trial that adding DARZALEX to VTD, in fact, the 7 years overall survival rate was 87% compared to 78% when VTD was used alone at 80 months of median follow-up, regardless of the second randomization, with a hazard ratio of 0.5 and a significant p-value. Whereas for the transplant-ineligible newly diagnosed multiple myeloma patients, here we speak about a 7.5 years with median overall survival when DARZALEX was added to RD versus 5.3 years with RD alone. So here we speak for 2.2 years gaining in overall survival when Darzalex was added, and this was at 89.3 months of median follow-up with a significant p-value. So Darzalex was proven significant across, again, the 3 newly diagnosed multiple myeloma trials. Here we speak about the transplant eligible newly diagnosed multiple myeloma patients. We speak about the PFS, in fact, and here we have the PERSIST trial, which had shown that the 4 years PFS rate was 84% with BVRD with the maintenance of DR versus 68% with VRD alone and maintenance with Revlimid alone. So we can speak about 47.5 months of median follow-up, and the hazard ratio was 0.4 with a significant p-value. If we move to the transplant ineligible newly diagnosed multiple myeloma patients, as we said, the Maya trial that showed that 53% with DRD had shown 7 years of overall survival rate when compared to RD alone with 39% of overall survival rate with a shortfall with a significant p-value. And if we want to speak about the deepen response and the deepen negativity rate, so here the data from CIFIS trial, as you all know, the MRD negativity rate was 61% versus 39% when we added DVRD in the induction and the consolidation and maintenance phase with a significant p-value. So even if we speak about the PFS, the OS, and the MRD negativity, we find the place of Darzalex in these 3 large trials. And about the practicality, so as you all know, the subcutaneous formulation is a game changer these days, and a 3 to 5 minutes injection significantly reduces the burden on both even the patient and the clinic. So it's a simple injection. It's once monthly after 5.5 months of treatment. We can move to monthly dosing. And for the transplant eligible newly diagnosed multiple myeloma patients, we can even talk or speak of discontinuation of Darzalex in the maintenance phase after 24 months in the MRD negative patients. Here a simple resume for the in fact the injection program. So in the PERSIST trial, the CIFIS trial, and the Maya trial, we can see that it's a monthly injection after 5.5 months in the PERSIST trial, and we can discontinue after 24 months in patients who was sustained MRD negativity for at least 12 months. Same for CIFIS and Maya trial. It's 1 injection after 5.5 months. Whereas if we compare with other treatments, for example, the isatuximab, we can see that the monthly injections start at least after 11 months as in the BENEFIT trial. So if we can count, it's a 1 year of gaining sub-Q injections of a monthly regimen. And this is simply the injection. We can skip. So Darzalex is this really summarized the practical benefits as well. It's a trusted treatment by all the healthcare professionals. It's recommended by all the major international guidelines, and it's backed for 15 years of clinical experience where more than 500,000 patients was treated with Darzalex. And again, the data from the Maya trial, Darzalex with RD provided a median overall survival of 7.5 years when compared to 5.3 years with RD alone. That is an additional 2.2 years of life of our patients, and this is the strongest survival signal we have in this population, even in the high cytogenetic risk group. So this slide will show the significant improvement of PFS survival, and it is consistent even with, as I said before, the high cytogenetics group. It's a 45.3 month with DRD versus 29.6 with a hazard ratio of 0.5. For example, the gain or amplification of the 1Q21, it's a 53.2 months with DRD versus 32.3. And why do we see this survival benefit? In fact, the answer is because of the deeper and the depth of response. This slide shows us that DARZALEX drives patients into deeper undetectable level of disease. The MRD rate negativity, in fact, is three times higher with DRD. More importantly, the rate of sustained MRD negativity, which is linked to the long-term outcomes, is dramatically higher, near 5-fold negativity lasting at least 12 months. And if we turn to our transplant-eligible patients and the groundbreaking PERSIST trial, the results are equally impressive. The DVRD quadruplet regimen followed by DARZALEX maintenance more than halved really the risk of disease progression or death. The 4 years, as it's shown here, the 4 years progression-free survival rate was impressively 84% with DARZALEX-based regimen versus 68% without. So this firmly established the quadruplet as a new standard of care. In fact, the depth of response in the PERSIST trial is unparalleled. 75%, as we can see here, of the patients achieved MRD negativity with DVRD when compared to 48% in the control arm. Furthermore, we see that responses continue to deepen more with the maintenance therapy, with many patients converting from MRD positive to MRD negative. And here it's not just about achieving MRD negativity, it's really about sustaining it. A significantly higher proportion of patients on DARZALEX regimen maintain their MRD negative status for 12 and even 18 months as shown here, which is a powerful predictor for long-term remission. So here we see the dynamic effect of DARZALEX maintenance visually. In fact, the bars clearly show more patients achieving and sustaining deep MRD responses over time. And just as we saw in the transplant-ineligible setting, this profound benefits in PFS and sustained MRD negativity extend to transplant-eligible patients with high-risk cytogenetics, as I explained before. The DARZALEX-based regimen provides really a superior outcome across the board. And to conclude with this impressive data, we can see that DARZALEX is advancing for more and more front lines in the coming NCCN updates for this year 2026. The quadruplet will be included as a category 1 preferred option for newly diagnosed patients who are even transplant ineligible. And with this, I would say thank you for this meeting, and I wish you a very pleasant day. Thank you.
I would like to thank Professor Ghosn for organizing this ESMO Together every year and for inviting me this year to speak I will be actually presenting data that I presented at ESMO regarding the outcomes of patients with chronic myeloid leukemia receiving second-line therapy after failing a frontline treatment with a second-generation tyrosine kinase inhibitor. These are my disclosures. As we know, there have been significant improvement in the outcomes of patients with chronic myeloid leukemia, CML, since the introduction of the BCR-ABL1 tyrosine kinase inhibitors, or TKI. Treatments in the frontline setting with second-generation TKIs leads to faster and deeper remissions compared to imatinib without any improvement in overall survival. However, about 10 to 15% of the patients receiving first-line treatment with a second-generation TKI will develop some resistance or some side effects leading to treatment discontinuation. Separately, in the third-line settings, studies have shown that in patients who fail a second-generation TKI, rotating to an alternate second-generation TKI does not significantly improve outcomes, but moving to a third-generation TKI, such as ponatinib, significantly improve response rates and survival. However, there is a gap in the literature and not enough data regarding the outcomes of patients who receive frontline therapy with a second-generation TKI and then move to second-line treatment due to different causes. And this is the objective of our study today. We looked into patients who had CML in chronic phase or accelerated phase, defined as clonal evolution only. And we looked at the frontline treatment that they received with a second-generation TKI before moving to a second-line treatment, what were the causes of switching to a second-line treatment, and what were the types of second-line treatment they received. We looked at their cytogenetic remissions, their molecular responses, as well as survival. In total, we had 276 patients who received first-line treatment with either nilotinib, dasatinib, or bosutinib, and went ahead to receive second-line treatment, mostly because of side effects. As you can see, 47% due to treatment intolerance, 19% due to true disease resistance, and 24% due to either intolerance, due to both intolerance and resistance. And when I say resistance, I mean patients who either never achieved the cytogenetic remission on first-line therapy, or they achieved the cytogenetic remission, but at some point down the road, they lost the response. And among patients who have disease resistance, 12% were found to have an ABL1 kinase domain mutation, most frequently, as you can see, T315I in 5 patients out of 9, as well as some other mutation that I am listing below. Now, what were the types of second-line treatments they received? Most frequently, imatinib, 27%. We saw earlier that most of the patients switch because of side effects, and we know that imatinib has a very favorable side effect profile, so it was kind of logical to change to imatinib in those patients. 23% of the patients received second-line treatment with bosutinib, and this is a practice in our center. 20% received nilotinib, 15% received dasatinib, and when we come to newer drugs, 11% received ponatinib as second-line treatment as part of a clinical trial, and 2% received asciminib. Now let us look together at the response rates to those second-line treatment. If we look at the first column, we classified patients based on the BCR-ABL1 transcript levels at the time of start of the second-line therapy, and we classified them by subgroups: 1 log reduction, more than 10%, 1 to 10%, 0.1 to 1%, and less than 0.1%. And then the different columns, if we go from left to right, those are the best responses that the patients achieved on the second-line treatment, again stratified by 1 log reduction of response. If we look at the first 2 rows, patients who have disease resistance and a BCR-ABL transcript above 1%, we can see that close to 60% of those patients eventually responded and deepens their cytogenetic and molecular responses, as you can see in light blue. So all the areas in this table that are in kind of light blue shade, those are patients who responded. So 60% of the patients with true disease resistance responded to second-line treatment. If we look at row number 3 and 4, those are patients who were already in a cytogenetic and a molecular response, and they were switched to a second-line treatment, 90% of those patients actually deepened their molecular remissions. As we might expect, those are patients who do not have true disease resistance, so it was kind of logical to see deeper improvement in molecular response rates. Here, we looked at patients who had only disease resistance, so their BCR-ABL levels were above 1%, and we looked at the second-line treatment they received, categorizing the patients by either second-generation TKI or third-generation TKI. And as you can see in red, patients who received either ponatinib or asciminib had improved response rates in the second-line setting compared to patients who rotated to an alternate second-generation TKI. 18% achieved a complete cytogenetic remission, and 77% achieved a major molecular response or deeper response. Now, what about treatment discontinuation and treatment-free remission? 28 patients in our cohort attempted the treatment discontinuation, mostly to side effects, 79%, as you can see here. We had a median follow-up of about 5 years after stopping therapy, and in those 28 patients, 12 of them lost response. If we look at the left curve, the 5-year molecular relapse-free survival, or TFR rate, was 57%. If we look at the right side, we can see that the top blue curve were patients who achieved a deep molecular response, MR4 or deeper, for more than 5 years before stopping therapy, and those patients had excellent TFR rate, 90%, compared to a TFR rate of 40% in those who had a shorter duration of deep molecular remission between 2 and 5 years. So if we want to summarize, this is the first report to analyze the outcome of patients with CML who failed a frontline second-generation TKI and went to receive a second-line therapy. Close to 60% of the patients with true disease resistance actually responded to treatment, higher response rate and better survival. I haven't included the survival curves here, but we have seen better survival outcomes, and you have saw higher response rates when using third-generation TKIs such as ponatinib and asciminib compared to second-generation TKIs in the second-line setting when patients fail a frontline treatment with a second-generation TKI. TFR was feasible. The 5-year TFR rate was 57%. Higher TFR rates, as you saw, were observed in patients who have a deep molecular remission rate of more than 5 years. And finally, we should always consider disease characteristics, the mutational profile of the disease, patient comorbidities, and financial status when selecting the second-line treatment for our patients. Again, I would like to thank you very much for the invitation. I am very happy to be here at ESMO Together, and thank you very much again.
Thank you, Dr. Hossein, for inviting us every year to this great meeting of ESMO Together. And we will be talking today about 2 major presentations that happened in hematological malignancies in ESMO Berlin 2025. The first one will take into consideration the CD19-CD22 bispecific CAR T-cell therapy for relapsed refractory large B-cell lymphoma. It was a prospective single-arm, single-center phase 2 clinical trial. As we all know, the prognosis of diffuse large B-cell patients have been improved in the post-CAR T eras, with only 1/3 of patients cured by CAR T-cell therapy. We can see here in the ZUMA-1 trial that the 5-year lymphoma-related event-free survival was at 33.5%. So this is a trial that studied the CD19-CD22 bispecific CAR T-cell therapy for relapsed refractory large B-cell lymphoma. It was a prospective single-arm, single-center phase 2 clinical trial that studied this particular CAR that consisted of a single-chain variable fragment derived from the anti-CD22 monoclonal antibody fused with another single-chain variable fragment from the anti-CD19 monoclonal antibody and the cytoplasmic signaling domains, of course. And the trial design was very simple. We had the treatment of the pre-BMC collection. Then we had a bridging treatment that was left to the discretion of the physician, lymphodepletion with a conditioning treatment that consisted of cyclophosphamide 250 milligram per square meter per day, fludarabine 25 milligram per square meter per day, and followed by a dose of CAR-2219 of 2 million. And as we said, the bridging therapy was left to the discretion of the physician. And after the CAR T-cell infusion, it was allowed in the maintenance therapy to use programmed cell PD-1 inhibitors 1 month after the infusion of the CAR T-cell. So for the patients that were included, we had more than 70% of the patients who were stage 4. 70% of the patients were refractory to more than 2 lines of treatment, and they had, in fact, an EP score that was elevated also in more than 70% of patients with an EP score of more than 2. So it is a heavily pretreated population and a population that is very high risk. And we can see here that if we can look at the efficacy of bridging therapy, we had only 1 complete response after the before the infusion of the CAR-T treatment. 30% of the patient achieved a partial response, and 62% of the patient achieved a stable disease. So we have the majority of the patient that achieved only a stable disease in the bridging therapy for the CAR T-cell treatment. And with a median follow-up of 4.2 months after CAR T-cells infusion, the best overall response rate was 100%, of course, comprising a complete response of 67% and a partial response rate of 32%, which really is unprecedented in this kind of population. And if we look also at the subgroup analysis, we can see that the patients with bulky disease and male patients, and they responded maybe a little bit more than the other patients in this subgroup population, but it was not powered to do something like that, this study. With a median follow-up of 4.2 months after CAR T-cells infusion, the median PFS and overall survivals were not reached. The 6 months PFS and overall survival rates were 83% and 87% respectively. At the time of data cutoff, 93.5% of treated patients remained alive, and 2 deaths were reported, 1 attributed to lymphoma progression and the other to non-lymphoma causes. So it's very promising in this kind of population that are heavily pretreated and with relapse refractory diffuse large B-cell lymphoma with tolerable adverse event, since we had only 1 patient who had grade 3 ICANS and 70% of the patients suffered from grade 1, 2 cytokine release syndrome, but it was manageable, as we can see in this study. So in conclusion, this phase 2 single center trial prospectively evaluated bispecific CD19, CD20 months after CAR T-cell infusion. The best overall response rate was 100%, including a complete response rate of 67%. And it exhibited a favorable safety profile with low incidence of grade 3 adverse event, and post-infusion maintenance therapy using PD-1 inhibitor was used, but it needs also further investigation in this kind of population. And I thank you for your attention. And I want now to talk about another abstract that was presented in ESMO. It was a sustained marrow and imaging MRD negativity that can lead to lenalidomide discontinuation following autologous stem cell transplantation in multiple myeloma. It was the updated results from a prospective cohort study. So as we know, autologous stem cell transplantation followed by lenalidomide maintenance is a standard of care for eligible newly diagnosed patients with multiple myeloma. Sustained negative bone marrow and imaging minimal residual disease correlates with prolonged PFS and overall survival. Also, often used as surrogate endpoint in clinical trial, it is not clear yet if MRD negativity can be decisive also in clinical decisions. So we know, in fact, that many patients receiving lenalidomide maintenance will remain in long-term remission. In this context, it is important to define the optimal duration of maintenance and define criteria to discontinue maintenance safely. So here are this patient. It was a 2-year landmark analysis versus a 3-year landmark analysis. And the aim of this study was to evaluate MRD-related and survival outcomes in patients who discontinue lenalidomide maintenance post-autologous stem cell transplantation after the achievement of sustained marrow and imaging MRD negativity for 3 years. So what were the inclusion criteria? The inclusion criteria were adult patients with multiple myeloma who received 4 to 6 cycles of triplet or quadruplet induction therapy, followed by high-dose melphalan, autologous stem cell transplantation, and at least 3 years of lenalidomide maintenance. And I think we have a lot of this kind of patients in our clinics and our everyday routine. Patients should have achieved a sustained bone marrow and imaging MRD negativity for 3 years, and 2 cycles of consolidation therapy similar to induction were allowed for inclusion in this study. So a very interesting study, very hands-on, interesting study. And as you can see, if we had a very good partial response of or better, we did the MRD at 6 months, 12 months, 24 months, 36 months, 3 consecutive MRD negative and PET-CT negative. They were included in the study with stopping the maintenance, and they repeated the MRD every 6 months, plus a PET-CT every 12 months. And if MRD positivity restart, or if we have an MRD positivity, we restart the maintenance. So it's a very elegant study that was done. Bone marrow MRD status was evaluated by next generation flow cytometry at baseline and then every 6 months. Patients underwent a PET-CT at study initiation and then every 12 months. Patients also had a full blood and biochemistry test for myeloma response every 3 months. If a patient converted from MRD negative to MRD positive, lenalidomide treatment was reinitiated. Lenalidomide was given at the same dose level that the patient received at the time of discontinuation and was administered as monotherapy. If a patient had a confirmed disease progression during follow-up, then the patient went out of the study and started second-line treatment. For co-primary endpoints, the rate of MRD conversion from MRD negative to MRD positive after the discontinuation of lenalidomide, the treatment-free survival among the multiple myeloma patients who discontinued maintenance, and secondary endpoints included the rate of progression after lenalidomide discontinuation, the rate of progression after re-administration of lenalidomide, progression-free survival, overall survival, and adverse events. So the study was powered to assess MRD resurgence and treatment-free survival. We hypothesized that the 3-year treatment-free survival from maintenance discontinuation for patients who were MRD negative would be 75%. Based on previously published data on PFS, we set a non-inferiority threshold interval of 55-65%, and the Kaplan-Meier and Cox proportional hazard methods were used to analyze. And this is an update analysis with, in fact, a prolonged follow-up. As we can see, the median follow-up from diagnosis was 7.5 years. It's a lot of years already, and 54 patients discontinued lenalidomide maintenance after 3 years sustained MRD negativity. The median follow-up was 3.4 years. 15 patients converted to MRD positivity and restarted lenalidomide, where 8 out of them were high-risk cytogenetic. 4 patients progressed, 2 were high-risk cytogenetics, and 1 died, but not related to multiple myeloma. So what we can say, in fact, after conversion to MRD positive, in total, only 4 patients progressed during the 3.5-year follow-up period of the study. For those who converted from MRD negative to positive, the median time to MRD resurgence was 30 months. The remaining 11 patients had restarted lenalidomide and are currently in remission. 10 remain MRD positive, 1 reconverted to MRD negative after 6 months of retreatment with lenalidomide. And the treatment-free survival, at 1 year we had 94%, 2 year 88%, 3 year 73%, and 4 year 59%, and the TFS was defined as the time from maintenance discontinuation to treatment reinitiation, progression, death from any cause or last follow-up. So these are the landmark PFS from lenalidomide discontinuation, and this is the PFS from diagnosis: 7-year 91%, 10-year 87%, with the multivariate analysis. So in conclusion, sustained MRD negative for 3 years seems a reliable biomarker to guide decisions for lenalidomide maintenance discontinuation. After a median follow-up of 42 months, 28% of patients converted to MRD positive and only 4 had progressive disease after lenalidomide reinitiation. Conversion from MRD negative to MRD positive always preceded myeloma progression, and longer follow-up will assess the risk of progression in patients that in fact converted to MRD positive and the potential role of lenalidomide reinitiation for these patients. And I thank you for your attention.
Hello, I'm very happy to be with you today to present the important abstract presented in the ESMO 2025. We'll start with a first abstract about the CAR T cells. So this is a study done by one team about a new CAR T, CD19, CD22 bispecific CAR T cell therapy in patients with refractory and relapsed large B-cell lymphoma. So this is an ongoing phase 2 clinical trial. It has enrolled 31 patients with refractory and relapsed DLBCL, and all were evaluable for efficacy and safety profile. The primary endpoint was best overall response rates as of 3 months post-CAR T cell infusion. The secondary endpoints were complete response rate, progression-free survival, overall survival, and adverse events. So the median follow-up of the patient were 4.2 months after CAR T cell infusion, and the best overall response rate in this trial was 100%, comprising a complete response rate of 64.5% and a partial response rate of 35.5%. The median PFS and OS were not reached, and the Kaplan-Meier estimated for 6-month PFS and OS rates were 83% and 87% respectively. Regarding the safety profile with this new treatment and this new CAR T, the most common adverse event included neutropenia and thrombocytopenia, and some cytokine release syndrome also occurred in 74% of patients with no grade 3 or higher events. About the ICANS, it occurred in 6% of patients with only 1 case of grade 3. For the second abstract, it's about the risk stratification for also the diffuse large B-cell lymphoma, integrating interim PET scan analysis and the National Comprehensive Cancer Network API score. It was a multi-center retrospective study, and the objective was to assess the prognostic significance of the INCNN API and PET-CT related parameters in predicting patients' outcome and to achieve accurate risk stratification. So this retrospective study included 498 patients with diffuse large B-cell lymphoma who had been analyzed the clinical pathological and PET scan data. The change in total lesion glycolized, the INCN API, the interim abdomen residual disease status, and the change in the maximum standardized uptake value were identified as independent prognostic factors via univariate and multivariate Cox regression analysis. So based on the result of this multivariable analysis, we developed a prognostic model, the PET and CCN API, which stratified the LBCL patients into 2 distinct prognostic risk groups. This highlights the importance of the NCCN API and PET scan related parameter at interim evaluation, and they confirmed that they are independent prognostic factor for the LBCL patients. Compared to the Duvir score, the usual one we use, the newly developed prognostic tool, IPET and CCN API, has superior prognostic predictive ability and can be used to identify patients with potentially poor prognosis among those patients with a Duvir score of 3. And this is a frequent situation with our DLBCL patients. For the third abstract that I selected for you, we will discuss a different disease, but a more challenging question about when we stop the Revlimid, or if we can stop the Revlimid for patients who achieve an MRD negativity. So the title of the abstract was Sustained Bone Marrow and Imaging MRD Negativity for 3 years drives discontinuation of maintenance post-autologous stem cell transplantation in multiple myeloma patients. This study was a prospective study, evaluated the conversion to MRD positivity and the treatment-free survival and the progression-free survival in 52 patients with multiple myeloma who discontinued lenalidomide maintenance after achieving sustained bone marrow and imaging MRD negativity for 3 years. The median follow-up from lenalidomide discontinuation was 3 years, and the overall 12 over 52 patients, or 23% of the patients, obtained MRD positivity and restarted lenalidomide maintenance after they stopped it. And only 7.6% of these patients, or 4 patients, progressed when we stopped the Revlimid treatment. 3 had a biochemical progression and 1 had a clinical progression. So the overall median PFS in this population who stopped Revlimid was not reached. The 7-year PFS from diagnosis was 90.2%. The 1, 2, and 3-year treatment-free survival rate was 93.9%, 91.6% for the 2 years, and 75.8% for the 3 years, respectively. So the 1, 2, and the 3-year landmark PFS rate from maintenance discontinuation, so the study entrance to the analysis, were 96.0% for the first year, 96% also for the second year, and 92.9% for the third year. Thus, in the era of modern anti-myeloma treatments, a subgroup of patients may remain treatment-free while in complete remission without jeopardizing the disease response. For my the abstract number 4, it tests the combination of mitoxantrone hydrochloride liposome with kidamide in patients with relapsed or refractory peripheral T-cell lymphoma, and it is an updated result of the phase 2 study published previously by the same team. Here we report the updated efficacy and safety data of the phase 2 single-arm prospective phase 1 and 2 study for these 2 treatments to explore the efficacy and safety of this combination regimen in patients with refractory and relapsed peripheral T-cell lymphoma. And as you know, the peripheral T-cell lymphoma in this situation, we don't have a lot of therapeutical options. So patients receive the liposomal mitoxantrone and the kidamide regimen once every 4 weeks for up to 6 cycles. The primary endpoint of this study was the objective response rate, ORR. Secondary endpoints were complete response rate, the duration of response, the progression-free survival, the overall survival, and for sure the safety. 26 eligible patients from phase 2 were enrolled in this study, including 61.5% refractory PTCL and 38.5% relapsed PTCL. With a median follow-up of 5.3 months, both median PFS and OS were not reached, and the Kaplan-Meier estimated 1-year PFS rate was 75.1%, and the 1-year OS rate was 79%. The common grade 3 and 4 treatment-related adverse events were mainly hematological toxicity, including lymphocytopenia, leukopenia, anemia, and thrombocytopenia. And for the last abstract, it's about molecular biology, but with a frequent disease, a follicular lymphoma. They try to understand the difference in the genetic profile of the different subtype of follicular lymphoma, and try to understand if there is an impact on the prognosis. So this study analyzed the clinical data from 831 patients, whole exome sequencing from 149 patients, and transcriptome sequencing from 63 patients to explore differences among follicular lymphoma type 1, 2, follicular lymphoma 3A, follicular lymphoma 3B, and follicular lymphoma DLBCL. And as we know, the treatment also of follicular lymphoma 3B and follicular lymphoma /DLBCL is different than the first 3 follicular lymphoma 1, 2, and follicular lymphoma 3A. So clinical analysis revealed 2 distinct groups of patients: an indolent group, follicular lymphoma 1, 2, and follicular lymphoma 3A, with favorable prognosis, and an aggressive group for the follicular lymphoma 3B and the follicular lymphoma DLBCL, characterized by poor prognosis. So this is to repeat what we said initially, and we see the difference in terms of overall survival between the different subgroup of follicular lymphoma, and also progression-free survival with a better profile for the follicular lymphoma 1, 2, and 3A, and less and reduced PFS and OS for the follicular lymphoma 3B and the follicular lymphoma DLBCL. So the genetic landscape depicted by WES distinguish follicular lymphoma and follicular lymphoma DLBCL into two independent biological entities, the follicular lymphoma 1, 3A group and the follicular lymphoma 3B combined with the follicular lymphoma DLBCL group. The difference between the follicular lymphoma 1, 2, and follicular lymphoma 3A appear to be more related to the tumor microenvironment than the genetic profile. And from the perspective of clinical presentation, genetic variation and the tumor microenvironment, follicular lymphoma 3B and follicular lymphoma DLBCL cannot be clearly differentiated. This was my last slide, and thank you.
Hello, thank you for having me at this ESMO Together. Dr. Ghosn, thank you very much. So I'm going to be sharing with you the latest on the immunotherapy combinations with Opdivo in non-small cell lung cancer, the latest from ESMO. So we know that lung cancer is still a very heavy disease burden on our societies, whether it's in the United States, Japan, EU, and also in the Middle East and in Lebanon. Around 48% of these cancers we diagnose as stage 4, 24% stage 3, and 8% stage 2. The most current TNM classification has a very good correlation between patients' stage and 5-year overall survival. This is better than previous TNM classifications where there was a little bit of discordance between stage and survival, which led to the current TNM. So the current topic that I'm going to discuss is very interesting because we're looking at the era of immunotherapy, not only in metastatic disease, but also in early stage disease. So the first part of my topic is going to be about neoadjuvant and perioperative chemoimmunotherapy with Opdivo. And then the second part is going to be about dual immunotherapy in PD-L1 negative metastatic non-small cell lung cancer. And this is a population that needs new efficient therapies. So let me start with the first part, which is the era of neoadjuvant, meaning before surgery, and then perioperative chemoimmunotherapy, which means before surgery and after surgery. So the first part is Opdivo in neoadjuvant treatment for resectable non-small cell lung cancer, and this is really transforming the standard of care for these patients. The theory behind this is that giving neoadjuvant immunotherapy with chemo while the cancer is in place will elicit a more robust anti-cancer immune response because of the high antigen load. And it will do it better than doing it after surgery where there's only microscopic disease. And then the second part is that the neoadjuvant immunotherapy can help make the surgery more efficient and more clean. So the Checkmate 816 study randomized patients into two groups, two arms. Those patients were stratified by stages, obviously. They started with stage 1B until stage 3A, stratified by PD-L1, negative versus positive. And the patients received chemotherapy with Opdivo every 3 weeks for 3 cycles in the first arm. And then the second arm, chemotherapy alone. And then they had imaging and they went for surgery. So this is just pure neoadjuvant. You can look at the patient populations later. I can share my slides with you, but basically just very well balanced patient populations, North America, Europe, Asia, in terms of stages, in terms of histology between non-squamous and squamous, PD-L1 negative and positive. So the first thing to get out of this study is the median EFS, which was significantly superior in the chemotherapy arm, 59%, chemo plus Opdivo, 59% versus 21% with chemotherapy alone. The 5-year EFS was 49% with Opdivo versus 34% with chemo alone. When you look at EFS based on stage 1 and B and 2 had a significant improvement with Opdivo, but it was mostly stages 3 that had the most significant improvement, a jump at 24 months from 38% to 63%. So very, very significant improvements here, almost double EFS. EFS was also improved regardless of PD-L1. So it was improved in PD-L1 negative, and it was improved in PD-L1 positive disease. But obviously in PD-L1 positive disease, the jump, the improvement in EFS was much more significant, and there's a better widening and separation of the curves. And this is because we know that PD-L1 negative tumors are immunotherapy cold tumors that need something else. We will see this later in the part with metastatic disease and dual immunotherapy. And the final analysis, overall survival was also improved in the Opdivo arm, 65% at 5 years versus 55% in the chemotherapy alone arm. The median overall survival for Opdivo and chemo was not reached. When you look at overall survival by stage, as we saw with EFS, there's an improvement in both stages 1B and 2 and in stage 3. However, the improvement is always better in stage 3. There's a much wider improvement. Same thing with PD-L1. Median overall survival with PD-L1 negative not reached compared to 61 months in the chemo arm, but in PD-L1 positive, the improvement is even more significant. And you can see here at 5 years, 78% versus 58%. So much better numbers with PD-L1 positive disease. This is just to show you that the improvements in median overall survival were actually positive across all subgroups in the study. Now, what I want to point out and stress in this study, and this is the most interesting point in the study for me, was that nearly 100% 5-year overall survival if you achieve a PCR. So you're giving chemotherapy here in a neoadjuvant manner, and then you're going to surgery. And if this patient who had surgery had a complete pathologic response, they have almost 90 to 100% 5-year overall survival. So you're able to tell your patient in clinic, and this is groundbreaking, when you see them in the clinic after surgery, if they had a PCR, you can tell them that they almost have 95 to 100% 5-year overall survival. So how deep was the PCR in this study? In patients who ended up going to resection, patients who had Opdivo plus chemotherapy had 30% complete pathologic response rates compared to 3% only in the chemotherapy arm, so 10 times more. And this is very, very significant results. PCR was improved across subgroups in the Opdivo arm, across stages, 40% in stage 1B, 23% in stage 3. Patients who did not have a PCR, we have major pathologic response rates, also significantly improved in the Opdivo arm, 47% here compared to 12% with chemotherapy alone. So very significant differences. The lung cancer specific survival is very interesting to see because I will compare it later to the lung cancer specific survival in the next trial that we will discuss. So this lung cancer specific survival in this trial at 5 years was 75% in the Opdivo arm compared to 65% in the chemo arm. So significant improvement. Time to death or distant mets was also significantly improved in the Opdivo neoadjuvant arm. In terms of adverse events, the autoimmune adverse events, those were very mild and were usually grade 1 and 2, very few grade 3 and 4, and it was very unusual to discontinue treatment due to an autoimmune reaction. So you're using single agent Opdivo in terms of immunotherapy, Opdivo plus chemo, so you're not going to have major toxicity like with dual immunotherapy. So in summary, in this checkmate, in the checkmate 816, there was a significant improvement and benefit from adding Opdivo to your neoadjuvant. Improved 5-year overall survival rates. You have improved pathologic complete response rates, which correlated with a 90 to 100% overall survival at 5 years after surgery. So these are really amazing numbers. And this trial and those results are going to be basically the preclude to jump to perioperative treatment. So using Opdivo not just in the neoadjuvant setting, but in the perioperative to continue Opdivo after surgery. So this is where we go with this study, the Checkmate 77T, and this is a phase 3 study that separated the patients into 2 different arms. The first arm, Opdivo plus platinum doublet chemotherapy for 4 cycles, followed by surgery, followed by maintenance Opdivo for 1 year, or adjuvant Opdivo for 1 year. And the second arm had chemotherapy plus placebo and neoadjuvant, followed by surgery, then followed by placebo for 1 year. So the patients were stages 2A until stage 3B. They were stratified by histology, squamous cell, non-squamous cell, disease stage, and PD-L1 levels. So baseline characteristics, very similar to the Checkmate 816 trial, very balanced populations. And this is just to tell you how many patients ended up getting the whole treatment. The surgical outcomes, most patients had lobectomies. So the extent of resection was lobectomy in 80 and 72%, respectively, in the neoadjuvant immuno and placebo plus chemo arm. Pneumonectomies around 9 to 14%. R0 resection around 90% in both, and R1, R2 around 10% in both. So what do we see in terms of results? Again, this is going to be very similar because now we're looking at the neoadjuvant portion. So very similar to Checkmate 816, significant improvement in event-free survival across subgroups, significant improvement in pathologic complete response rates. This is just replicating and duplicating the results that we had in the previous study, Checkmate. You're not going to see anything different up to here because then we're going to move to the adjuvant arm. So when you look at the adjuvant, continuing with the adjuvant treatment, the EFS is significantly improved in Opdivo, in the Opdivo plus chemotherapy neoadjuvant and adjuvant arm compared to the chemotherapy with a placebo arm. A median EFS not reached with Opdivo versus 35 months with chemo placebo. Patients who had no adjuvant treatment had definitely much lower number, but obviously did much better also when they received Opdivo. But you can see here the comparison. If you do the adjuvant treatment, it's much better than just doing neoadjuvant. So you have to do your neoadjuvant, you have to go for surgery, and then you have to continue with adjuvant Opdivo chemotherapy. Let's look at lung cancer specific survival. So in Checkmate 77T, for these patients who received neoadjuvant and then surgery and then adjuvant, they had a 5-year 87% lung cancer specific survival. If we compare this to Checkmate 816 that we previously saw, it was 75% versus 65% Opdivo versus chemotherapy. Here it's 87% versus 75%. So here the benefit of adjuvant therapy also is very, very clear. In terms of safety summary across study phases, it was very balanced actually between the placebo arm and the immunotherapy arm. In the neoadjuvant period and the adjuvant period, very, very similar numbers. So no increased toxicity from adding immunotherapy to the chemo. The immune-mediated adverse events, again, were very mild, usually grade 1, 2. Especially the higher rate here is what we know how to manage very well, is hypothyroidism and thyroiditis. But discontinuation of treatment was extremely rare due to these events. So in summary, This study shows us that neoadjuvant Opdivo and chemo, followed by surgery and adjuvant Opdivo, showed statistically significant improvement in EFS and in other parameters like death from the and this is the first phase 3 study to show us this in the perioperative study. So I'm going to move now to the second part of my talk, and this is a niche population that has the PD-L1 negative metastatic non-small cell lung cancer, and these patients are considered a population that needs new treatments, new efficient treatments. So we're going to explore the potential of dual immunotherapy in these patients. And in 2025, our IO strategy is usually the following. If a patient has a PD-L1 50% or more, we usually give them immunotherapy alone, monotherapy, but some patients it's still reasonable to give them, if they have like a visceral crisis, still reasonable to give them chemotherapy plus IO, at least for the first 2 cycles. For someone who has a PD-L1 of 1 to 49%, they usually end up receiving chemo plus immunotherapy, but it's still reasonable to give some of these patients immunotherapy alone if they cannot tolerate chemo, for example. And in patients who have a negative PD-L1, less than 1%, they usually receive chemotherapy plus IO, and some of these patients receive chemotherapy alone. And in these patients, the PD-L1 negative, this is the population that we're going to look at now, it's reasonable to add CTLA-4 inhibitors, particularly for this population. So double immunotherapy for these patients, because these are patients that are considered to be immunologically cold. They have low response to Opdivo single agent, to PD-L1 blockade. And the theory is that by giving them ipilimumab, it will help activate and proliferate cytotoxic T cells. And this will help nivolumab work better by discovering the tumor cells and by activating the immune system. So this is where the CM9LA study came in. And this is a landmark randomized phase 3 trial that compared 2 different arms. The first arm, double immunotherapy, Opdivo-Yervoy, Opdivo with ipilimumab, plus chemotherapy for the first 2 cycles. And they give chemotherapy for the first 2 cycles to avoid the small percentage of patients. There's often in these double immunotherapy trials, there's increased death at the beginning of the trial for patients who receive double immunotherapy without chemo. So they gave chemotherapy for the first 2 cycles with Opdivo-Yervoy, and then followed by Opdivo-Yervoy alone every 6 weeks. Opdivo every 3, and then Yervoy every 6. The second arm was doublet chemotherapy every 3 weeks. So key eligibility criteria for this study was stage 4 or recurrent non-small cell lung cancer, and the patients were stratified by histology, squamous versus non-squamous, and we'll look at the differences, and then PD-L1 positive or negative. So overall survival, significant improvement in overall survival from the beginning of the trial till the plateau. So you have a median overall survival of 16 months in the Nivo-Ipi arm, Nivo-Ipi plus chemo, versus 11 months in the chemo arm. The 6-year overall survival rate was 16% in the immunotherapy arm compared to 10% in the chemotherapy alone arm. The improvements were positive across subgroups, except for patients who were older than 75 years old. They seem to have possibly worse toxicity, leading to worse overall survival. When we look at subgroups in terms of histology, there's a significant improvement in the immunotherapy arm in the squamous cell population and also in the non-squamous population. But what I want to show you here very interestingly is, if you look at in green, I added these arrows in green. If you look at the chemotherapy alone arm, these patients do much worse when they have squamous cell carcinoma than when they have non-squamous cell carcinoma, which can be treated with pemetrexed and Avastin. However, when you add double immunotherapy into the mix, look here in red at the blue curves, they become identical between squamous and non-squamous. So this is telling you that double immune therapy is able to overcome histology. And here you have no difference anymore between squamous cell and non-squamous cell. You can see the same in PD-L1, and it's very important to see that in this PD-L1 negative population, the significant improvement in the immunotherapy arm compared to the chemotherapy alone arm. When you combine PD-L1 expression and histology, you get the same thing. Much worse if you're squamous cell and PD-L1 negative, much worse than if you're PD-L1 negative and non-squamous. But again, immunotherapy can overcome this, and a significant improvement in the double immunotherapy arms. In terms of duration of response, 19%, so close to 20% at 6 years, so very significant numbers. You have a plateau here with double immunotherapy, which is great. And when you look at duration of response by subgroups, if you look at the PD-L1 negative, the duration of response with chemotherapy alone is dismal. And you can see how this is significantly improved when you add double immunotherapy over here. So the overall survival was significantly improved across different subgroups and different molecular types. And what is even more striking, and we know this from melanoma trials, double immunotherapy, even in patients who discontinued due to autoimmune adverse events, these patients, it did not negatively impact their 6-year overall survival. So even patients who had severe side effects from autoimmune reactions and had to start the dual immunotherapy actually did a little bit better than patients who continued to be on nivolumab, ipilimumab. And this is very reassuring for these patients who have to stop treatment because of severe toxicity, that their immune system is so ramped up that stopping the treatment will not impact their overall survival. Beautiful numbers. In terms of the safety of treatment, obviously with double immune therapy, you're going to have more autoimmune reactions than with single agent nivolumab, and you have some grade 3 autoimmune reactions. There were no deaths related to autoimmune reactions in the study at 6 years, but there were some patients who discontinued treatment, and as I showed you, they did not lose the benefit from their treatment. So the most common side effects, obviously, we have rash, we have colitis in grade 3, and some of the grade 4. We have pneumonitis, we have thyroidism, so the usual suspects. So in conclusion, at a 6-year follow-up, CheckMate 9LA continued to show long-term durable efficacy benefit with double immunotherapy, Opdivo, Yervoy, and chemo versus chemo alone. In these patients with tumor PD-L1 expression less than 1% or squamous cell histology, and this is the patient that really needed new treatments because of their dismal response rates and overall survivals. And this was true across subgroups, a significant survivorship at 5 years. And this should be considered the first-line treatment of choice for this small patient population that is PD-L1 negative and squamous cell. Thank you very much, and I'm open for questions.
Good afternoon. I will share with you 2 abstracts concerning bladder cancer that were presented at the Presidential Symposium, both of them. And both of them are very important to be some kind of practice changing. The first one is a very interesting one. It's dedicated to early stage muscle invasive bladder cancer, where the combination of enfortumab vedotin EV plus pembro was used as a peri-surgery procedure in muscle invasive bladder cancer. and in the category of patients who are cisplatin ineligible. So we know that around 50% of patients with muscle-invasive bladder cancer are cisplatin ineligible, so they don't benefit from neoadjuvant chemotherapy, and the practical classical strategy is to go immediately to radical cystectomy plus retroperitoneal lymph node dissection. So in this category of patients, we have an unmet need to give neoadjuvant or peri-surgery treatment. So this study is a randomized open-label phase 3 Keynote 905, called also EV303, which compared the perioperative EV plus Pembro with radical cystectomy compared to radical cystectomy alone in muscle-invasive bladder cancer who are not fit or who did not who refuse cisplatin chemotherapy. So this is the study design. As I said, the eligibility criteria are muscle-invasive bladder cancer with advanced stage T2, T4, or N-positive patient, and these patients are cisplatin ineligible per Galsky criteria or cisplatin declining. And you look to the right of the screen, we have 3 arms. Forget about the first arm concerning Pembro alone, pre and post-surgery, because this arm was closed. So the randomization was done between cystectomy immediately, the red one, compared to the experimental arm. We give 3 cycles of EV plus Pembro, EV day 1, day 8, Pembro day 1, to be repeated 3 times, then the radical cystectomy, followed by maintenance or adjuvant enfortumab vedotin for 6 cycles and Pembro for 14 cycles. This is the distribution of the patient. 344 patients were included, 170 patients in the experimental arm, 174 in the control arm. The patients who get the cystectomy were 149 in the experimental and 156 in the immediate cystectomy arm. And here are the patient characteristics. They were well balanced between the 2 arms, but we have to say that we have in this study a real life characteristics of patients, since we have PS2 in almost 12 to 14% of the patient in both arms. And concerning the cisplatin eligibility, the reason was ineligibility because of Galsky's criteria in 83, around 80% in each arm. And also among the disease stage, we have around 78 or 75% of patients who are T3, T4, and for those who are N1, around 5%. And here is the primary objective of the study, the EFS. We have a significant difference between the 2 arms, where at 2 years we have 74% of patients who didn't relapse among those who have the adjuvant and neoadjuvant EV plus P, compared to patients who get immediate cystectomy with a EFS of 39%. If we look to the right, we have the median EFS in the experimental arm not reached, compared to 15% or 15 months concerning the patient who get cystectomy immediately and observation. And here is the forest plot concerning the characteristics of patients. And here we have a consistent benefit in all these patients in favor of the experimental arm. And for the secondary endpoint, which is overall survival, also the study was positive in favor of EV plus P and showed a median overall survival not reached in the EV plus Pembro arm, compared to 41% in the control arm, with a hazard ratio of 0.5. And also the forest plot was tested in the overall survival and all the category of patient concerning platinum eligibility, the PDL1, the tumor size, the creatinine clearance. All these characteristics are in favor of the experimental arm, in favor of EV plus pembro, neoadjuvant, and adjuvant. And concerning the pathological complete response, which is also a secondary endpoint, it was in favor of the EV plus P arm. And here we have 57% pathological complete response at cystectomy compared to 8.6% in the control arm. Concerning the side effect, obviously we have more side effect in the EV plus P arm, but these side effects are exactly copying our experience with this combination. And if we look to the adverse event leading to surgery delay, we have here almost a small percentage. So there was no true side effect from EV plus P behind any delay in the surgery. And here we compare the toxicity of both arms. Certainly in the EV pembro, we have more side effects. These side effects could be related to the immune toxicity of the immunotherapy or to the ADC toxicity of EV. And here we have also a comparison concerning the surgery itself. When we get the surgery, the cystectomy, all the arms have almost the same toxicity, both arms. And here, if we split the toxicity between the toxicity of pembro, the immune-related toxicity, and the other toxicity related to the EV, we have almost what we know about the experience of these both drugs. So in conclusion, according to the authors, and it was appreciated by all the attendees, that the perioperative EV plus pembro added to radical cystectomy may represent a new standard of care in this population who are not fit to get cisplatin as neoadjuvant. This is the first one. Now I move to the second presentation. The second presentation, it was presented by Chinese authors. It's also an interesting one, but dedicated to first-line metastatic bladder cancer. There was a combination of disitamab vedotin, the ADC, targeting ERBB2, plus toripalimab. Toripalimab is an anti-PD-1. So we have a combination DV plus T compared to chemotherapy in first-line metastatic bladder cancer in patients who have tumor expressing at HER2. So here in the introduction, the author said that the majority, almost 70% of metastatic bladder cancer express by immunohistochemistry the ERBB2. In fact, even if it was 1+, 2+, or 3+, these patients are included in this study. So this is the design of the study. Patients are all metastatic. They have HER2 immunohistochemistry +1, +2, +3 with measurable disease, eligible for platinum, either cisplat or carboplatin, and they were randomized 1:1, 242 who get the DV plus T, and 241 who get the cisplatin plus or carboplatin plus gemcitabine. The primary endpoint were PFS and overall survival, and the secondary endpoint are the PFS, duration of response, and quality of life. Here are the repartition or the distribution of patients: 811 screened, 243 in the experimental arm compared to 141. And the patient characteristics are well balanced. For instance, we have something not usual, but it was mentioned by the author that the percentage of upper tract urothelial tumor was high. There was almost 50% of included patient in each arm with UTAC. So we don't know why we have this observation. And for the HER2 expression, 1+ in almost 22% in both arms, and for the 2+, 3+, it was 77 to 78%. And here is the primary endpoint, the PFS. It was clearly positive in favor of DV plus T, with a hazard ratio of 0.36, and the median EFS in the DV plus T arm was 13 months, almost double, compared to the chemotherapy arm. And for the forest blood distribution, the benefit was consistent with the DV plus T arm in all the characteristics of patient, including HER2, including the performance status, and the tumor localization. And here we have the difference in pathological complete response. It was significantly in favor of the DV plus T arm compared to chemotherapy, 76.1% compared to 50% when it was defined by an independent committee. And now concerning the subsequent treatment, it's obvious that the anti-HER2 therapy was higher in patients who progressed after chemotherapy. Also, there was PD-L1 chemotherapy or combined chemotherapy in the arm of chemotherapy. And if we look to the safety of the disease, there is certainly the known toxicity of chemotherapy, and also in the experimental arm, the known toxicities of ADC and of immunotherapy. However, if we look to the right, the grade 3, we have almost 55% of toxicity in the experimental arm compared to 86 with the chemotherapy arm. So as conclusion, and according to the Chinese authors, we have a great PFS. The overall survival increased from 16.9 months to 31.5 months in these patients. And they said that DV plus T offers a valuable new treatment option and represent a potential new standard of care for the first-line treatment of patients with HER2 positive, with HER2 expressing locally advanced or metastatic urothelial cancer. And thank you for your attention.
Hello, this is Dr. Deborah Mukherjee, Consultant Medical Oncologist at the Clemenceau Medical Center, and I'm sorry I can't join you in person, but it's a great pleasure to be able to discuss these two abstracts, both presented at the ESMO 2025 meeting this year. The first one was presented at the presidential session. This was the PSMA addition trial, looking at the addition of lutetium PSMA to an ARPI plus ADT in patients with metastatic hormone-sensitive prostate cancer. So this is the background, that we already have lutetium PSMA approved in patients with metastatic castration-resistant prostate cancer, both before and after taxane chemotherapy. So this is the first phase 3 trial looking at the addition of PSMA theranostic treatment in patients with metastatic hormone-sensitive disease. This was the study design. Patients had to be untreated or minimally treated for HSPC. They had to have more than one or more PSMA positive metastatic lesion on their PET scan, and appropriate for the combination of an ADT plus an ARPI. And this was randomized to the standard arm, ADT plus ARPI, plus 6 cycles of lutetium PSMA. The primary endpoint was radiographic progression-free survival, and importantly, crossover was allowed. These are the patients who were well distributed and balanced between both arms. The majority of patients had high volume disease, and again around 50% of patients had de novo metastatic prostate cancer. This was the primary endpoint of the study, which was positive. The radiographic progression-free survival median had not been reached in either arm, but there was a hazard ratio of 0.72 in favour of the lutetium PSMA arm. The PFS benefit was consistent among the subgroups, including the de novo or recurrent disease, high and low tumour volume, and the performance status of the patients. The interim overall survival looked similar. This is an intention to treat analysis, and again we do know that there was crossover, so this may impact the final survival results. These are selected other secondary endpoints, including best response as per RECIST, time to PSA progression, which was significant in the experimental arm, time to metastatic CRPC, and time to symptomatic skeletal-related event. If we look at adverse events, again, any adverse events were quite similar between the two arms. If we look at adverse events related to lutetium PSMA treatment specifically, at grade 3 or above, these were just about 14% in the experimental arm. And if we look at other findings such as dry mouth, nausea, other things that we might think could be associated with lutetium PSMA, these were generally low grade. And we do get concerned about cytopenias when we're treating earlier in disease, and the incidence of grade 3 or above cytopenias was around 14%, with anemia, neutropenia, and a very low incidence of significant thrombocytopenia. Time to worsening pain or pain intensity was similar between the two arms. We did see that in the experimental arm there was a slight decrease in all measured quality of life by the FATP total score. This was not significantly decreased, but it was decreased compared to the control arm. So the conclusions of the authors were that PSMA addition leads to a statistically significant improvement in radiographic progression-free survival when added to ADT plus ARPI in patients with metastatic hormone-sensitive prostate cancer. There was a positive trend to overall survival, data are maturing, PSA decreases, PFS, time to metastatic CRPC, and skeletal-related events favoured the lutetium PSMA combination arm. Safety profile was consistent with the known profile of lutetium PSMA, and AEs were more frequent, commonly dry mouth, fatigue, and nausea. They mentioned that the differences in worsening to health-related quality of life and pain were not statistically significant or clinically significant, and their conclusions were that combining lutetium PSMA with ADT and an ARPI provides clinical meaningful benefit in patients with PSMA-positive metastatic hormone-sensitive prostate cancer. So this is obviously very exciting data. There was a fantastic discussion by Dr. Aaron Azad from Australia, and these were his concluding thoughts that PSMA addition is the first randomized phase 3 trial demonstrating the efficacy of lutetium PSMA in metastatic hormone-sensitive prostate cancer. The RPFS benefit may lead to regulatory approval, but there were no improvements in overall survival, and we may not expect them because of the crossover, and the quality of life was numerically lower. So the goal of any cancer treatment is to make patients live longer and live better, and his opinion this was not achieved in PSMA addition, and he would not recommend widespread use of lutetium PSMA at this stage, but definitely he did have a very good discussion about the volume of disease and the PSMA uptake on the scans, using PSMA SUV mean and or total tumour volume to help select those patients that really may benefit more from this treatment. And he mentioned his concerns about patient selection, over treatment and toxicity. So lutetium PSMA 617 remains an active and approved agent for metastatic CRPC, but to give the best outcomes we definitely need a patient-centered approach, focusing on identifying predictive biomarkers avoiding overtreatment and minimizing late toxicities. So moving forward to a biomarker-directed approach in metastatic hormone-sensitive prostate cancer, this is the second abstract that I'll discuss, which was presented at the profit-paid session for prostate cancer. This is the phase 3 study, the CAPItello 281, capivasertib plus abiraterone versus placebo plus abiraterone in patients with PTEN deficient de novo metastatic hormone-sensitive prostate cancer. So we know that PTEN deficiency in prostate cancer is a key driver of disease, and it is in AR and AR signaling. So this is one of the most important drivers, along with the AR signaling, of tumour development. In PTEN deficient tumours, we have additional proliferative drive from this PI3 kinase pathway, and PTEN deficiency is known to be associated with poor prognosis. Capivasertib is a potent and selective inhibitor of all 3 AKT isoforms, and we have preliminary data that showed benefits in subsets of patients with an alternative PI3K inhibitor, ipatasertib, in patients with PTEN deficient metastatic castration-resistant prostate cancer. So this is the study design. Patients with PTEN deficient de novo hormone-sensitive prostate cancer, the cutoff was more than 90% of viable malignant cells with no staining by IHC, and they randomized patients to capivasertib plus abiraterone and prednisolone plus ADT versus placebo plus abiraterone, prednisolone plus ADT, and the primary endpoint was investigator-assessed PFS. These were the baseline characteristics, which were balanced between the 2 arms. Remember, these were all de novo metastatic disease. The majority, again, were high volume. The primary endpoint was met, and in the experimental arm, the median radiographic progression-free survival was 33.2 versus 25.7 months, with a p-value of 0.81, with a 7.5-month improvement numerically in the arm receiving the AKT inhibitor. This was the forest plot, seeing that all the subgroups were benefiting from the addition of the therapy. And interestingly, the key secondary elements, secondary endpoints were tested according to the hierarchical procedure, but most of these were borderline in terms of their significance. So there's still maturing of the data to do before we see things like survival analysis and secondary endpoints such as time to second treatment progression. This is the interim overall survival analysis, and again the data are immature with a hazard ratio of 0.90. Time to skeletal event in terms of skeletal event-free survival was prolonged in the experimental arm, 42.5 months versus 37.3 months. And again, time to castration resistance was also prolonged in the experimental arm. Time to PSA progression was not significantly improved, but there was a numerical improvement in terms of time to PSA progression. So interestingly, and this was brought out by the discussant, Dr. Elena Castro, there did appear to be an increasing efficacy of the experimental combination with a increase in PTEN deficiency. So the patients who had 100% PTEN loss did better than the patients who had 90% PTEN loss. And so this is the gradient which is supporting the biological rationale that the extremely PTEN deficient tumours benefit more from AKT inhibition rather than relying on the androgen receptor signaling pathway for growth and proliferation. And these were the subgroups according to P10 by investigator-assessed radiographic-free survival, and we see that there is a separation in those curves favouring the combination arm in those patients with 100% P10 loss. And indeed, overall survival was improved, favouring the combination arm, although this did not reach statistical significance even in the patients who had 100% P10 loss. The secondary endpoints, again, we see this, rationale that the more P10 loss, the better the outcomes with the combination. If we look at safety summary, these were as expected with this AKT inhibitor. There were increased grade 3 and above adverse events, and if we look at the ones leading to discontinuation of the combination, there were around 18% of patients who discontinued the combination due to adverse events. And these were mainly diarrhea, hyperglycemia, rash, anemia, hypokalemia. These are all the effects that we would anticipate with this class of treatment. So the conclusions of Dr. Fizazi were for patients with P10 deficient metastatic hormone sensitive prostate cancer, they have a poor prognosis and reduced benefit from current standards of care. This study met its primary objective, showing a statistically significant rPFS benefit with CAPI plus ABI, which was with a median radiographic progression-free survival of 33.2 months versus 27.5 months. We also observed improvement in secondary endpoints in clinically relevant predefined subgroups, and overall survival is immature. Post-hoc analysis indicated that increased P10 cutoffs showed greater treatment effect, and the common grade 3 or above adverse events of rash and hypoglycemia were expected with AKT inhibition. And he concluded with his view that capacisertib in combination with abiraterone presents a potential first-in-class targeted treatment for patients with P10 deficient metastatic hormone-sensitive prostate cancer. This was discussed very nicely by Dr. Elena Castro, whose conclusions are here, that this study confirms the poor prognosis of P10 deficient metastatic hormone-sensitive prostate cancer on ARPIs, suggesting a distinct pattern of progression, and alternative treatments or additional treatments are definitely required for these patients. The combination met its primary endpoint, but the magnitude of the benefit presented may not justify a change in practice today. This is her personal opinion, and predictive biomarkers are even more needed, so perhaps we need to really identify those completely P10 deficient tumours that are really relying on this pathway for growth. And we also need to think about other biomarkers through widespread NGS testing, which will need to be implemented into clinical practice, looking at HRR markers. We may need to do PET scans looking for PSMA positive high volume disease. So there are many factors that we now need to consider based on the data presented at ESMO this year. But adequate tissue sampling is definitely essential for biomarker-driven therapy decisions. Thank you very much. It's a great pleasure to speak with you today. We have a lot of data to digest, and I look forward to seeing you all in person very soon.
Hello, my name is Chris Labaki. Thank you for the opportunity to present today at the 6th ESMO Together 2025. I will be talking about renal cell carcinoma related abstracts presented at ESMO 2025. I will focus on two abstracts, the phase 3 RAMPART trial of adjuvant durvalumab and tremelimumab as compared to observation in the adjuvant setting in RCC, and the phase 2 LENCABO, which is a multi-center trial of lenvatinib and everolimus as compared to cabozantinib monotherapy in patients with metastatic clear cell RCC after treatment with PD-1 based immune checkpoint inhibition. Let's start with the RAMPART trial. So looking here directly at the study design, Patients with confirmed RCC that presented with a high or intermediate risk of relapse, as classified by the Leibovitz risk score, were enrolled in the study. Additionally, patients with fully resected synchronous ipsilateral adrenal metastasis or with a single fully resected soft tissue metastasis were also included in this trial. Patients were randomized in a 3:2:2 ratio into active monitoring in the first arm, durvalumab monotherapy for 1 year in the second arm, and durvalumab and tremelimumab combination therapy in the third arm. At ESMO 2025, the results comparing arm A of active monitoring to durvalumab and tremelimumab combination therapy were presented. In total, 565 patients were randomized into active monitoring and combination therapy. 340 underwent active monitoring, while 225 received durvalumab and tremelimumab in the adjuvant setting. Looking here at the baseline characteristics of the patients included in this trial, we can see notably that around 15% of patients presented with a non-clear cell histology. Looking here at the risk of relapse in both arms of active monitoring and dual therapy, around 45% of patients in each arm presented with an intermediate risk of relapse, while 50% presented with a high risk of relapse as classified by the Leibovitz score, and around 5% of patients in each arm presented with M1, no evidence of disease. Looking here at the results of the disease-free survival, which is the primary endpoint, in the intention to treat population, we can see a significant improvement in DFS in the dual combination arm of durvalumab and tremelimumab with a hazard ratio of 0.65, and at the median follow-up of 3 years, the 3-year DFS rate was 81% in the combination arm compared to 73% in the active monitoring arm. Looking here at an analysis of risk subgroups, and specifically talking here about intermediate and high risk subgroups in the study, we can see that it appears that most of the benefit was derived in the high risk subgroup. And specifically here, looking at the high risk subgroup in an individual way, in a pre-specified, pre-powered subgroup analysis, we can see a more significant benefit of the durvalumab and tremelimumab arm as compared to active monitoring with a hazard ratio of 0.52 and a 3-year DFS rate of 78% in the combination arm as compared to 61% in the active monitoring arm. While in the intermediate subgroup, no difference in DFS was observed between the two arms with a hazard ratio of 1.19 and a similar 3-year DFS rate of 86 to 87%. In terms of treatment exposure, around 23% of patients enrolled in the combination arm were able to complete the treatment as per protocol, meaning 2 infusions of tremelimumab and 13 infusions of durvalumab. And now in terms of safety summary in this trial, around 97% of patients in the combination arm experienced any grade adverse event, as compared to 63% in the active monitoring arm, and around 40% of patients experienced a grade 3 or more adverse event in the combination arm, as opposed to 8% in the active monitoring arm. Such differences were also seen in severe adverse events of any grade, that were reported in 34% of patients in the combination arm, as opposed to 6% of patients in the active monitoring arm. And looking here at the distribution or the characteristics of these adverse events, we can see when looking at the severe or grade 3 or more adverse events that the most frequent safety events observed were related to colitis, transaminitis, and renal impairment. In terms of quality of life, when comparing between baseline and month 15, there was no significant change in the overall health and quality of life among patients in the combination arm. And now, putting the results of the RAMPART trial obtained so far in relation to disease-free survival in comparison with other trials evaluating adjuvant immunotherapy in patients with kidney cancer, we can see that the RAMPART trial is the second trial that shows so far a significant improvement in the FS, along with Keynote 564 of adjuvant pembrolizumab, while all remaining trials of iMotion 010 of adjuvant atezolizumab, Checkmate 914 of adjuvant nivolumab, and adjuvant nivolumab in combination with ipilimumab did not show an improvement in DFS. Of note, Keynote 564 of adjuvant pembrolizumab has shown also an improvement in the overall survival. The results of overall survival regarding the RAMPART trial, in addition to the results of Arm B of the RAMPART trial of adjuvant durvalumab, are currently being awaited. Moving now to the second study of LENCABO, which is a randomized phase 2 trial of lenvatinib and everolimus versus cabozantinib in patients with metastatic clear cell RCC, previously treated and who have progressed on PD-1 immune checkpoint inhibition. Patients with metastatic clear cell RCC, previously treated with PD-1 or PD-L1 immune checkpoint inhibition, and who had received only 1 to 2 prior therapies were enrolled in this trial and randomized 1-to-1 to lenvatinib 80 mg daily with everolimus or cabozantinib at 60 mg daily. The primary endpoint of this study was the progression-free survival. Secondary endpoints were the response rate, safety, and overall survival. Looking here at the distribution of patients, overall 90 patients were randomized in the study. 40 patients received a combination of Len-Ev, while 46 patients were treated with cabozantinib. And looking here at the baseline characteristics of patients enrolled in this trial across treatment arms, and looking specifically at prior lines of therapy, we can see that around 67 to 73% of patients across each treatment arm in this trial received 1 prior line of therapy, while between 26 and 35% of patients received 2 lines of therapy. Looking at prior VEGF target therapy exposure, we can see that around 45% of patients in each treatment arm received prior VEGF target therapies, or a high percentage, between 55 and 58% of patients in each treatment arm that were not priorly exposed to VEGF target therapies. And also looking at the first line of systemic therapy administered in those patients, around 67 to 75% of patients received the combination of nivolumab and ipilimumab in the first line setting. 12% to 19% of patients received the combination of pembrolizumab and axitinib, and around 5% of patients were treated with adjuvant pembrolizumab. Looking here at the primary endpoint of progression-free survival in the primary analysis presented at ESMO 2025, we can see a significant difference with an improvement of progression-free survival with lenvatinib and everolimus combination as compared to cabozantinib monotherapy, with a median PFS of 15.7 months in the combination arm compared to 12.2 months in the monotherapy arm of cabozantinib, with a hazard ratio of 0.51. Of note, 62.5% of patients had in the Len-Ev arm had experienced progressive disease, as opposed to 76% in the cabozantinib arm. And here, looking at the secondary endpoint of overall response rate, we can see that in the Len-Ev arm, 52% of patients presented with a response as compared to 38% in the cabozantinib monotherapy arm. In regard to overall survival, results remain so far immature, with a median follow-up of 20 months. However, so far, no significant difference in outcomes regarding overall survival is identified. In terms of safety summary, we can see overall that serious or grade 3 or more adverse events were observed at a higher frequency in the lenvatinib and everolimus arm as compared to the cabozantinib treatment arm. and also a high rate of treatment discontinuation was identified among patients in the combination arm as compared to those in the cabozantinib therapy arm. Now, putting the context of treatments in this trial compared to other trials of cabozantinib monotherapy or Len-Av combination therapy, although not comparable, given different populations and different trials, we can see that both progression-free survival and overall response rate are both in line with prior experience. And in conclusion, this is a positive phase 2 trial. Although the overall survival data is immature so far, it demonstrates the efficacy of Len with Eve in ICI pre-treated patients with an improved PFS and response rate as compared to cabozantinib monotherapy. However, it's also associated with a higher toxicity compared to cabozantinib. And so this regimen can be considered in patients for whom the priority is for response and for whom the higher toxicity rate is acceptable. Thank you very much.
Hello again. I am pleased to present now a satellite symposium sponsored by MSD on belzutifan and the treatment of VHL-related tumors. As you know, belzutifan has been recently introduced to the Lebanese market, although I think that it has been introduced before to other markets in the region. And today I have the task to give you, after the introduction, a overview of belzutifan, a small overview of VHL disease, give you some results about the latest PARC 004 study and the latest PARC 005 study, which are two studies which are very important in the development of this drug. And at the end, I will give you some take-home messages. First of all, I would like you also to remind you all that hypoxia is very important in the development of cancer cells. And in fact, hypoxia-inducible factors, HIF, are transcription factors that facilitate hypoxia signaling. And as we know, we need oxygen supply, and this supply is critical to the functioning and the survival of cells. When oxygen demand exceeds supply, it leads to hypoxia. Tumor cell hypoxia is also associated with the stimulation of the process of the tumorigenic process. It induces a poor prognosis of these cancer cells, and more important, it induces resistance to radiation therapy and to chemotherapy. HIF subunits are high HIF-1 alpha and HIF-2 alpha drive the cellular response to hypoxia into the cells, and I will show it to you in the next few slides. And an increase of the expression of HIF-2 alpha has been observed in different cancer cell types and has been associated with poor prognosis of these cancer cells. As you see in this slide, HIF2 alpha is a key oncogenic driver in clear cell renal cell carcinoma, and this is the main interest of this presentation. And it is attributed to be present in 80 to 90% of these patients with renal cell carcinoma due to a deficiency of an underlying protein product of VHL, which is von Hippel-Lindau tumor suppressor gene. The deletion or the mutation in the VHL gene can result in VHL disease, and which is in general an autosomal dominant genetic condition, and the patients with this VHL disease might have benign or malignant tumor and cysts, and VHL disease may affect the brain, the spinal cord, the retina, the inner ear, the pancreas, the adrenal gland, the sympathetic ganglia paraganglioma, kidney, and this is important for us, and the epididymis. In renal cell carcinoma, HIF activation is regulated by hypoxia, and the VHL tumor suppressor gene and the oncogenic signaling pathways such as MAPK, RAS, MNK, NPY3K, AKT are present in this activation, and in preclinical mouse models of renal cell carcinoma, HIF2 alpha inhibition demonstrated a significant tumor regression. I promise you, this is the last slide complicated like this one. So you can see in this slide also that HIF2 alpha can be used as a novel target for modulating HIF2 alpha, VEGF, and VEGFR axis. It's very important. It has a unique biology mechanism of action and a safety profile. So let's go and speak a little bit about belzutifan. So belzutifan was developed and discovered as a small molecule in 2009. It is a small molecule. It binds to the inner pocket of HIF2 alpha, and it disrupts its interaction with HIF1 alpha. And if there is anything that you need to know and to remember about this drug, is that it disrupts the interaction between the HIF2 alpha and the HIF1 beta, and it is enough to block the development and the pathogenesis of new cancer cells. As you see here, it is belzutifan is selectively and potently binds to HIF2 alpha, as you see it inside the cell, the HIF2 alpha inside the cell, and it blocks its interaction with the HIF1 alpha. And the HIF1 alpha is responsible for the proliferation, survival, metastasis, and angiogenesis. What is the difference between belzutifan and, for example, bevacizumab, and, for example, other VEGFR TKIs? All of them will have an action on the angiogenesis, but only belzutifan will have a decrease in the glucose metabolism of the cancer cells. It impacts on the cell migration of the cancer cells. It impacts on the VEGF production of the cancer cells. It impacts on the nutrient uptake of the cancer cells. It impacts on the de-differentiation of the cancer cells. And at the end, it impacts on the cell proliferation. VHL disease, it comes in multiple places. You can have hemangioblastoma, pheochromocytoma. It acts in the kidney, and we have clear cell renal cell carcinoma. We have NET tumors, mainly in pancreas, retinal, angioma, and other diseases. I will not go in all these diseases, but you need to know that this drug has been developed and this drug has been tried and tested in those diseases. You will see some of the results of the tests which was done for these diseases, and in fact for these patients who have a genetic disease, in fact and indeed this could be a very active drug. And this is the LITESPARK-004 phase 2 study, where multiple of diseases and neoplasms who expresses the von Hippel-Lindau disease were included, including the renal cell carcinoma. And this was a phase 2 trial. So for the part of renal cell carcinoma, the key inclusion criteria of the 61 patients who were included in this trial were that they needed to have a diagnosis of VHL disease based on germline alteration. They needed to have, of course, this is the part of renal cell carcinoma, at least one tumor and target of renal cell carcinoma tumor. They didn't need to have metastatic disease outside the renal cell. They needed to be in a good performance status, and patients shouldn't have been treated by any treatment. So these patients were treatment naive. And the assessment of the results were at screening and every 12 weeks, and patients were followed up for a minimum of 3 years. So these patients were treated. The median follow-up was 37.8 months. Some of these patients discontinued their treatment. Some of these patients discontinued their treatment. And in fact, only 38 patients are ongoing patients. If you see, as you see in this waterfall plot, the majority of the patients had some kind of response. In fact, 64% of the patients did respond, either by small number complete response or the majority by a partial response or a stabilization of the disease. And the median time to response was very long. It was nearly 11 months. And the duration of response was also very long, ranging to 35.8 months. So this is the duration of the treatment for the patients with renal cell carcinoma associated with VHL. As you see in this cartoon, the swimming cartoon, you see that patients were still responding and under treatment for a long period of time. And if we look in other diseases associated with VHL, like PNET and CNS and retinal hemangioblastoma, you will see the same kind of waterfall slides that we have seen in the renal cell carcinoma, with overall response rate which are very high, nearly 50% in hemangioblastoma and nearly 91% in pancreatic NET. So this is a very potent drug when you are dealing with this kind of mutation. And patients were able to get some kind of surgery after their response. And in fact, nearly all the diseases where the patients had this VHL disease and different localization and were under treatment, a certain number of patients were able to get surgery and to get rid of their tumors. And it included renal cell carcinoma, pancreatic PNET, CNS localizations, adrenal localization, retinal localization, and epidermal cysts. And even some patients had more than one surgery over the years. What was the safety profile of this drug? In dark green, you have the grade 3-4, which were usually very mild, as you see, anemia and fatigue, dyspnea and myalgia, less than 10% of anemia, less than 5% of fatigue, and merely 1 or 2% dyspnea or myalgia. So this drug was relatively well tolerated. In conclusion, for this first part of the presentation, when we are dealing with VHL disease in general, VHL disease is a rare genetic disease where patients are prone to develop multiple tumors, and usually they require repeated surgeries across their lifetime, and there are no approved systematic treatments available that target the underlying pathology. Belzutifan is the first continuous systemic treatment for localized VHL disease to demonstrate clinically meaningful and durable responses in patients not requiring immediate surgery. By reducing the tumor growth rate, belzutifan had the potential to reduce the risk of and or delaying the time to surgeries, to preserve organ function, and to decrease the risk of surgery-related complications. Belzutifan is indicated for the treatments of adult patients with von Hippel-Lindau disease who require therapy for associated renal cell carcinoma, central nervous system, hemangioblastoma, or pancreatic neuroendocrine tumor, and for whom localized procedures are unsuitable or undesirable. So let's come today to the best part of the presentation, the part which interests us, all of us. What is the role of belzutifan in the treatment of renal cell carcinoma? This is a small diagram for the treatment, the classical and the current treatment of metastatic renal cell carcinoma. As you know, our patient is classified as favorable risk or intermediate risk. And according to this classification, they are able to receive either a combination of immunotherapy alone or a combination of immunotherapy with any TKI, mainly lenvatinib, axitinib, or cabozantinib. And among the immunotherapies which are used is either the combination of ipi-nivo or the combination of either nivo or pembro with any of the other TKIs are present. But what to do when the patient progresses? When a patient progresses after a first-line treatment, usually if the patient received immunotherapy, we will rechallenge them. We will salvage them with a TKI or a TKI-based treatment. And if the patient, if any, have been treated exclusively with oral TKI, we will go and give them immunotherapy. So this is the classical treatment, and this is the classical algorithm for our patient. What did belzutifan do in this algorithm? In order to introduce belzutifan in the treatment of our patient, so last year in Barcelona, 2024, the LifeSpark 005 study, which was a phase 3 trial study of belzutifan versus a classical second or third line, a classical third line treatment, which is everolimus. As you know, before the era of immunotherapy, we had everolimus, and we were treating our patient first line treatment with TKI and second line treatment with everolimus. And currently, everolimus is usually tried alone or in association in second or third line treatment. So in this phase 3 trial, our newcomer, the belzutifan, was compared to everolimus. And these were the key eligibility criteria for our patients. They should have unresectable, locally advanced or metastatic clear cell renal cell carcinoma. Of course, they should have disease progression of at least one, and after one or even up to 3 prior systemic regimens, and they should have included in their treatments at least one time an anti-PD-L1 and one time an anti-VEGFR TKI. And the Karnofsky status of the patient should be good. It was a fairly good number of patients, more than 700 patients, equally stratified between belzutifan and everolimus. Please note the dose of everolimus. It was a 10 milligram orally daily, which is the high dose of everolimus. Of course, patients were stratified according to their prognosis factor. PFS was a primary endpoint as well as overall survival. There were some key secondary endpoints, including overall response rate and the duration of response, as well as the safety criteria. These are the demographics of the baseline of the patients. As you see, patients were equally distributed between the two categories. Please note that there were around 10% of the patients with sarcomatoid features. These are the patients with the poorest prognosis. 50% of the patients received at least one prior TKI, and 50% of the patients received even 2 or 3 TKI. And the patients, only 12% of 10 to 15% of the patients only received one line of treatment. The big majority, 85% of the patients received minimum 2 or 3 lines of treatments before. So these patients were really heavily pre-treatment by the classical means of the treatment. As you look at the first endpoint, which is primary progression-free survival, you see at 2 years, 17.5% of the patients were still progression-free survival when they received belzutifan, as per only 4% only were still PFS on everolimus, and the the patients were with a median months of 5.6 months, and the hazard ratio was 0.75. So the difference was statistically significant, with more patients still in progression-free survival than the patients who had everolimus. If we see by the different subcategories of the patients, you will see that wherever you look at it, the age, the sex, the race, the region, the risk factors, how many prior TKIs the patient received, and how many number and prior lines of therapy, all of them favored belzutifan. If we look at the overall survival, there were no statistically significance for the overall survival, although numerically there were more patients still surviving at 24 months and at 12 months. But the hazard ratio was 0.92, but the confidence was exceeding 1 to 1.1. If we look in the overall survival subgroup, if there is any group who might eventually be responding better to the drug, you will see that the patient, of course, who had only one prior line of therapy seemed to respond better. The patient who had poor prognosis seemed also to respond better, but this was not statistically significant. If we look to our secondary endpoints, which were the overall response rate and the duration of response, you will see that there were a 19.2% difference in the overall response rate between the patients who were on belzutifan and between the patients who were on everolimus, and more patients were responding, had any kind of response when they were using belzutifan compared to everolimus. Don't forget that these are very heavily pre-treated patients. The majority received at least 2 prior lines of treatment, so that this included immunotherapy and TKI. So if you have 22% overall response rate in this heavily pretreated population, I think that this is meaningful, and we should look carefully and to evaluate our patients that might be candidate to this kind of response. And if you look into the curve of belzutifan, you will see that the ongoing response is at 24 months 43.7% for the patients who received belzutifan compared to 23% for the patients who were on everolimus. And the median duration of response was 19.3 months on belzutifan versus 13.7 months on everolimus, and this was statistically significant. If you look on the survival follow-up of the patients, and for the patient who did not get any subsequent therapy, you have it in green for belzutifan, and those were 173 patients, and you have it in red or pink for everolimus, and this concerns 121 patients. So as you see, there were more patients on belzutifan who were still surviving without any subsequent therapy than the patients who received everolimus. If we look on the adverse events, we didn't see any new adverse event that we didn't knew about belzutifan, neither about everolimus, and the management of these patients where experienced medical oncologists know how to deal with these patients now, and they were able to deal with the patient. But it is notably to be noted that 40% of the patients experience more than grade 3 side effects, and obviously needed to have some dose adaptation and aggressive management of their side effects. But only less than 1% of the patient had deaths, 1 in the belzutifan arm and 2 in the everolimus arm. As you know, or you don't know, but obviously, as you know, the recommended dose of belzutifan is 120 milligrams. So this is 3 tablets of this 40 milligram drug taken once daily, and usually we take it until disease progression or an acceptable disease in the first line. Currently, in the third line, this is one option in the third line treatment of our patients, or in the second line if other options are not present. So in conclusion, the final analysis of the phase 3 LIGHTSPARK 005 study, belzutifan continued to show a progression-free survival and overall response rate benefits over versus everolimus, including some durable responses lasting to more than 2 years. With more than 2 years minimum follow-up, more participants remained on the treatment with belzutifan versus everolimus. Significant improvement in overall survival was not observed. No new safety signals for belzutifan were observed. The most common any grade adverse drug reaction had a median time of onset of less than 2 months. And the final results of this particular study, LIGHTSPARK 005, support belzutifan as a treatment option in advanced metastatic and recurrent clear cell renal cell carcinoma after the use of PD-L1 inhibitor and VEGFR TKI therapy. And with that, I thank you very much for your kind attention. Thank you.
Hello, my name is Naji El Sagir from the American University of Beirut. It is my great pleasure to participate in this annual ESMO Together meeting organized by Dr. Marwan Ghassan, and I thank him and the organizing committee very much for inviting me. My task is to give you a keynote lecture on take-home messages from ESMO 2025, and I chose to talk about metastatic triple-negative breast cancer, new data on metastatic triple-negative breast cancer. As a reminder, you know that it is defined as a ER/PR HER2 negative. The tumors are usually high grade, and patients have a poor prognosis, advanced stage at presentation, early recurrences, and visceral metastasis. It represents 10 to 15% of all breast cancers. This is data also the same in Lebanon and Arab countries. There is an association, as you well know, with BRCA mutations. 15 to 20% of triple-negative breast cancer patients have a BRCA1 mutation or pathogenic variant, as we now like to say. And the BRCA1 pathogenic variant patients, in 80 to 90% of them, have triple-negative disease. Now, the approved systemic therapies are addition of immunotherapy, pembrolizumab or atezolizumab if PD-L1 is positive, and if we have a BRCA or PALB2 mutation, at least those mutations, we have data to show that PARP inhibitors are effective. The mainstay of immunotherapy is the trial Keynote 355, pembrolizumab plus chemotherapy versus chemotherapy. As you well know, pembro plus chemo was compared with chemotherapy, and we had an excellent 53% overall response rates, and overall response rate for the control was 13%, 40%, and there were complete responses, very interesting, 17% in the pembro group, 30% in the placebo chemo group, and the benefit was seen in patients who had a CPS score 10 or more. This is the recommendation now for patients with CPS more than 10, equal or more than 10. And then after immunotherapy, we had the antibody drug conjugates. If the patient has HER2 low, then trastuzumab deruxtecan was shown to be effective, as in Destiny Breast 04. This is the information that we have before ESMO. We had improvement in PFS and improvement in overall survival, doubling of progression-free survival. Subgroup of patients with hormone receptor negative that were HER2 low, we had also significant improvement, PFS and OS, with a hazard ratio of 0.46 and 0.48. How do they work? The payload chemotherapy is attached, linked to the antibody, monoclonal antibody. It is internalized, and the topo 1 inhibitor chemotherapy is free inside the cells, killing the cells, and diffuses and kills the neighboring cells. In addition to TDXD, we have sacituzumab govitecan. Also, this SG, sacituzumab govitecan, is an antibody drug conjugate. We have the anti-TROP2, the trophoblast antigen present, protein antigen on the cell surface, linked to govitecan payload chemotherapy. Responses were seen in second line, anti-TROP2 plus govitecan in second line for patients with triple-negative breast cancer. At ASCO 2025, we had the association of sacituzumab govitecan SG with pembrolizumab, with an improvement of progression-free survival. Now, so up to October 2025, before ESMO, first-line IO plus chemo, Pembro plus chemo or atezolizumab plus chemotherapy. The data is stronger with Pembro plus chemotherapy. And beyond first line, we had the antibody drug conjugates, as I mentioned. What we have at ESMO, we have the ASCENT-03 SASI govitecan in first line and Dato-DXd in first line for patients who are not eligible for first-line immunotherapy, those who do not have a PD-L1 positive. So the ASCENT-03 in first-line SASI day 1, day 8, compared with the chemotherapy, paclitaxel, nab-paclitaxel, or gemcitabine carboplatin. Primary endpoint was progression-free survival, significant improvement of progression-free survival, 9.7 versus 6.9, with a hazard ratio that's significant, 0.62. And we see that at 6 months and at 12 months, we have an improvement in the percentage of patients who are still alive, free of disease. And we had the TROPION-Breast02 study that compared Dato-DXd with investigators' choice of chemotherapy, which was also paclitaxel, nab-paclitaxel, capecitabine, eribulin, or carboplatin. Here we had dual primary endpoint, overall survival and PFS. We have seen significant improvement. Authors reported significant improvement, progression-free survival with a hazard ratio of 0.57. The median was 10.8 versus 5.6 months, significant improvement. So we have a choice now for patients who are not eligible for PD-L1, metastatic triple negative, either SASI, govitecan, or Dato-DXd. This is a slide by Dr. Bill Gradishar, presented at discussion as a discussion at ESMO. The difference, we have a progression-free survival benefit in both. Dato-DXd did show overall survival benefit. It was still immature for sacituzumab govitecan. We have to pay attention to neutropenia. Prophylaxis for patients with sacituzumab is important. The nausea, vomiting should be controlled. Govitecan is responsible for that. In the Dato ocular toxicity, patients should have eye drops and avoid contact lenses. Mucositis can be treated with mouthwash. Monitor for ILD because we have deruxtecan, as we do with T-DXd. So these are the choices. Now, another important study I just like to mention that many of us, of course, use prophylactic G-CSF for patients on chemotherapy and also for the T-DXd and also for the SASI may be necessary as I mentioned. So this study showed that if you give it at 24 hours, 48 hours, or 72 hours is the same. I usually use it 48 hours after chemotherapy. Some people use it after 5 days. That is, I think, too long. Using it prophylactically, either the next day. We do that with Neulasta, but with the filgrastim, usually 24, 48, or 72. I use it at 72. It's the same. Very important study. One last thing I'd just like to mention, low-dose pembrolizumab. We may have to consider this because of our resources. This was in early triple-negative breast cancer, using 50 milligrams only of pembro every 6 weeks. We need follow-up on that. So in conclusion, after ESMO 2025, for patients with metastatic triple-negative breast cancer, in first line, PD-L1 more than 10% CPS score, chemo plus pembrolizumab as per Keynote 355. We have an overall survival of 23 months versus 16 months. Very important. We have a significant number of patients alive at 24 months, 48% versus 34%, and the progression-free survival hazard ratio 0.65. If they get immunotherapy, then second line is sacituzumab, SG superior to chemotherapy, and we have a new data from ASCO that sacituzumab plus pembro shows improvement in progression-free survival. Now, patients who are ineligible to immunotherapy, sacituzumab is an option, or Dato-DXd is an option after ESMO 2025. Choice, of course, according to availability and toxicity and monitoring of toxicity. Later lines, chemotherapy options or clinical trials. I like to mention the noticeable thought about pembro low dose 50 milligram, and the timing of GCSF is important, whether you give it at 24, 48, or 72 hours, it's the same. And with that, I thank you for your kind attention and congratulations on a great meeting. Hopefully next year we will be face to face. Thank you.
Thank you, Dr. Ghosn, for this ESMO Together. As usual, amazing meeting. So I'll be presenting two abstracts from the long sessions. The first one is the North Star, a phase 2 randomized study of osimertinib with or without local consolidative therapy for metastatic EGFR mutant non-small cell lung cancer. So this is the design of the study. So patients with metastatic or locally advanced unresectable non-small cell lung cancer harboring EGFR mutations, majority of them, they were receiving first-line osimertinib. These patients, they received for up to 3 months osimertinib, and if they don't have progressive disease, they were randomized into one of two parts, either continuing osimertinib, and that's the standard of care, or add local consolidative therapy, and we will talk about what is local consolidative therapy. The primary endpoint of the study is PFS, and the key secondary endpoints are OS, PFS in less than 3 metastases, these are the oligometastatic disease, and the safety of osimertinib and local consolidative therapy. So the majority of these patients received osimertinib in first line, 95% of the patient. The majority of the patients, 70%, had greater than 3 metastatic site. Almost only the third has what we call oligometastatic disease. When you look at these numbers, you can see that the majority of the patients has more than 3 metastases. 43% has, for example, the 5 to 10 metastases. That's the local consolidative therapy treatment were used. In the majority of cases, as expected, that was radiation, 60%, and only 32% of patients underwent surgery, either for the primary or for the metastasis. When you look at the treatment-related adverse event, this is a key secondary endpoint. You can notice that adding local consolidative treatment to osimertinib does not increase the toxicity profile, especially when you look, for example, at pneumonitis, where you can see that the rate of pneumonitis is less than 2% grade 3 pneumonitis. Here is the primary endpoint, the progression-free survival. Very interesting slide. At 3 years, you increase the progression-free survival by 16% from 24 to 40%. And you increase the median PFS from 17 to 25, hazard ratio 0.66. This applies for both kind of common mutation, exon 19 deletion and L858R. When you look at the number of metastases, patients with 3 metastases or less, the hazard ratio is 0.67, almost similar to the hazard ratio of patients who have more than 3 metastases, hazard ratio 0.7. So you decide to do local consolidative therapy for your patients, but not all of them are able to go to do it. So patients with oligometastasis, 3 metastases or less, 100% of them, they underwent the whole local consolidative treatment. For patients with polymetastasis, only 60% of them underwent the whole consolidative treatment for all metastatic deposits. This is a major finding in the study. So patients who completed the LCT had a median progression-free survival of 28 months compared to 14 months for patients who underwent only partial LCT. So the conclusion is that adding local consolidative therapy to osimertinib improve progression-free survival. The benefit is for both patients with less than 3 metastases or more than 3 metastases. Patients who completed the whole local consolidative treatment for the whole sites of metastasis has the most benefit, and it is safe. I will move to the second abstract, also very interesting and innovative study. So we were talking about zongertinib as first-line treatment in patients with advanced HER2 mutant non-small cell lung cancer, the BIMULONG-01. So only 2 to 4% of patients with lung adenocarcinoma harbor this HER2 mutation. And this drug, zongertinib, is a selective, irreversible tyrosine kinase inhibitor that selectively inhibits HER2 while sparing the EGFR. So not too much toxicities because it spares the EGFR blocking, and it blocks irreversibly the HER2 mutant compound. This is a phase 1b, and they presented at the ESMO the cohort 2. So treatment naive patients with TKD mutations. Of course, it's a phase 1b, so the primary objective is objective response rate, and the secondary objective was disease control, duration of response, and progression-free survival. So 58% of the patients were 65 years and old, half of them female, half of them non-Asian, and of note, the third of them has no history of tobacco exposure. So it's not like a kind of mutation that it's only for smokers and ex-smokers. And here's a very beautiful waterfall curve plot. So you can see that the overall response rate is 77% and the disease control rate is almost 100%. So these drugs, it works for the 74%, 74 patients included in the trial. And the responses are durable, and the response are quick. So the median time to objective response was 1.4 months. The disease duration of response and the progression-free survival at 6 months is similar, 80%. And here they presented 2 cases of patients with HER2 mutations. You can see, for example, this patient in lung metastasis, you can see that the decrease in the tumor size is 50% during the first 2 months, and the tumor continued to shrink with time. And here's also a response in the brain. So this drug also works for brain metastasis. It's a small molecule tyrosine kinase inhibitor, so it works also for brain metastasis. Not too much toxicity. Grade 3 toxicity is almost nothing, like 4% ALT increase, 3% AST increase, 1% paronychia. So it's a very, very safe drug. So in conclusion, there is no standard first-line therapy for HER2 mutant non-small cell lung cancer, and you know that these patients have a very poor prognosis with chemotherapy or chemoimmunotherapy. This zongertinib, which is a selective inhibitor of HER2 mutant non-small cell lung cancer, is very effective. Response rate 77% and 80% PFS at 6 months with an excellent safety profile. That's why the drug was granted breakthrough therapy designation by the FDA in the US and in China. And now there is a phase 3 trial, the BIMIOM Lung 02, comparing this zongertinib TKI to standard of care treatment. Thank you so much.
Hello, everyone. Thank you, Dr. Hassan, for the invitation. My name is Pamela Abdayem. I'm a medical oncologist at Gustave Roussy at the Thoracic Group, and I'll be presenting 2 abstracts on lung cancer. I'll share my screen. Okay. So, as you all know, neoadjuvant or perioperative chemoimmunotherapy is now the standard of care in EGFR and ALK negative stage 2 and stage 3 resectable non-small cell lung cancer with a clear benefit in overall survival and significant pathologic complete response rates. On the other hand, concomitant chemoradiation followed by consolidation durvalumab remains the current standard of care in unresectable non-small cell lung cancer. So the resectability of non-small cell lung cancer is a major issue, and we had a publication beginning of 2025 by EORTC of a consensus, to try to see which patients are resectable and which tumors are resectable, which aren't. And so you have the unresectable tumors, the resectable tumors, the borderline resectable, and the no agreement where you have small tumors with multiple N2 or larger tumors with single station N2. So can potentially resectable and unresectable tumors be converted to be resectable? This is the question. So first abstract is the MDT bridge study that was presented by Dr. Martin Reck. It's a phase 2 non-randomized study, global, adult patients aged 18 or older, previously untreated or pathologically confirmed resectable or borderline resectable stage 2B to 3B non-small cell lung cancer, EGFR and ALK wild type, baseline MDT resectability assessment. And so tumors that are deemed resectable or borderline resectable are included in the study. So patients will undergo 2 cycles of chemoimmunotherapy with durvalumab and platinum-based chemotherapy, and then multidisciplinary tumor board reassessment with restaging and optional pathologic confirmation. Patients who are deemed resectable will continue and have 1 or 2 additional cycles of durvalumab and chemotherapy, and then surgery. Those who are unresectable will undergo chemoradiation. And after surgery or chemoradiation, patients will undergo adjuvant or consolidation durvalumab for 12 cycles. The primary endpoint is the resection rate, defined as the proportion of all patients who underwent definitive surgery. And so these are the planned interim analysis results. So the baseline patient characteristics were generally balanced between the cohorts. So you have all patients 84, baseline resectable 56, and 28 borderline resectable. You can see that there were very few non-smokers in this cohort. And then the borderline resectable had more stage 3B disease and more T4 tumors. Then what happened to these tumors? So all patients received more than 2 cycles of neoadjuvant durvalumab, and 32% received 4 cycles. And so most patients who are deemed borderline resectable at baseline were reassessed as resectable after 2 cycles. There were only 3 patients who were deemed unresectable. And so 95% had either surgery or chemoradiation after neoadjuvant durvalumab and chemotherapy. Resection rates were good, 85.7% overall, 71.4% in the borderline resectable cohort, with the majority of patients having R0 disease, R0 resection, 85% for the borderline resectable patients. And so the patients who got surgery, 60.5% partial response before surgery and 30.3% stable disease. Pathologic complete response rate of 27.6%, all patients included. If you look at the resectable ones, 39.5%, and the borderline resectable ones, 17.4%, which is not bad when you compare with the results of Keynote and Checkmate. You can see that the majority of patients received carboplatin, and the surgery that was the most frequently performed was lobectomy. What happened to those patients who were unresectable and underwent chemotherapy? So we have 8 out of 12 who started and completed chemoradiation, and 7 out of 8 who started consolidation with durvalumab. And so there were no new safety signals in this cohort, and in particular 0 any grade pneumonitis. Second abstract, LungMate 13, open label randomized controlled phase 2 Chinese trial. So patients who have histologically or cytologically confirmed unresectable stage 3B or 3C non-small cell lung cancer, EGFR and ALK wild type, and they will undergo induction therapy with 4 cycles of chemotherapy and serplulimab, which is a recombinant humanized anti-PD-1 monoclonal antibody. And then resectable patients who have disease downstaging to stage 3A or lower will be randomized to receive either surgery or radiation. Unresectable patients will undergo treatment as per MDT decision. The primary endpoint was the event-free survival. So 100 patients were treated with 4 cycles of, so they were started on chemoimmunotherapy, and then 50 ended up being randomized between radiation and surgery. You can see that the patients that underwent radiation were slightly older, and as I said in the MDT bridge, there were very few non-smokers. PD-L1 was generally well balanced, and what was weird was that we had the majority of the patients had squamous cell carcinoma, which is not what we have in our real life right now. So the initially 100 enrolled patients, 74% partial response, 61.9% major pathologic response with less than 10% viable tumor cells, and 47.6% pathologic complete response rate, which is a very important prognostic factor. Event-free survival, the median was 17.7 months, and the median overall survival was not reached. So the patients who underwent randomization, either the intention to treat population and the protocol, we had, so those who underwent surgery did better with a hazard ratio of 0.38 and 0.21. Adverse events were expected for the induction phase. For the radiotherapy outcomes, there were increased pneumonias, 52.4%, but they don't give details about the grade or the severity, the grade. And then you have the surgical outcomes, so 50%, around 50% thoracotomies and 50% VATS, and then 100% are zero resections and a 90-day mortality of 0%, which is not bad at all. So in conclusion, if we take these two studies that are trying to, tackle the issue of conversion of borderline and unresectable tumors to resectable tumors after chemoimmunotherapy, so this may be possible. We need additional studies, additional data. There are some questions and caveats. So how do we assess resectability? How was resectability assessed in these trials? And do we do restaging, invasive restaging? And finally, the key question, once we do all this, the neoadjuvant part and the surgeries, do we need adjuvant or consolidation treatments? Or which patients might need these treatments? Those with a lack of pathologic complete response, those with positive MRD. So this is what we need to work on. And with that, I thank you for your attention.
Hi, everyone. I would like to thank the steering committee for the invitation and Dr. Marwan Ghosn. In the next 10 minutes, I'll try to share with you two abstracts presented in the last ESMO in Berlin 2025. The first study, it's a phase 3 study presented by Dr. Shan, addressing the role of a new bispecific antibody, which is the ivonescimab plus chemotherapy versus the PD-L1 inhibitor tislelizumab plus chemotherapy as a first-line treatment for advanced non-small cell lung cancer squamous cell histology as a part of the Harmony 6 trial. The background of this, we know that there is several PD-L1 inhibitors, and tislelizumab is one of this immunotherapy, has been approved in combination with chemotherapy in China as well as in the European country according to the EMA labeled indication for those patients with non-small cell lung cancer squamous cell histology. Now, ivonescimab is a bispecific antibody targeting both receptors, the PD-1 and the VEGF receptors. It has been approved for two indications in China as for patients with non-small cell lung cancer have experienced the disease progression on EGFR TKI. So those are EGFR muted, and this is based on the Harmony A study. Also approved for those with the PD-L1 positive advanced non-small cell lung cancer in the first-line treatment, again, based on the Harmony 2. Now, this study, as we mentioned, is trying to compare it with what currently we use as standard of care, and this is tislelizumab is approved, as we mentioned, in China as well as in Europe. This is the design of the study. It's a multi-center randomized double-blind trial, parallel control phase 3, eligibility, patient with non-small cell lung cancer, squamous histology, they should be stage 3B or 4, no prior systemic therapy, and no mutation in the EGFR or ALK rearrangement, and they have echo performance status 0 to 1. Those patients were stratified according to the stage of the R3 versus 4, and the PD-L1 status negative versus positive, which considered 1 or more. Randomization 1-to-1, and 532 patients were enrolled. So the control arm was chemotherapy, carboplatin plus paclitaxel, the usual dosing, plus tislelizumab. And this is considered the control arm for 4 cycles, and then maintenance tislelizumab 200 milligram every 3 weeks for 2 years. And the investigational arm, the same backbone of chemotherapy, but this time the bispecific antibody, which is ivonescimab 20 milligram per kilogram every 3 weeks for 4 cycles, and then the maintenance of the bispecific antibodies. The primary endpoint is progression-free survival by independent review per RECIST criteria 1.1, and the secondary endpoint was overall survival. This data cutoff was in February 2025. If you see patient disposition, 532 patients were enrolled, 266 in each arm. And if we see that most of the discontinuation rate were related to the disease progression, while the other reason like death or withdrawal or consent were similar in both arms and nothing really significant. Still, 162 patient is on treatment on the investigational arm, and 134 patient are on the control arm. This is the baseline characteristic. It's showing that 50% of those patients are younger than 65 and the rest are older. The vast majority of those patients were male because, again, as we expect, squamous cell histology, and most of them are a smoker, around more than 90%. The vast majority are stage 4 disease. If we look into the PD-L1 status, we see that 39% of those patients are negative, while the rest were positive, and 20% of those patients, they are strong expressor, which is considered 50 or more. If we look for the primary endpoint was met, and this was a significant improvement from 6.9, the progression-free survival in the control arm, to 11.1 in the investigational arm, with a hazard ratio of 0.6 with the short confidence interval, which is very reassuring that it's almost 40% you reduce the risk of progression if you use the bispecific antibodies rather than immunotherapy alone. And if we look for the investigational assessment, we see even the hazard ratio is matching with what we saw it here. It's 0.64. If we look into the subgroup analysis, we see most of those patients benefit, regardless whether they have liver metastasis, regardless to the PD-L1 status. If we look into the stage, as well as whether they have brain metastasis or not, all they benefit from the investigational arm compared with the control arm. Now, this is classifying patient according to the PD-L1 status, and we see the most significant hazard ratio was noticed in the PD-L1 negative. We know the efficacy of immune therapy in those with PD-L1 negative is limited. Probably adding the anti-VEGF by the bispecific antibodies enhance the activity of the immune therapy, and this is why you see it is even more effective. While those with a strong expressor, they have higher sensitivity to immune therapy, and this is why probably the hazard ratio is get lower. But if you take all the PD-L1 status in general, still the hazard ratio is positive with 0.66, and this was significant. If you look other secondary endpoint, the response rate, it is positive with the investigational arm, regardless to the PD-L1 status. And if you look, the durability of the response was also positive from 8.3 to 11.2, and this is very reassuring. If you look into the toxicity to see that this advantage was based on more toxicity or not, we look into the grade 3 toxicity, slightly higher with the investigational arm, around 9%, while if you look into the serious treatment-related toxicity is almost similar, 30%. And if you look into the death or discontinuation, it's almost similar. If you look into the other graph on the right side, it's almost similar toxicity, so there is no additional toxicity gained by the investigation arm with the ivonescimab treatment. If you look at the specific immune-related and the VEGF-related anti-VEGF-related toxicity, if you look into the immune, we don't see differences between using tislelizumab or ivonescimab. And again, for the grade 3 toxicity, serious toxicity, all were similar between the two arms. Even the VEGF inhibition in that bispecific, we see it's not exceeding the one-digit proteinuria is 2.3%, thromboembolism 1.1%, so it is really a safe drug. The conclusion from that study that using ivonescimab in replacement of the PD-L1 inhibitor showed improvement in progression-free survival in non-small cell lung cancer squamous histology, and this was significant, and this is regardless to the PD-L1 status. The hazard ratio is more pronounced in the PD-L1 negative, which is expected. Also that the tumor response, all the secondary endpoint was achieved. The overall survival is not mature yet. And the conclusion of the presenters that using ivonescimab plus chemotherapy showed a significant efficacy improvement with manageable safety profile and might be a new standard of care for patients with advanced non-small cell lung cancer squamous histology. The second abstract, and this is another antibody drug conjugate, sacituzumab tirometecan, SAC-TMT. This is presented by Dr. Li Zhang. Here, trying to compare this antibody drug conjugate versus the platinum-based chemotherapy in patients who carry the sensitive EGFR mutated non-small cell lung cancer following progression on the regular anti-EGFR TKI, mainly the third generation, and it can be also first or second generation. And this is part of the OptiTrop Lung 04 study. The background of this, we know that SAC-TMT is a TROP2 antibody drug conjugates. It has a unique bifunctional linker that maximizes the delivery of the payload, which is the belotecan derivatives. And usually TROP2, it is highly expressed in EGFR mutant sensitive non-small cell lung cancer, and sometimes it predicts resistant. And those who are progressed on EGFR, they have higher sensitivity to this antibody drug conjugates, and engaging this and engulfing these antibodies is shown to be higher in those who progress on anti-EGFR therapy. Now, usually the second line treatment, those who progress on the anti-EGFR therapy, the standard of care is to go for chemotherapy, and we know that this is a very limited outcome with a median progression-free survival ranging between 4 to 5 months. Now, the recent advances with the therapeutic involvement in combination of immune therapy plus anti-angiogenic agent, also bispecific EGFR, MET antibodies, HER2/3 directed therapy, some of those combinations did not really reach the overall survival significance. So there is an unmet need in this cohort of patients when they progress on the anti-EGFR therapy. The design of the trial, you see that their ECOG performance status 0 to 1. Those patients have non-squamous non-small cell lung cancer, stage 3 or 4. They have sensitive EGFR mutation, progressed either on the third generation TKI, or they progressed on first and second generation without the presence of the T790 mutation. They were randomized 1-to-1, either SAC-TMT, 5 milligram per kilogram every 2 weeks, or to pemetrexate, either carboplatin or cisplatin, followed by maintenance pemetrexate. The primary endpoint was progression-free survival. The stratification were according to the prior TKI, whether third generation or first and second generation, and whether they have brain metastasis, yes or no. These are the patient disposition, and we see that 188 in each arm, and again, most of discontinuation were related to the disease progression. If we look into the baseline characteristic here, because of the EGFR mutation, we see much younger population. Those who are older than 65 is around 30% of the cohort, and almost 60% of the patients are female because they have higher incidence of EGFR mutation, and 2/3 of them, they are never smoker. And again, if you see that the vast majority were stage 4 disease, around 96%. The brain cohort, brain metastases were around 17 to 19%, and they were balanced between the two arms. The primary endpoint was met, and there was a significant improvement in the median progression-free survival from 4.8 to almost 8.4 with a hazard ratio of 0.51. And this is very significant. And if you take the timing of 1 year, those who are still on the treatment and disease progression free is almost 3 times the control arm, 34.7% versus 10.7%. And if you look into the independent review, it's almost matching with even higher hazard ratio of 0.49, almost 51% reduction of risk of progression if we use the antibody drug conjugate sacituzumab TMT. All subgroup analysis, they benefit. So regardless, they are smoker, non-smoker, female or male, prior EGFR, third generation or first or second generation. Just to mention that only 10% of those, they took first or second generation without third generation. Most of those patients, they either started first line, third generation, or they shifted in the second line. So 90% of patients received third generation TKI. Brain metastasis or not, also liver metastasis or not, whether they are T790, whether they are mutated in exon 19 or 21, both negative and regardless to the T790 mutation. If we look into the overall survival, this was also positive. We see that the median survival was 17.4 months in the investigational arm, while in the control arm, while investigational arm was not reached. And if you take the time of 18 months, we see almost 48% of those patients still alive, while 65.8 they are alive on the investigational arm. So 40% risk of reduction of death if you use the sacituzumab TMT in the second line or third line treatment after anti-EGFR therapy. Now, if you look into the overall survival subgroup analysis, also all they benefit from the treatment. So regardless to the type of the mutation in the EGFR, or they have liver or brain metastasis, or if they have smoking or non-smoker. Now, if you look at the post-treatment, post-progression treatment, we see that almost 37% of those in the investigational arm crossed to the pemetrexed-based therapy. If we look on the other side, those with control arm, 20% of those patients, they switched to sacituzumab or antibody drug conjugates treatment. And if you censor those patients, we see that even the hazard ratio is much higher, and the risk reduction is almost 44% risk of reduction of death by using this without crossing to antibody drug conjugates in the subsequent line treatment. What about secondary endpoint? Again, all has been improved. Overall response rate from 43% to 60%. The disease control rate is better, and the duration of response was higher. If you look into the overall survival, overall safety of the treatment, we see that it is also safe. If you look into the grade 3 toxicity, almost similar. If you look into the serious treatment-related events, it's even safer than the chemotherapy, 17% versus 9%. If you look into the specific toxicity that you can see it with this antibody drug conjugates, it's mainly mucositis, which reported to be grade 1 and 2. Similarly, the ocular surface toxicity, again, reported around 9 to 9.6%. Again, it's a grade 1 to 2 toxicity. The conclusion of the presenters is that sacituzumab TMT demonstrated an improvement in the progression-free survival, as you see on the right pictures, from 4.3 to 8.3, hazard ratio 0.49. If you look into the overall survival, also significant. The hazard ratio is 0.60. In the control arm, 17.4, while this was not reached with the SASI TMT. And if you look into the other secondary endpoint, all favor the antibody drug conjugates. So the result of the conclusion of the presenter, the result of the OptiTrop Lung 04 study support that SASI TMT as a promising new treatment option for patients with EGFR mutated non-small cell lung cancer with EGFR TKI resistant. By this, I finish my presentation, and thank you very much for listening.
Hello, everyone. First of all, I would like to thank Professor Ghosn for inviting me to participate in this annual Congress in the ESMO Together. That is really a big success, especially that is being organized 2 weeks after the ESMO, which is really a very good thing for everyone who attended and who did not attend the Congress, because as you know, no one has the ability to attend all parallel sessions during the ESMO. This year, we had the pleasure to have many positive results, among which trials that showed that treatments could be used. Many drugs which were indicated or approved in metastatic setting are now being used in neoadjuvant treatment. So it's very good for early stage cancers, but this raised other questions regarding, for example, what would we do if a patient progress after receiving the newest treatments in the neoadjuvant settings, whether it was bladder cancer and breast cancers and other types. But also, as we know, the hit hard theory, which is doing everything we can so that the patient is cured from the beginning and avoiding any relapse in the future months or years after the curative treatment intent. In this topic, I will have the pleasure to be talking about Tecentriq, aiming high for your PD-L1 high metastatic non-small cell patients. So we will be talking about the Empower 110 and other trials which evaluated the treatments in PD-L1 positive patients, high patients, more than 50% in the metastatic non-small cell lung cancer, as we said. So these are my disclosures. So let's take, for example, the example of a patient, Raji, a 67-year-old non-smoker professor, PS1, who was newly diagnosed with metastatic non-small cell lung cancer. Biomarker testing came back positive for PD-L1 high, more than 50%, no EGFR or genomic tumor aberrations. What do we have as options for these kinds of patients that we regularly see in our clinic? So as you know, as per the NCCN guidelines, many immunotherapy drugs are approved in the first line, non-small cell lung cancer, metastatic, adenocarcinoma, and squamous, whose PD-L1 are above 50% and whose performance status are 0, 1, or 2. If we look at the preferred regimens in the first line, as per the NCCN guidelines, we can see that Tecentriq monotherapy is one of the options. Pembrolizumab monotherapy is another option. Pembro with chemo is another option. Cemiplimab monotherapy is an option, and cemiplimab and chemo is also a fifth option. What do we do? Is there any difference between those drugs? We know that we do not have any direct comparison, direct trials who compare those drugs between them. Do we do only chemo? Do we do chemo with immuno? Do we do this immuno or another one? So based on this, we're gonna tackle some trials. First of all, the Empower 110, which was a randomized phase 3 multicenter study that led to the approval of Tecentriq in stage 4 non-squamous or squamous non-small cell lung cancer with patients who were chemo naive, EGFR ALK negative, and the study had PD-L1 selected. We will see this later on in the study design. So the patients were randomized to receive on one-on-one Tecentriq 120 milligrams every 3 weeks or chemotherapy for 4 to 6 cycles. For non-squamous, carbo or cisplatin with pemetrexed. For squamous, carbo or cisplatin with gemcitabine. No maintenance were approved after chemo. As for the Tecentriq, patients continue to receive it until progression or loss of clinical benefit it's a type also of progression, clinical progression, or loss of benefit. Primary endpoints were OS in the wild type population. Key secondary endpoints also assessed PFS, overall response rate, and duration of response, which is also something that is very important, because we do not only want with immunotherapy to add some few months to our patient. What we really want with immunotherapy is for patients who respond well to immunotherapy to respond for a long period of time. And this is what is really what really changed our practice with immunotherapy. Instead of adding just few months for patients, we are adding, we will see how much we can add with each drug to our patients. So the baseline characteristics were well balanced between the arms and between the PD-L1 subgroups. So when we look at the TC123 or IC123, means PD-L1 more than 1%, the overall population with PD-L1 positive, or the TC3, so the PD-L1 high more than 50%, we can see that the baseline characteristics are well balanced. 70% of patients had non-squamous histology, nearly 10 to 15% never smoked, 70% of patients were male, and ECOG PS0 represented 1/3 of our patients. So looking at the prevalence of PD-L1, we see that the expression was similar between treatment arms, whether it was for the TC3, so PD-L1 high more than 50%, PD-L1 more than 5%, and PD-L1 positive more than 1%. Looking at the results, the median OS was 20.2 months with atezolizumab or Tecentriq arm compared to 13.1 months with the chemo standard arm. This was significant with a hazard ratio of 0.59 and a p-value, as we said, that is 0.01 significant, which means that we had a 41% risk reduction of death with Tecentriq monotherapy in the first-line metastatic non-small cell lung cancer, PD-L1 high, whether they were non-squamous or squamous, based on this study. We can look at the results at 6 months and at 12 months for the percentage of patients who were still alive. PFS was also positive, 8.1 months versus 5 months, hazard ratio of 0.63, which means 37% risk reduction in disease progression with a p-value of 0.007, very significant for squamous and non-squamous patients. What about the overall response rate and the duration of treatment? Duration of treatment was also in favor of Tecentriq with 38.9 months versus 8 months for the chemo arm, which is the highest median duration of response as monotherapy in first-line metastatic non-small cell lung cancer PD-L1 high ever recorded in immunotherapy pivotal clinical trials. What about the updated OS in PD-L1 high? Indeed, we had an exploratory OS analysis in the PD-L1 high, which showed a continuous benefit of OS with Tecentriq compared to chemo. When we look at the numbers, we can see that the median OS for the immunotherapy arm, it's still 20.2 months. When we look at the OS for the standard arm, it's 14.7 months, a bit more than what we saw in the primary analysis with nearly 13 months. How is it explained? We can see that nearly 1/3 of patients in the control arm received subsequent cancer immunotherapy. And when we adjust the effect of subsequent cancer immunotherapy, we have again the same numbers of 20 months versus 13 months for the standard arm. The updated safety profile also shows a favorable profile. We do know in our practice, all of us are using this drug in many indications. We can see that it's usually well tolerated. Personally, I already had real adverse events with this immunotherapy, especially when we compared it to other kinds of immunotherapy. Overall, grade 3-4 adverse events were nearly 12 to 13% with atezolizumab compared to 44% with chemotherapy. Same as here to say that the profile is usually favorable for the adverse events. It's something that we really used to it nowadays, especially that we use a lot of immunotherapy and Tecentriq for our patients. So overall, the Empower 110 showed that the Tecentriq monotherapy was efficacious, and this led to its approval for metastatic non-small cell lung cancer PD-L1 high in the first line metastatic setting for non-squamous and squamous. The study was positive for OS PD-L1 high with a hazard ratio of 0.59 and a meaningful improvement in PFS, overall response rate, and duration of response versus chemotherapy. Safety profile, I just talked about it, and patient treated with Tecentriq had a longer treatment exposure, as we know it, as per the design trial, also than patients treated with chemotherapy. So, as a summary card, OS 20 versus 13 months, hazard ratio 0.59, PFS same hazard ratio, PFS 8 versus 5 months, overall response rate, the median was 14 months, and the duration of response was 38 months for PD-L1 high, and this is a very important number to keep in mind for the Empower 110 trial and in favor of Tecentriq to have 38, nearly 39 months of median duration of response. When you look at other clinical trials, we cannot have a direct comparison between trials, but it's important in the absence of those kinds of trial to decide what do we want to do in our clinical practice. What do you do on Monday after this week, and when we have a patient for whom we have many treatment options? Is there a treatment that seems better than another one or not? We had the Keynote 042, which studied pembrolizumab monotherapy in chemo-naive non-small cell lung cancer for patients with PD-L1 positive more than 1%. They compared pembrolizumab every 3 weeks to chemotherapy, carbopaclitaxel or pemetrexed up to 6 cycles, with an option to continue pemetrexed as maintenance, and crossover was not permitted. Primary endpoint was overall survival. When we look at the results, we can see that the overall survival was 20 months for the pembrolizumab arm for patients with a PD-L1 more than 50%, compared to 12 months for the standard arm. These numbers seem like numbers who are similar to the study of Empower 110, who evaluated Tecentriq versus chemotherapy. PFS in this trial was not significant. Median overall response rate was 39, and median duration of response, however, was 20 months, nearly half of what we saw with the study of Empower 110, which showed a median duration of response of nearly 39 months. Another trial, the Keynote 024, also evaluated pembrolizumab monotherapy in chemo-naive non-small cell lung cancer for patients who had only PD-L1 more than 50%, so PD-L1 high patients, same comparing pembrolizumab to chemotherapy, crossover not permitted until progression. So when you look at the results of overall survival, we can see in this trial that the overall survival was 26 months, amazing survival, compared to 13 months for the standard arm with chemotherapy. PFS was reached 7.7 compared to 5.5. The PFS is quite similar to what we saw with the Empower. Still, Empower had 5 versus 8 months. Here it's 5.5 versus 7.7. The difference is really in the OS. But when we look again, at the median duration of response, we can see that the median is around 29 per month, still less than what we saw with Tecentriq of a median duration of response of 39 months with the other trial. So this trial also showed, of course, that pembrolizumab is a solid option for first-line treatment in those patients, with some numbers that seemed better, some others that seems less good than the Empower 110 trial. Although we keep in mind that we are not directly comparing those trials, but giving the similarity of the designs, we can have an idea of the numbers of the trials. When we try to do an indirect comparisons between Tecentriq and pembrolizumab, when we compare the Empower 110 indirectly to Keynote 024, so Tecentriq versus chemo compared indirectly to pembro versus chemo. When we look at the differences, we do not have any significant difference to favor one drug over another. Still, for the Empower 110 compared to the Keynote 042, the other trial of pembrolizumab, when we look at the differences, the overall conclusion that we should keep in mind is that there is no major difference between those the results of those studies. Another trial is the Empower Lung 1 trial, who evaluated cemiplimab this time every 3 weeks compared to 4 to 6 cycles of chemotherapy. Optional crossover to cemiplimab monotherapy was permitted in this trial. They also took PD-L1 high patients more than 50% after retesting and according to the criteria of evaluating PD-L1 high. So what did this study show? It was also a positive trial in favor of cemiplimab compared to chemotherapy. The trial showed an overall survival of 26 months compared to 13 months in favor of cemiplimab. PFS was positive 8 versus 5.3 months. Median duration of response was again 23 months, similar to the other studies and less than the Tecentriq results in the Empower 110. So overall, we can say that the 3 molecules are approved, which is the case. They are approved as preferred treatments option in the NCCN guidelines, category 1, immuno or immuno with chemo. Do we have a real difference between those drugs? In practical, we can see that there is no real difference using them. However, we can and we should think of the accessibility of the price of the drug, its accessibility, its reimbursement. The most important thing and the best drug in real life is the drug that we can have and we can have for a long period of time. The mode of administration. Another thing that is very, 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 very interesting for the Tecentriq, and hats off for this, is that it was the first PD-L1 subcutaneous cancer immunotherapy approved in Lebanon. Why is it important? First, it's FDA and EMA approved in all indications for Tecentriq IV. So we can use the sub-Q for all the indications where the IV is approved. How was it approved? We had a phase 1b dose-finding study, then a phase 3 randomized non-inferiority study, who included patients with histologically or cytologically documented stage 3B4 non-small cell lung cancer, immunonaive, failed first-line platinum-based chemo, and with a measurable disease, who compared Tecentriq sub-Q, fixed dose of 875 milligrams every 3 weeks, compared to Tecentriq fixed dose 1,200 milligrams every 3 weeks. The co-primary endpoints were the CTROF, it means the minimal concentration of the drug when we administer the next dose, and the model predicted AUC. Both co-primary endpoint were non-inferior, so the study was positive, allowing us to use Tecentriq subcutaneously. When we look at the results of overall survivals, they are also similar and non-inferior using the sub-Q or the IV molecule. This is, as we said, the first sub-Q immuno-approved in Lebanon. We will see that another study tried to compare two arms, people who received 3 cycles of Tecentriq sub-Q, followed by 3 cycles of Tecentriq IV, and then the patient had to decide if they wanted to continue with the sub-Q or the IV mode of administration. There was also another arm where we began with an IV, 3 cycles, then 3 cycles of sub-Q, and then the patient had also to decide whether they wanted to continue with the sub-Q or IV mode of administration. When you look at the results, we see that 70% of patients preferred the sub-Q, 20% preferred the IV, and nearly 10% had no preference. So overall, more than 80% or nearly 80% of patients were satisfied or okay with having Tecentriq sub-Q versus 20% of patients who preferred the IV route of administration. Beyond the preference of the patients, we can see overall that Tecentriq monotherapy did, as we said in the Empower 10, improve the median OS 20 months versus 13 months with a 40% reduction in the risk of death. What we should keep in mind is that Tecentriq is globally used in more than 170,000 patients globally. And as you said, not only in Lebanon, but also in the US and the UE, Tecentriq was the first anti-PD-L1 subcutaneous cancer immunotherapy that was approved. So beside the preference of the patients, as you said, we also have the preferences maybe of the nurses, of the hospital, of the time to administer and the time during which the patient stays in the hospital. Actually, using the sub-Q Tecentriq mode of administration, we can see that it's 3 times quicker than the IV treatment. It's 3 times quicker when prepared by nurses on the ward compared with pharmacists in the pharmacy. Also, 85% of the nurses were satisfied using it. This is for you to keep in mind that Tecentriq sub-Q is also a solution that needs to be prepared, and it does not come already pre-filled in syringes. The administration is also every 3 weeks. So I think that this is also very important to know that we are doing now what the patients need next. And we do know that I think that more and more drugs will be used through the subcutaneous mode of administration instead of the IV. We're glad that it's already being used in Lebanon. It's being used at the hospital under medical surveillance, and it's not used at home. It's also something to keep in mind. I would like to keep you my email in case anyone has any question. I will be very glad to answer you. I would like to thank again Professor Ghosn for organizing this amazing Congress and for inviting us to be part of it. Thank you.
Hello, everyone. First, I would like to thank Professor Ghosn for the invitation to present in this annual Outstanding Congress. So today I'll be presenting the updates in the perioperative treatment of resectable gastric and gastroesophageal carcinoma, highlighting 2 trials that were presented in the ESMO 2025 in Berlin 2 weeks ago. So the first study was the final overall survival analysis of the Matterhorn phase 3 study that evaluated the association of durvalumab with the standard perioperative chemotherapy FLOT in resectable gastric and gastroesophageal junction adenocarcinoma. So a first result of this study showed a significant improvement in event-free survival with durvalumab plus FLOT versus placebo plus FLOT in participants with resectable gastric and gastroesophageal carcinoma, with increased pathologic complete response and major pathologic response rates in favor of the association of durvalumab plus FLOT. And an interim analysis of overall survival indicated a trend toward improved overall survival with this association versus placebo plus standard FLOT. So they presented at the meeting the results of the final analysis of the overall survival in the intention to treat population with a data cutoff that was set to the 1st September of 2025. And they also reported an analysis of the association between pathologic outcomes and event-free survival in this trial. So this was a phase 3 randomized double-blind placebo-controlled study that included patients with gastric or gastroesophageal adenocarcinoma that were suitable for resection. Those patients were randomized 1-to-1 to receive durvalumab plus FLOT in the perioperative setting, followed by maintenance with durvalumab for up to 1 year, or placebo plus FLOT in the perioperative setting, then in adjuvant treatment with placebo for 10 additional cycles. The primary endpoint was event-free survival, and the key secondary endpoints were overall survival and pathologic complete response assessed by central review by modified Ryan criteria. So here's the final analysis of the overall survival. The median OS was non-reach in both groups, but we have a clear separation of the curves in favor of the group durvalumab plus FLOT with a hazard ratio of 0.78 and a statistically significant p-value of 0.021. We had a difference of 6.7 between the two group with a 36-month overall survival rate at 68% in the group durvalumab versus 61% in the group placebo. The overall survival benefit was consistent across all subgroups with some differences. For example, patients with negative clinical lymph node status, they explained that was a small number of patients with negative clinical lymph node status. That's why the benefit was minor in this group. And we had a problem that histologic subtype, we had 216 patients who had indeterminate histologic subtypes, and the histologic subtypes was not reviewed centrally. So the overall survival benefit was also seen in patients with positive PD-L1 top score or negative PD-L1 top score with the same hazard ratio of 0.79. What about pathologic and nodal assessment? So the pathologic complete response based on Ryan score, defined as the Ryan score of 0, was at 16.5%. And non-pathologic complete response was seen in 83.5% of patients, a major pathologic response in 25.8% of patients, and any pathologic response defined as a Ryan score of 0, 1, or 2 in 87% of patients. And nodal staging status was assessed locally in participants who completed surgery. So we had no nodal involvement in 51 patients versus 48 patients who had a nodal involvement. The event-free survival benefit was also seen among participants with any degree of pathologic response. So in pathologic complete response in patients who had a major pathologic response, and in any pathologic response with a hazard ratio of 0.6. 58% of patients in the group durvalumab plus placebo had a negative nodal staging score, and versus 44% in the group placebo plus FLOT. The event-free survival benefit was also seen regardless of pathologic nodal status, with a hazard ratio of 0.7. So in conclusion, durvalumab plus FLOT significantly was associated with a better overall survival versus FLOT alone, with a hazard ratio of 0.78 and a p-value that was statistically significant and 0.021. The OS improvement in the group durvalumab was regardless of PD-L1 status, and the event-free survival benefit was seen regardless of the pathologic response and regardless of pathologic nodal status. So following these results, durvalumab plus FLOT could be a new standard of care in patients with localized gastric or gastroesophageal adenocarcinoma. About HER2-positive gastric cancer, previous trials showed that there was no benefit to add trastuzumab to the perioperative chemotherapy. But this phase 2 study, the PHER-FLOT IKF-053 trial, was a phase 2 trial that was presented in the ESMO 2025, and they evaluated the association of pembrolizumab, trastuzumab in combination with chemotherapy in the perioperative setting. So we know that pembrolizumab, trastuzumab, and chemotherapy is a standard of care in the first-line setting in metastatic gastric adenocarcinoma. Is this association can be feasible in the perioperative setting? So this was a phase 2 trial that included patients with localized gastric or gastroesophageal adenocarcinoma that were suitable for surgery, who had a positive HER2 score of 3+ on immunohistochemistry or 2+ and a positive FISH. Those patients were treated with FLOT in perioperative setting associated with pembrolizumab and trastuzumab, followed by 11 cycles of pembrolizumab and trastuzumab. The primary endpoint that was presented in the ESMO was pathologic complete response, and secondary endpoints were feasibility, defined as the number of patients who completed the perioperative treatment, safety, R0 resection. 32 patients were assessed for eligibility in this trial. One patient was excluded for a HER2 score of 1+. So 31 patients were included in this trial. The median age of patients included was 65 years. Most patients had an ECOG performance status of 0 and had a 3+ score of HER2, a T3 tumors with positive nodal status, and the positive CPS score. Among the 31 patients that were included in this trial, 10 patients discontinued treatment because of toxicity in 2 cases, death in 3 cases, patient wish in 4 cases, and post-surgery complication in 1 patient. So in total, 21 patients completed the total perioperative treatment. So feasibility rate at 67.7% with a predefined feasibility threshold of 66.6%. So this trial met its secondary endpoint. So perioperative FLOT plus pembrolizumab plus trastuzumab was considered as feasible. What about safety? We had more than 10% of patients who experienced more than grade 3 adverse events, especially that was diarrhea. We had an increase in reoperation rate in this trial to 26.7% versus 10% described with standard FLOT, but there was no increase in time in hospital, and there was no increase in 30-day post-operative mortality. Pathologic response, so all patients who considered to surgery underwent an R0 resection. So we had a pathologic complete response rate at 48.4%, a pathologic subtotal response of 19.4%, a pathologic partial response of 9.7%, and a pathologic minor response of 19.4%, and 1 patient had no pathologic response. The pathologic response was seen across subgroups in patients with negative PD-L1 score or positive PD-L1 CPS score, and in patients who had HER2 2+ with a positive FISH and HER2 3+, but there was an increase in pathologic complete response rate with increased CPS PD-L1 score and with increased HER2 expression. So in summary, FLOT, pembrolizumab, and trastuzumab was considered as feasible in this study. There was increase in grade 3 diarrhea and higher reoperations rate. there was a 67.8% of major pathologic response and a high response in patients with CPS score more than 10 and in HER2 score 3+ on immunohistochemistry. Thank you for your attention, and I'm ready for your questions.
Good morning, everyone. Thank you for this opportunity to have this small talk on ESMO Together this year. Thank you, Dr. Hossein, for this opportunity. So I will be presenting new updates from ESMO Congress this year in gastric and gastroesophageal tumors. The first update is updated survival results in the Matterhorn trial, and to note this was the rated #1 abstract in GI tumors this year. In the phase 3 Matterhorn study, durvalumab with FLOT significantly improved event-free survival versus placebo in a patient with resectable gastric adenocarcinoma, with improvement in pathologic complete response and major pathologic response in the durva plus chemotherapy arm. And the interim analysis of overall survival indicated a trend toward improvement and overall survival with the combination arm. In addition, evidence suggests that pathologic response and nodal downstaging are associated with improved survival in people with gastric cancer. And in this update, they reported the overall survival final analysis and the intention to treat population. And they reported also the association between pathological outcomes and the event-free survival in the Matterhorn study. As a refresher, the Matterhorn was a global phase 3 randomized double-blind placebo-controlled study where patients with gastric adenocarcinoma stage 2 to 4A were treated with the standard chemotherapy regimen, which is FLOT perioperatively, in addition to either placebo or durvalumab continued up to 1 year after the surgery. In the final analysis of overall survival, we see that durvalumab arm demonstrated a statistically significant and clinically meaningful improvement in overall survival versus the placebo arm, with median overall survival not reached in both arms. It has a ratio of 0.78 and a significant p-value. The rate of overall survival at 36 months was 68.6% in the durvalumab arm versus 61.9% in the controlled arm. And the curves separated clearly in this slide, and the separation started approximately 30 months after enrollment. The benefit of overall survival was observed with immunotherapy in most key subgroups in this analysis. This benefit was also seen independently of the expression of PDL1. So PDL1 more or less than 1%. The benefit of durvalumab was clearly seen regarding placebo arm. For the pathological response, we see that in this study, we had 16.5% of pathologic complete response, 25.8% of major pathological response, and any pathological response in 87% of the patients. And at any degree of pathological response, the event-free survival was better in the durvalumab plus FLOT arm. For nodal staging also, we see that we had more patients in the durvalumab plus FLOT arm that have negative nodal staging post-operatively with more down staging in the nodal status. And the benefit of durvalumab was seen in both cases, either with N1 or N+ nodal status after surgery. So in conclusion, durvalumab with FLOT demonstrated a statistically significant and clinically meaningful improvement in overall survival versus FLOT alone in the intention to treat population. This benefit was seen regardless of the expression of PDL1, and any degree of pathological response was associated with improvement in event-free survival for durvalumab plus FLOT arm. The event-free survival was also improved regardless of the pathological nodal status. So this study strongly support the new standard of care, which is the combination of durvalumab with the standard chemotherapy regimen with FLOT for patients with resectable gastric and gastroesophageal junction adenocarcinoma. The second update I will like to present is the Fortitude 101 phase 3 study. This is a study talking about targeting FGFR2b and asking the question, is there a new target in gastric adenocarcinoma? We know that FGFR2b is overexpressed in advanced gastric cancers that can reach 20 to 30% of the cases, but until now, this is not a targetable mutation in these cases. Bemarituzumab is an ADC that targets FGFR2b that blocks factor signaling, growth factor signaling, and has an ADCC activity that induces tumor cell death. In FIGHT phase 2 study talking about this drug, bemarituzumab was added to FOLFOX and showed a promising survival signal in FGFR2b overexpressing HER2-negative advanced gastric cancer. And here they reported the results of the pivotal phase 3 Fortitude 101 trial. This study was a global phase 3 randomized double-blind trial also, including patients with unresectable metastatic gastric or gastroesophageal adenocarcinoma, newly diagnosed, no previously treated, with an overexpression of FGFR2b. And later in the amendment of the trial, they included only patients with more than 10% of expression of FGFR2b defined with 2+ or 3+ status on staining. And essentially, this was a study for HER2 negative gastric cancer. And the patient was randomized to receive either placebo with FOLFOX or bemarituzumab with the FOLFOX. The first thing is the overall survival in the primary analysis was positive for this trial with targeting FGFR2b. Better median overall survival reached with bemarituzumab versus placebo with a median of 17.9 months versus 12.5 months, a hazard ratio of 0.61 and the p-value that was significant. So this study met its primary objective, which was the overall survival benefit. And also this benefit was consistent across all subgroups in this trial. The PFS was also positive with median PFS of 8.6 months versus 6.7 months, a hazard ratio of 0.71, a significant p-value also. But in this study, there was no difference in objective response rate, which was approximately 45% in both arms. So bemarituzumab added to FOLFOX significantly improved PFS, but not overall response rate. Nevertheless, in the study with a more follow-up analysis, the overall survival benefit was still there, but with time, the benefit was less important than in the primary analysis. So the benefit was the magnitude of benefit was a little bit lesser, with 14.5 months versus 13.2 months, a hazard ratio of 0.82. So this is a question to answer later for explanation for this result. But in conclusion, Fortitude 101 met its primary endpoint of overall survival and key secondary endpoint of progression-free survival in patients with advanced or metastatic gastric cancer with overexpression of FGFR2b on more than 10% of tumor cells. The observed overall survival, as we said, the benefit was attenuated at subsequent descriptive follow-up analysis, and this is to be clarified later. The safety profile, we had no time to discuss safety profile of bemarituzumab, but like all targeted therapies against FGFR2b or FGFR2 in general, the main toxicity concern was about visual and ocular toxicities, but all were reversible. And the results from this trial and the upcoming Fortitude 102, which studied the combination of this drug with nivolumab, with immunotherapy in this setting, will further characterize the benefit-risk profile of bemarituzumab in gastric cancer. So in conclusion, the Matterhorn study strongly support the perioperative durvalumab combination with FLOT as standard of care for localized gastric cancer, and the FGFR2b appear to be a potential new molecular target in advanced gastric cancer to be more clarified for later. Thank you for your attention.
Hello, everyone. Thank you, Professor Ghosn, for inviting me to be part of ESMO Together 2025. So I will be highlighting 3 very interesting abstracts presented in the ESMO 2025. The Checkmate 8HW, the Dynamic 3, and Matterhorn trials. So let's start with the Checkmate 8HW. This updated the presentation of this trial was evaluating nivolumab plus ipilimumab versus nivolumab monotherapy for MSI-high metastatic colorectal cancer. So as we know, in patients with MSI-high, the phase 3 Checkmate demonstrate that nivo plus ipi has PFS higher than chemotherapy in the first-line setting. 3 years rate 69 versus 11. And these results led to the approval of nivo plus ipi as first-line treatment in patients with MSI-high. So here we are reporting in this abstract for the first time results from the PLEPRANT PFS final analysis for nivo plus ipi versus nivo. So as you can see, we are focusing in the Checkmate 8HW, where patients immunotherapy naive, MSI high, metastatic disease received either nivolumab or nivo plus ipi, knowing that ipi is 1 milligram per kilo every 3 weeks for 4 doses. The primary endpoint was progression-free survival. So you can see that we have a well-balanced population regarding the ECOG, the site of metastasis, the mutations, the history of Lynch, and you can see clearly that we have an advantage in progression-free survival for first-line nivo plus ipi versus nivo in centrally confirmed patients. The median PFS was not reached in nivo plus ipi versus 60 months for nivo alone. And you can see clear separation of curves. And also at 4 years, we have 55% of patients with nivo didn't presented progression versus 65 with this combination. Also, you can see that in all subgroups, we have an advantage in favor of the combination versus nivo monotherapy. What is interesting that also that the overall response rate was 73% for nivo ipi versus 61% with nivolumab. Regarding the toxicity, we had higher toxicity profile with nivo ipi. However, we know that with ipi 1 milligram per kilo every 3 weeks, the quantity of toxicity, the burden of toxicity is lower than the ipi 3 milligram per kilo. That's why this combination is not so toxic. So regarding the overall survival, also we have a trend for overall survival. 78% were alive at 4 years with the combination versus 65%. The median of both arms were not reached with a hazard ratio of 0.61. Also, the updated PFS showed a consistent advantage for nivo plus ipi versus nivolumab. So, as a summary, these new results further support that the combination nivo-ipi, either versus chemotherapy or nivolumab, is showing interesting result, and it's considered a standard of care option for first-line treatment of MSI-high dMMR metastatic colorectal cancer. What about the second abstract, the dynamic 3, ctDNA-guided adjuvant chemotherapy de-escalation in stage 3 colon cancer? We know that 3 to 6 months of oxaliplatin-based adjuvant chemotherapy is the standard of care for patients with stage 3 colorectal cancer. However, we have potential for substantial toxicity and certain benefit for any additional patient. Post-surgery circulating DNA status is a strong prognostic marker, could inform risk-adjusted treatment selection. So Dynamic 3 explores ctDNA-informed management of stage 3 colon cancer. In this part, we will be presenting post-operative ctDNA negative population with treatment de-escalation versus standard of care. So you can see clearly we have the standard arm, the randomization was to the standard arm versus patients based on ctDNA negative were de-escalated, the positive were escalated. So we are focusing today with the de-escalation. For example, 6 months of FP, the de-escalation was no chemo or 3 months. 3 months oxali plus FP, 3 to 6 months FP, 6 months oxali and FP, 3 months oxali and FP. The primary endpoint was 3-year recurrence-free survival. So also you can see that we have well-balanced population between those who received the standard of care versus the DNA-informed de-escalation. You can see clearly that in the treatment delivery, patients with standard treatment, only around 10% received 3-month single-agent FP or 6-month single-agent FP versus around 60% in the de-escalation arm. You can see the huge difference. Also, you can see that those who received the oxaliplatin doublet, 88% in the standard management versus 34%. So you can see the number of patients in which we skipped the intensive chemotherapy. And also we have completed the planned treatment around 89% in those who had a de-escalation based on ctDNA versus 82% in the standard management. So it's interesting to see that the toxicity level was decreased in patients who had the escalation, and this is the normal versus the standard management. What about the recurrence-free survival? The recurrence-free survival at 3 years was quite similar with an absolute difference of minus 2.8% for ctDNA-guided population. However, it was considered statistically identical. And patients who benefit more from ctDNA guidance are those who are less than 70 years old and with low clinical risk. So if we want to compare between low and high clinical risk, in the low clinical risk, the ctDNA guided did around 2% less performance compared to the standard, while we had a huge difference of 6% in clinical high-risk population. However, in all comers, it was pretty similar. So the conclusion for patients with ctDNA negative stage 3 colon cancer post-surgery, recurrence risk is low, around 87%. The ctDNA-informed treatment de-escalation was feasible with high adherence, and this was interesting. Markedly reduced oxaliplatin exposure from 88 to 34 with the subsequent neurotoxicity, better safety profile, non-inferiority versus standard of care was not confirmed, tough outcomes were closed, particularly in low-risk disease population. So it was not confirmed that we don't have an inferiority. So could inform risk-benefit discussion for individuals, patients. So ctDNA-informed de-escalation strategy warrant further investigation. So this was a very interesting proof of concept. What about the METEOR trial? So we are presenting event-free survival and patient-reported outcomes in MATEORN trial. The MATEORN trial, the float was considered for a long time the standard of care in a perioperative setting for early gastric and GEG adenocarcinoma. However, with the MATEORN and the first interesting result, the combination of durvalumab plus FLOT was considered one of the standard of care. So updated results from this study, the primary endpoint was the event-free survival. You can see clearly we have well-balanced population between the two arms. And the primary endpoint, the event-free survival at 2 years, 67% versus 59%. The event-free survival, the median was not reached with Durva plus FLOT versus 32.8 months with placebo and FLOT, with the p-value of less than 0.001. So also the secondary endpoint, the overall survival, we have a trend for advantage in overall survival. You see the very interesting separation of curves. 76% were alive at 2 years while receiving the durvalumab plus FLOT versus 70% with placebo and FLOT. Regarding the quality of life, it's very interesting to see that we didn't find any huge difference when adding the durvalumab to the FLOT. Also, the toxicity profile, we know when adding the durvalumab, we have more immune-related toxicity. However, the chemo-related toxicity was similar between the two arms. So as a conclusion, MATEORN supports the positive benefit-risk profile of perioperative durvalumab with FLOT and its global adoption as a new standard for patients with localized gastric or GEJ adenocarcinoma. Thank you very much. Thank you again, Professor Ghosn, for this invitation. And thank you, and ready for any questions. Thank you very much.
For inviting me to address this this topic on sarcomas in ESMO. So I'm going to present 3 abstracts for today. The first abstract is on the extended efficacy and safety from the phase 3 maneuver trial of pimicotinib in patients with tenosynovial giant cell tumor, or TGCT. TGCT is a very rare tumor that does not have a risk of metastatic disease, but has a very high risk of local destruction of articulations. So as we can see here, the cells of the TGCT will secrete CSF1 overexpression, which will stimulate the accumulation of macrophages and increase the tissue microenvironment as well as the tumor cells. And we have many approved small molecular inhibitors such as pexidartinib, vimseltinib, and now we have a new molecule, small molecule called pimicotinib, that will inhibit the receptor of CSF1 and reduce this accumulation of cells. In this phase 3 trial, we have included patients that were unresectable with at least 1 lesion of more than 2 centimeters. A total of 94 patients were randomized to receive pimicotinib 50 milligrams once daily versus placebo. Here we have the overall response rates. We have at least 76% of overall response rates with 6% of complete responses and 69% of partial response, with an overall disease control rate of at least 95% with pimicotinib. Here we can compare the primary analysis, and we can see that the waterfall plot has much improved in comparison with longer-term follow-up. We have at least 10 patients that have been with disease control, with stable disease that have passed to partial response, and we have, for example, 4 complete responses at longer-term follow-up, which means that with prolonged duration of treatment, we can have a deeper response with time in this rare tumor. Here we can see that we have also clinically meaningful improvements, all the clinical outcomes, including the relative range of motion, stiffness, and we have much better control of pain in these patients that have their disease, advanced disease in their articulations. As well, for safety, pimicotinib was very well tolerated and longer-term follow-up. There was no new safety signals, and the rate of dose reduction was only 25% in patient, and discontinuations were 6% only due to side effects. Grade 3 or grade 4 toxicity were rare. We have only a limited increase in CPK levels as well as increase in lipase levels, which is not life-threatening for these patients. So in conclusion, in this very rare, ultra-rare tumor, the TGCT patients with very high risk of local destructions, we can see that we have with this type of treatment 76% overall response rates, which will have a very high impact on functional outcomes in these patients. So pimicotinib may offer an effective, convenient, and tolerable systemic treatment option for patients with TGCT, providing early and durable tumor response with sustained relief from pain and functional impairments. Now for the second abstract, also a very rare tumor. So this is a phase 2 association and combination of sunitinib, a tyrosine kinase inhibitor, plus nivolumab, a PD-1 inhibitor, in advanced alveolar soft part sarcoma. And this is a particular specific cohort within the IMMUNOSARC-2 study that included many types of sarcomas. So alveolar soft part sarcomas is an ultra-rare sarcoma subtype that is resistant to classical cytotoxic chemotherapy with a median progression-free survival of 7 months. So sensitivity to both tyrosine kinase inhibitors with anti-angiogenic activity and immune checkpoint inhibitors have been described in this histologic subtype, and this is one of the rare sarcoma that have FDA approval for one immune checkpoint inhibitor. So the first part with IMMUNOSARC that was assessed in many types of sarcomas has showed that the association of sunitinib and nivolumab may be active in these patients. So there was a specific cohort for alveolar soft tissue sarcomas in a phase 2 trial within the IMMUNOSARC-2. This is the study design of the trial. First, we have an induction phase with sunitinib. Adults will receive 37.5 milligram daily for 14 days, followed by a maintenance phase with the addition of nivolumab at the dose of 240 milligram. And this treatment will be continued until progression or intolerance. So the primary endpoint of this trial was 12 months PFS rate, and there was a statistical assumption that we had at least 11 out of 18 patients that will be free of disease at this time. 18 patients were included. We have almost 2/3 of the patients that were in the first line treatment and a KEGOG baseline of 0 to 1. Here we have the toxicity. There was no major toxicities in these patients. We had only one grade 4 toxicity that was thrombocytopenia, and the overall toxicity was grade 1 and grade 2 known toxicities related to tyrosine kinase inhibitors such as diarrhea, fatigue, or mucositis. Here we have the 12-month PFSR that was at 53%. We have 9 of 17 patients that were free of progression, which is lower than the level that was predefined in the primary endpoint. But we have a median PFS of 13.1 months, while the overall survival reached 57.9 months in this very aggressive tumor, especially in the advanced and metastatic disease. Here we have the univariate analysis. For PFS, we can see that patients that were at the first line of treatment had better outcomes with very much prolonged PFS. Also, those patients that were exposed to prolonged metastatic free interval also benefited more from this combination. And of course, patients that had complete response or partial response had better PFS than those who had at least stable disease. Here we have the overall response rates. The overall response rate reached 53% among these patients, and we have a clinical control rate of 88% and only 12% of patients that had disease progression. So most of the patients had benefited from this association of TKIs and immune checkpoint inhibitors. Here we can see the difference in the prognostic impact of the virologic response. As we have said, those patients who have at least a partial response will have a better progression-free survival in comparison to those who had stable disease or progressive disease, that in whom the response only lasted for 7.5 months. This is a comparative table where we can see that the overall response rate is among the highest with the combination of TKIs and immunocheckpoint inhibitors, as well in comparison to the study that was published in the Lancet Oncology in 2019. We have almost 54% of overall response rate and a prolonged median PFS. So in conclusion, this is a single-arm study, and we can see that the added value of combination with TKI and PD-1 remains to be determined, but the combo seems to provide a greater chance of obtaining an objective response, with almost half of the patients will have a response, which we can add in patients who have locally advanced disease. And the last abstract in the sarcoma part, we have the efficacy and safety of metronomic cyclophosphamide versus doxorubicin as first-line treatment in older patients with advanced soft tissue sarcomas, which is a very frail population, and we have very few studies that have assessed the type of treatment in these older patients beyond 70 years of age with metastatic sarcoma. Standard first-line doxorubicin as monotherapy is not always feasible in these patients who have a lot of comorbidities. So in this trial, they have hypothesized that patients that can benefit from metronomic cyclophosphamide, which can be an oral treatment and very well tolerated in comparison to doxorubicin. So the rationale for metronomic cyclophosphamide was this treatment had antineoplastic activity, immune modulation mediated by the inhibitory effect on Tregs, and anti-angiogenic mechanisms. Patients that had more than 70 years of age were included in this trial, were randomized to receive doxorubicin 60 milligram per square meter every 3 weeks, up to maximum of 6 cycles, in comparison to cyclophosphamide 50 milligram orally per day. The patients were stratified based on the G8 score and histotype, leiomyosarcoma, and other type of tumors. The primary endpoint was time to treatment failure, and here we can see the patient's characteristics. We had 21 patients that were included in the metronomic cyclophosphamide versus doxorubicin, in which 18 patients were included. Most of the patients were leiomyosarcomas, liposarcomas, and undifferentiated pleomorphic sarcomas. We can see that the median cycles of treatment were 3 for the metronomic cyclophosphamide versus 4.5 for the doxorubicin, but we can see that half of the patients only received 3 cycles with doxorubicin, which can translate to the toxicity of doxorubicin in this frail population. Here we have the time to treatment failure. There was no difference between the metronomic cyclophosphamide and doxorubicin. We have 10.14 weeks for cyclophosphamide versus not reached in doxorubicin, but we have a p-value of 0.26. The median PFS was not significantly different between both the groups, and also the overall survival, we had 20.90 months in the cyclophosphamide versus 19.12 months in the doxorubicin, which was not significant, but this can give us an idea that in these patients, doxorubicin might not be very superior to metronomic cyclophosphamide. As well, for response rate, we had a little bit higher response rate in the doxorubicin with 4 partial responses. In the cyclophosphamide, had only 1 complete response, and this was in patients mostly with leiomyosarcomas. Adverse events, these are well known to the toxicities for doxorubicin, that had 88% of toxicities versus 66% in the cyclophosphamide. So this is a treatment that is an oral treatment that is much well tolerated in compared to doxorubicin. In conclusion, despite multicenter collaboration, the study was closed for crude futility. Valued prospective evidence of chemotherapy activity and toxicity in older patients with STS. We have a small sample size that could preclude robust statistical comparison. Observed time to treatment failure, PFS, and overall survival, as well toxicity, do not show significant differences between doxorubicin and cyclophosphamide, and we have higher than expected overall survival compared to retrospective available data. Thank you very much for watching us.
Hello, everybody. I'm Dr. Céline Boutros. I'm a medical oncologist at Gustave Roussy, France, and I work in the dermatology unit, mainly on cutaneous cancers. And today we'll talk about the updates in melanoma treatment that were presented this year at the ESMO. So I have no conflict of interest, and we will principally talk about 2 trials in the neoadjuvant settings of melanoma and 1 trial in the metastatic setting of melanoma treatment. So let's start in the neoadjuvant treatment of melanoma with the first trial that will be presented. It's the SWOG trial. So this is a phase 2 trial, and the primary results of this phase 2 trial SWOG were reported at last year's ESMO. They showed that in the stage 3B through stage 4 melanoma, who started immunotherapy before surgery, patients had significantly longer event-free survival times than patients who started immunotherapy after their surgery. The rate of recurrence-free survival at 24 months appeared to segregate by pathologic response and was at 89% for patients whose tumor achieved the pathologic complete response. Longer follow-up from the SWOG trial supports neoadjuvant over adjuvant immune checkpoint inhibition in patients with resecable stage 3 or 4 melanoma. In the new analysis presented this year, 3-year event-free survival rates were 68% in the neoadjuvant arm and 56% in the adjuvant arm. The overall survival data appeared to be favorable. However, we need mature data to talk more about this. Recurrence-free survival and overall survival were better in the neoadjuvant arm with a pathologic complete response or pathologic near complete response than with a pathologic partial response or non-response. So we can summarize by saying that updated analysis confirmed the sustained benefits of neoadjuvant immunotherapy with resecable stage 3 or 4 melanoma at 3 years of follow-up. The 3-year event-free survival rates were 68% in the neoadjuvant arm and 56% in the adjuvant arm with a minimum follow-up of 3 years. As for the overall survival data, it appears to be favorable, but mature data are needed. Recurrence-free survival and overall survival were better in neoadjuvant arm with a pathologic complete response or pathologic near complete response than with partial response or non-response. And there were no new safety signals, and rates of treatment-related grade 3 or 4 adverse events and adverse events leading to discontinuation were similar for the 2 arms. So let's talk now about another neoadjuvant trial in melanoma. It's the NADINA trial. This is a phase 3 trial that enrolled patients with stage 3 resecable melanoma. Patients were randomly assigned to one of 2 arms. In the experimental arm, patients received 2 courses of ipilimumab plus nivolumab, and this was followed by therapeutic lymph node dissection. Patients with major pathologic response entered follow-up. Those without major pathologic response received adjuvant nivolumab if they were BRAF wild type or dabrafenib and trametinib if BRAF mutated. Patients in the control arm received lymph node dissection followed by adjuvant nivolumab for 1 year. NADINA trial has previously shown last year that neoadjuvant ipilimumab plus nivolumab followed by surgery and response-driven adjuvant therapy increased 12 months event-free survival rates compared to surgery followed by adjuvant nivolumab, and the primary endpoint was event-free survival. This year at the ESMO, updated findings showed 22% higher estimated 2-year event-free survival rates of 77.3% in the neoadjuvant arm versus 55.7% in the adjuvant arm. The updated 2-year distant metastasis-free rates were 82.8% with neoadjuvant therapy versus 63.9% with adjuvant therapy. Additional data were presented with respect to recurrence-free survival and distant metastasis-free survival according to pathologic response in the neoadjuvant arm. The 24-month recurrence-free survival rates were significantly higher in patients with pathologic complete response and near pathologic complete response. Similarly, the 24-month distant metastasis-free survival rates were significantly higher in patients with pathologic complete response and pathologic near complete response. Baseline interferon gamma signature, PD-L1 expression, and tumor mutational burden were associated with superior event-free survival in the neoadjuvant arm. The updated safety data showed that 97.6% of patients in the neoadjuvant and in the adjuvant arms experienced an adverse event. The incidence of grade 3 or more was higher in the neoadjuvant arm. So, neoadjuvant nivolumab and ipilimumab showed superior event-free survival and distant metastasis-free survival compared to adjuvant nivolumab in resecable stage 3 melanoma. Patients with pathologic complete response had the most favorable event-free survival and distant metastasis-free survival. All grade adverse events and grade 3 adverse events were higher in the neoadjuvant settings, and baseline biomarkers, including interferon gamma signature, tumor mutational burden, and PD-L1 expression, were predictive of response in the neoadjuvant settings. And we'll finish with an update in the metastatic treatment of melanoma by presenting the primary result from the randomized phase 3 trial of the IO-102-IO-103 cancer vaccine plus pembrolizumab in untreated advanced melanoma. So, the primary result of the phase 3 trial combining IO to pembrolizumab in untreated advanced melanoma were presented this year. IO is an off-the-shelf immune modulatory cancer vaccine designed to target both tumor cells and immune suppressive cells within the tumor microenvironment. The vaccine stimulates activation and expansion of T cells against IDO1 positive and PD-L1 positive cells, enhancing anti-tumor immune activity. After a median follow-up of 2 years, the median progression-free survival in the experimental arm was 19.4 months versus 11 months for pembrolizumab alone. The primary endpoint of progression-free survival narrowly missed statistical significance threshold of the p-value. However, among the patients with PD-L1 negative disease, the median progression-free survival was 16.6 months with the combination versus 3 months with pembrolizumab alone. So we can say that the combination of IO plus pembrolizumab didn't lead to significantly improved progression-free survival in metastatic melanoma. However, interesting insights come from a pre-specified analysis of the IO trial, where IO appeared to offer particular benefits to patients with PD-L1 negative tumor with a median progression-free survival of 16.6 months in the vaccine arm, compared with only 3 months with pembrolizumab alone. And the treatment was well tolerated. Thank you.
Good afternoon. First of all, I would like to thank and congratulate Professor Ghassan for this initiative. It gave me the opportunity to try to select what I have learned from this long and uncomfortable meeting of ESMO 2025. The title of my presentation is really what I have feel, innovation or inflation, and the subtitle of From Pathology to Molecular Biology. The first question we can ask when you go to a meeting, is there practice-changing data in this meeting? And I can say maybe, because I'm not sure that what has been presented give us the opportunity to change directly our way of treating patients. But I selected here the 3 presentations. The first of all, the keynote B96 with Pembro plus chemo plus Bev in platinum-resistant ovarian cancer. This is, in my opinion, the best way, because the benefit here of PFS was 30% across all subgroups, and the benefit of overall survival in PD-L1 positive patient. The importance of this trial, it is the first randomized regimen to show survival benefit with IO in ovarian cancer. This is maybe a new way of standard signal in this setting. This is why I selected this presentation. The second presentation are mainly Destiny B05 and B11. The B05 is designated here to the population after neoadjuvant chemotherapy who failed to have PCR and was randomized 1-to-1 to receive either TDX in HER2 or TDM1 Kadcyla. And here you can see that in this setting, the benefit of Enhertu is high with a hazard ratio of 0.47, 53% of response, better response if you give Enhertu instead of Kadcyla. The second one, Destiny B11, here is designed for population HER2 positive capped with tumor inflammatory breast cancer is neoadjuvant setting. Here again, when you give in HER2, you get better response. It's PCR comparing to TDHP. So when you add TDX to THP, you have a better response rate, 67% versus 56%. Really is very important. So in this setting, we can see that in HER2 now, in our practice, daily practice, is devoted to nearly 85% of cancer patient, breast cancer patient, with, of course, HER2 positive patients, also HER2 low and HER2 enriched. That's why I'm giving this slides, what to choose, because what will be the best scenario for this excellent drug? This is a neoadjuvant, after neoadjuvant therapy in metastatic disease. Where is the position here? And that's why I said maybe there is practice changing, but we don't know yet what is the better position for this drug. That's why I put this slide, important to see what is our strategy for the future. The second one, question one, when I go to a meeting, I would like to see if there is a new concept approach. Is there something we can learn from this approach? And here I selected the presentation of Atezo tribe. The Atezo tribe here, it's an integration of AI in before chemotherapy. And you can see that I have presented years ago with Kairis, a study where you know the Turnigan study, when you give Folfox or Folfiri, you have the same response. But when you add an experience of AI to the molecular biology, you can see that the choice will be or Folfox or Folfiri with 1 year of benefit. And here again, when you go integration of AI in Atezo for colorectal cancer, you can see a better response with a hazard ratio of 4.65. So with the AI biomarker high group patient, arm Atezo for Foxiri, BEV showed improved PFS and OS. This is the way to select patient maybe and to have a better response. Hazard ratio 0.65 for PFS and 0.7 for survival. This is maybe a new way of thinking when you integrate AI and with a good manner to have a better selection for the treatment of the patient. The Invigor here, another one with CTDA, a new concept, CTA guided adjuvant Atezo versus placebo after cystectomy. This is also a good way of thinking to ctDNA. We know that ctDNA become something very important in colorectal, and now in bladder, and maybe in future for breast, everything. This is a very good approach and a new way of thinking the ctDNA guided adjuvant Atezo or any ctDNA and guided adjuvant therapy. The first-in-class bispecific here again, a new concept, the first-in-class bispecific antibody targeting PD-1 and VEGF. This is interesting because with the Harmony 6, squamous non-small cell lung cancer, ivonescimab plus chemotherapy, this is a new approach where you have a combination, a new concept of ADC plus, this is the way of, with again here, we can meet the PFS of 11 months, compared to 6 months with chemo alone, when you give the combination of ivonescimab with the chemo versus chemotherapy alone. So the last part, because I have only 7 to 10 minutes, why I talk about inflation? The inflation, because look at what ADCs everywhere. With name, we cannot memorize. How can you memorize all the names of, look at here, I put maybe 4 or 5. We have, in the meeting, we have maybe, if I select, maybe have 30, 40 names. This is something very unusual in a meeting, one meeting, to have a lot of names nobody knows, a lot of without any substance for that. So And my last call will be expensive new treatment are not always the answer. This is not the way we have to move in medicine. We have to move for new concepts and new strategies, and not to have more and more expensive treatment for the patients. For example, here one example to say, docetaxel, it's maybe better if remains the key for patients with metastatic prostate cancer. We think was better, but you compare to lutetium, this is one example of cost is not always the better. So in conclusion, I would like to say that the role of AI is expanding in oncology. AI models still wait for prospective studies confirming utility and approval, but this is the way we can move on. ctDNA could guide treatment in adjuvant urothelial and other cancers. Pembro can be added to chemo BEV in platinum-resistant ovarian cancer. Ivonescimab, the first bispecific PD-1 VEGF, outperformed chemo plus PD-1 in untreated metastatic squamous cell non-small cell lung cancer. Many ADCs to keep an eye on for the future approval and use, but it's still early yet to say this is the new way this is the new treatment. In her to show positive result in neoadjuvant and PCR positive patient. Historical treatments are still standard, such as docetaxel in metastatic colorectal prostate cancer. This is where we have to think, and thank you very much for it.
Good evening. Yes, we are in late afternoon. I know that you have had a very long day, and I would like to personally thank all the presenters and the member of the faculty who had made the effort for themselves and for us in order to give us this very nice overview of what happened in ESMO. You will have just heard Professor George Shaheen with his take-home messages about what was the best in ESMO. For my personal take-home messages, I would say that this year's ESMO, we had some clear new messages for the use of circulating tumor DNA. And we have seen a lot of presentations, I will not go through them, where our treatment have been tailored with this new technology, which is circulating tumor DNA. And we know that this has been used and was useful and has been we were able to do it with the support of AI. And also we have seen a lot of presentations where we have where the ADCs are coming from second line to first line in multiple situations. And this is good because nowadays we have new options for our treatment. We have them in breast cancer. We have them in bladder cancer, for example. I will not go through all the details you have seen. And also we have seen during this ESMO new incorporation and new indications of the vast majority of immunotherapy in a variety of situations. And also we have seen new drugs and new immunotherapy coming from multiple parts of the world. And also we begin to see new compounds which we were not seeing before. There are a substantial number of new compounds and new drugs which are coming. Saying that, I would like to end with a very, very positive feeling. This ESMO was a very fruitful and very successful ESMO. I think that it was the best ESMO ever, 37,000 of participants. I have been there. I have seen again a lot of my colleagues, and I have seen again a lot of my friends I have seen the friendship which is very strong in this oncology community, including all the multidisciplinary participants in this community. And also we have seen a lot of advocate people, very interesting people, pharmaceutical, everybody was very enthusiastic. And it was a very successful ESMO. And with that, I would thank you for being with us this long day and hope to see you soon, and goodbye.